عندهم ريسبونس.
الفاكسين ممكن تقلل
انفلونزا بس والكوفيد.
شوف يعني شيء بس
هذا احنا سبلت في العالم.
بس والله فوكس توك انفكشن زي كارتي بس
ولا المفروض بس
حتى لو في
'Bismillahir-Rahmanir-Rahim. Good morning. Thank you very much for coming for the first session of second day of international meeting of Ssbmt. So I have the pleasure of introducing our first speaker, Professor Lydia Jill, is the head of Department of Hematology and Bone Marrow Transplantation of the Poznan University of Medical Sciences in Poland. She's a hematologist and a transplant physician. She deals with the everyday practice with the cellular therapy and the treatment of neoplastic blood diseases, hematopoietic stem cell transplantation, and CAR T-cell therapy. The center she runs was the first in Poland to be accredited to conduct CAR T-cell therapy in adult patients and is currently the largest such center in the country. Her special interests include the safety of cell therapies, especially infectious complications. She is the author of numerous publications on this topic. She has been a provincial consultant in the field of hematology in the Greater Poland since 2018. She serves as the chair of the infectious section of the Polish Adult Leukemia Group. She has won numerous awards she has received in her professional life, and she values to be the Mentor of the Year award was one of the most important awards she receives. And she's going to talk to us about infections in patients who have CAR T-cell therapy. So, can you hear me, Dr. Lydia Jill?
Yes, I do. Thank you very much for this kind
please.
introduction. Thank you very much for invitation. I'm very sorry that I cannot be with you inside, but I would like to present you my presentation. I hope it is seen now. Could you confirm if it is seen? I would like to give you the talk about infection in CAR T-cell patients. These are my disclosures. Of course, generally, currently, CAR T-cell therapy, this is standard of treatment of many lymphoid malignancies. However, it is all the time exciting treatment because of very modern technique which is behind this therapy. We know much more about the safety and how to influence survival. However, we do learning all the time. This method is being studied intensively also in patients with solid tumors and non-neoplastic diseases. And from my opinion, the successful therapy can be is related to treatment of patients regardless of age. However, there are some limitation of this method, just like demanding logistic and first of all late complication. Of course, currently in US we have 7 products, but most of CAR-T patients are patients with lymphomas all over the world. This is the main indication for the treatment, and that's why also data concerning infection are based first of all on patients treated because of different forms of lymphoma. What about CAR T-cell complication? We can generally divide them into 2 main groups or 3 main groups: short-term and long-term. Some subgroups also distinguish medium-term complication. In this group of short-term complication, we can first of all talk about cytokine release syndrome, neurological complication which are called ICANS, and currently very important hematotoxicity which is called ICAT, and infection, of course, other complication also. In later phase of the treatment, after 30 days, usually 28 to 30 days, we can observe also a similar complication, but the most common are infections and ICAT, and that's why I would like to focus first of all on those phenomena. However, from very first beginning, we discussed all over the world, first of all, about CRS, cytokine release syndrome, and neurological complication, because such complications are the most common today with treatment according to recommendation, international recommendation, and first of all with early treatment. We know that we can manage most of such complication, and just like CRS and ICANS, and it was confirmed during last ASH meeting, when it was shown that CRS higher grades and also ICANS higher grades in the perspective on time occurred less frequent than at the very beginning. However, it doesn't concern also prolonged cytopenia and infection. We observe the same rates of such complication, just like, for instance, in 2017. What is very important that if we look at non-relapse mortality after CAR T-cell therapy in patients treated because of lymphoma, we can realize that this non-relapse mortality is about 5% in a perspective of 1 year. But based on analysis presented by French group, we can find that the most common reason for mortality, this is during early period, this is CRS and infection. And after 30 days, this is first of all infection. Of course, this analysis was performed during first and second wave of COVID infection. However, not only COVID infection were related to higher mortality. What we know about risk factors of infection after CAR T-cell therapy? Currently, we know that this is not only number of lines before CAR T-cell therapy, and this is not only underlying malignancies. This is very important history of previous transplantation, history of previous infection, performance status at baseline of patient, baseline hypoglobulinemia, and also older age. But also there are some CAR T-cell related factors, just like dose of CAR T-cell, that the presence of CRS, presence of ICAT, corticosteroid use, and hypogammaglobulinemia also. Current meta-analysis indicates that rate of infection in adults reach about 34%, with severe forms of such infection in about 16-17%, with attributable mortality in about 2%. In patients who are treated with anti-CD19 CAR T-cell, this infection density is highest before the day plus 30 and is caused by bacterial infection. After the day plus 30, we observe, first of all, respiratory viral infection, but viral reactivation, for instance, in comparison to allogenic stem cell transplant setting, are observed not in a high rate. They are rather rare, however, may occur, and it concerns, of course, CMV or VZV. Fungal infections are generally rare and are observed in less than 6% of patients. In those patients who are treated with anti-BCMA CAR T-cell, infection rate is quite high because it reaches about 60%, but density of those infection is highest after the day plus 30, and those infections are caused, first of all, by respiratory viral infection. Viral reactivation as well as fungal infection are rare. Of course, during early period, almost all patients after lymphodepleting therapy are neutropenic, and during this time, early infection are caused, as I mentioned, by bacterial infection, and we observe, first of all, bloodstream infection. Risk factors for such early infection during neutropenia are, first of all, corticosteroids, but also infection just before CAR T-cell. What we know about etiology of more detailed information about etiology concerning CAR T-cell infection. Bacterial infection can be caused by any bacteria, but and of course it is center specific. But of course the most common seems to be infection caused by gram-positive bacteria. Viral infection, as I mentioned, first of all, respiratory viral infection, and not very common fungal. If we compare fungal infection in a setting of anti-CD19 and anti-BCMA, there are some differences. Anti-CD19 is offered to patients with lymphoma, but also acute lymphoblastic leukemia, and that's why in the setting of such patient, we can expect infection, fungal infection caused not only by yeast, but also by molds, and also infection caused by pneumocystis. This pneumocystis is seen as early phenomenon, and as well as yeast infection. In patients after treatment with anti-BCMA products, we observe, first of all, yeast infection, and about 1/3 of patients are presented with Aspergillus, for instance, or other mold infection. Risk factors for fungal infection, this is first of all allotransplant, previous fungal infection, and corticosteroids. Previous allotransplant, first of all, population of acute lymphoblastic leukemia. We were afraid, some years ago, we were afraid about COVID infection in patients after CAR T-cell therapy, and during first and second wave, unfortunately, about 40% of patients with such infection dying. Today, this outcome of patients during SARS-CoV-2 infection is much better, and we can achieve this survival rate in about 85 to 90% of patients, so it is real improvement. CMV infection, this is area of interest currently according to CAR T-cell therapy. Of course, this is one of the main infectious problem in patients in allo transplant setting. However, we do not know all data. We do not have all data about such complication in CAR T-cell patients, and it for sure requires a prospective analysis. However, there are some groups which present data about CMV reactivation observed in about 33% of patients, especially in those who are presented with CRS, who are treated with corticosteroids, who receive immunosuppressants, including anakinra. But clinically important CMV is observed in about 11% of patients, especially those who are treated with corticosteroids, tocilizumab, or receive 2 or more immunosuppressants, including anakinra. However, we know that reactivation of CMV in patients after CAR T-cell therapy influence survival, and unfortunately, those patients are presented with poorer outcome. As I mentioned, we have early and late infection. During this early phase, during first 30 days, we observe most of infection, and most of them are caused by bacteria, but also other etiological factors are important. What is the most important during first 30 days? It is to distinguish infection from CRS, because such complication is observed as a early complication. For this, we do not have currently generally approved algorithm, because a number of different cytokines can be observed during infection and sepsis, and also during CRS, cytokine release syndrome. Such analysis, such algorithm should be very easy and simple to perform. For now, we do know that there is a number of different cytokines that can help us to distinguish between those two entities. However, most of them require time to perform and to analyze. I show you on this slide one of such proposals based on interferon level and interleukin beta level. The second proposal was given by Chinese group when they use a very simple analysis based on 3 cytokines added to two main, in addition to 2 generally used, just like interleukin-6 and ferritin, and such 3 cytokines. This is interleukin-8, interleukin-1b, and interferon. With this, we can distinguish between infection and CRS. And the last one, which was published a few months ago in 2024, that we can use very simple parameters, just like fever, just like procalcitonin, just like interleukin-6 and CRP, to distinguish between infection and CRS. It is very important that CRS, and especially high grade of CRS, are related to higher risk of infection, and especially bacterial infection, and especially bloodstream infection. The authors of such analysis present also quite simple algorithm, which is based on the presence in blood of interleukin-6, CRP, PCR, and blood culture, and with this we can distinguish between CRS and infection. What about late infection? Late infection may occur at any time after CAR T-cell therapy, but generally are considered as quite mild infection, and only in some situations require hospitalization. Most of such patients are treated as ambulatory patients, and most of such complications are related to respiratory viruses. And those infections are related to 2 main factors: cytopenia and hypogammaglobulinemia. There are different analyses which show that cytopenia, first of all neutropenia, are observed in about 20 to 40% of patients after CAR T-cell therapy, and I'm talking about prolonged neutropenia after 30 days, of course. And if we look at hypogammaglobulinemia, this is also a phenomenon which is seen up to 60% in those who are treated because of lymphoma, and such situation is observed for 1 year or even longer. Patients, now we know that the age is very important in patients treated treated with CAR T-cell therapy, because of the risk of infection in population older than 75. And in this group of patients, we do observe, first of all, late infection. Unfortunately, such infections are quite important, because they may influence mortality of patients. So it is maybe not maybe it is not related to severity of such infection, but in this late period, older patients are usually treated by centers which are not very familiar with CAR T-cell therapy and complication with this treatment, and maybe that's why those patients can die. I mentioned also that very important factor related to the risk of late infection, this is neutropenia. Of course, almost all patients during early time after CAR T-cell infusion are presented with neutropenia, and this is effect of lymphodepletion and effect of CAR T-cells. But in some situation, we observed also prolonged neutropenia. And the most dangerous in the context of infection, this is aplastic phenotype of neutropenia, which is observed in some group of patients, not very common, in about less than 20%, 15 to 20%. However, it is a situation when the patient do not respond to growth factors, and neutropenia is responsible for infection. Now we can assess before treatment at the first day of lymphodepletion what kind of patients and who of our patients can develop neutropenia as prolonged complication. We can divide patients according to CAR hematotox score into two main groups, low risk and high risk patients. In high risk patients, the risk of prolonged neutropenia is high, and the risk of infection is also high. Such a score was approved and was validated in lymphoma patients, including diffuse large B-cell lymphoma, mantle cell lymphoma, but also multiple myeloma patients. It was not this score was not approved for ALL patients. However, we are trying to prepare such similar score to help us to predict the response according to neutropenia in this group of patients. Today, we do have a lot of different forms of prophylaxis and treatment of infection, and the most accepted suggestion are prepared by Ssbmt and IHA recommendation, and shortly I would like to present it to you, because for antibacterial prophylaxis currently there is no routine recommendation to use it as routinely and everyday procedure. But we have to consider this prophylaxis in patients who are older than 65, patients with comorbidities, and patients in poorer general condition. In patients who are after plus 30 days, it should be conditioned with those with prolonged neutropenia or recurrent neutropenia. For those who are presented with neutropenia, there is an algorithm how to deal with this, of course, but we need to start from growth factors. And of course, most of our patients require immunoglobulin replacement given as intravenous or subcutaneous. Prevention strategies, this is also strategy of prevention and treatment, early treatment of CRS with early use of tocilizumab or other cytokine drugs, just like anakinra, for instance. What about antifungal prophylaxis? This prophylaxis is not routinely recommended as well. However, it should be considered in patients who receive CAR T-cell therapy after allogeneic stem cell transplantation, or those with a history of invasive fungal disease. After the day plus 30, it should be considered first of all in patients with prolonged neutropenia, and especially those who are on steroids. And of course, for those with neutropenia, we need to start from GCSF and of course try to explain the reason for this neutropenia. And antiviral prophylaxis is generally routinely recommended, and we advise to use acyclovir or valacyclovir for 1 year after CAR T-cell therapy, or this duration of this prophylaxis can be also based on the number of CD4 lymphocytes. Vaccination is very important, and vaccination should be done for influenza and SARS-CoV-2. However, we know that response to vaccination is lower than in general population. We should start not earlier than 3 months after CAR T-cell therapy. For COVID-19 prevention, not only vaccination, but probably in the time of waves, we can use pre-exposure prophylaxis and early antiviral treatment. There is a number of different problems which should be solved in the future related to CAR T-cell therapy. From my opinion, one of the most important is to distinguish between infection and CAR T-cell toxicities, just like CRS, cytokine release syndrome, and of course to analyze very in details late complication infection and immunological complication which can occur in patients after the treatment. Thank you very much for your attention.
Thank you, Dr. Jill, for this comprehensive review of the infections in CAR T-cell therapy patients. So we have time for maybe a couple of questions because Dr. Jill has to leave. So please stay with us. Okay, so you have a question?
Thank you for this comprehensive talk. I have a question regarding stem cell collections. I mean, we have some patients who have received multiple lines of therapy and they come for the CAR T, and you know that the risk of developing cytopenia is high. In your center, are you considering collecting stem cells just in case for them to be used if the patient had prolonged cytopenia without recovery, so you can infuse the stem cells?
So, of course, there are some data confirming that such a procedure with use of autologous stem cells is very effective. And so it is easier for patients with multiple myeloma because most of such patients, they have collection of stem cell early in the period of the treatment because we are preparing for autologous transplant. And usually we have for 1 or 2 transplants enough material. So we can offer this group to patients with this diagnosis, the treatment with use of hematopoietic cells, autologous hematopoietic cells in the case of refractory cytopenia. It is a little bit more complicated in patients with lymphoma because currently we use this CAR T-cell treatment as second-line treatment, and usually we have no time for collection, but in some situation we need to even consider allogeneic stem cell transplantation. Of course, in those situations with a plastic phenotype of neutropenia, and in those situations when we suspect also myelodysplastic syndrome, which may develop after previous treatment as therapy-related complication.
Thank you. And for how many months you would wait until you say it's time to infuse the stem cells?
So it is not. It is between 3 and 6 months. This is this time when we decide about this form of treatment.
Any other questions? Dr. Issa?
Thank you very much for the comprehensive talk. I'm from pediatric transplant cellular therapy. My question is about vaccination in general. Clearly you mentioned about early vaccination and the expected low response to them. We encounter also in pediatric, because the indication in ALL and CAR T is a little bit different. So many of our patients are post-BMTs and they are younger in age. So they have like full round of vaccination after birth, and then after BMT they have a full round of a year, and then they get the CAR T, and then after that they are put on IVIG replacement for a long time. The question is, what is your practice in terms of reinitiating other than the SARS, the COVID and the influenza? Is it 6 months, 1 year, avoiding life attenuated vaccines, or you do it for everybody, or it depends on any kind of recovery of T cells?
Of course, live vaccines are contraindicated in the setting of CAR T-cell patients. We are trying to start this vaccination between month 3 and month 6. And apart from vaccination against influenza and SARS-CoV-2, one of the most important vaccination, this is anti-pneumococcal vaccination, and we are trying to start this vaccination between months 3 and 6. We do not have very good data, and we copy our behavior based on stem cell transplant patient, and we use similar procedure and algorithm for such vaccination. For adults, one of the most important, this is pneumococcal vaccination, and other vaccines are offered to our patients depending on situation. For instance, people who working with children, they may have, just like teachers, for instance, they may need to be vaccinated also against meningococcal infection or Haemophilus infection. So it depends. However, 3 main vaccination, this is SARS-CoV-2, influenza, and pneumococcal vaccine.
I think we have to stop for the sake of time. Thank you, Dr. Jill, and we hope to have you in person next time. Thank you very much.
Thank you very much.
Thank you. It's my pleasure to introduce Dr. Mohammed Al-Isa, who is the next speaker. He is currently the Deputy Chairman of the Department of Hematology and Oncology at King Abdullah Specialist Children's Hospital, National Guard, Riyadh. He is also an Associate Professor at King Saud bin Abdulaziz University for Health Sciences. His main area of interest is transplant and thalassemia and sickle cell. He is going to enlighten us about the current literature for the conditioning regimens for transplant and transfusion-dependent thalassemia. Thank you.
Thank you very much, Dr. Abdullah, and really it's a great pleasure to be with you, and thanks for the organizer and Ssbmt as well as the EBMT. And it's also a pleasure to talk about, switching gears to hemoglobinopathy. This talk actually, it's a combination talk. It was presented in the last EBMT about conditioning regimen for TDT patients, part of the EBMT hemoglobinopathy party. So today we'll go an overview, so some introductions and the factors contributing to TDT outcome, conditioning for match-related donor and alternative donor transplants, and then finally we'll try to have some conclusions. It is very tricky subject because every center do their own conditioning regimen and their own recipe. But this also, so I'm going to trying to go at the beginning, talk about the historical part of that, my disclosure. And this actually slide comes from the EBMT Working Party, and it stops at 2020. You see the COVID time where a lot of shutdown happened for the elective transplants. But if you look at the trends, you see in hemoglobinopathy that sickle cell keep going and rising in transplants. But for thalassemia, it's sort of plateauing, at least in the children. And you see also that in the adult population, the number of transplant is much lower, and that's expected because of the fitness of the patient and the organ function over time. If we look at general outcome, general two-year overall survival, it was in the 92% and the 80s for the thalassemia patient. But what makes thalassemia, transfusion-dependent thalassemia patient challenging is their massive pre-transplantation exposure to blood products, expanded erythropoietic marrow, no prior chemotherapy exposure. Their marrow is very active. And also, of course, the iron overload and the organ function has a possible implication on the outcome. Plus minus the organomegaly or splenomegaly as part of the this is the CIBMTR data that looked at the around 1,100 patients of TDT patients who received transplantation, and based on donor type, you'll see different outcomes. We have to keep in mind here that this data is published in 2019, but it's lagging a little bit behind as we're talking today, especially when we talk about the mismatch related or haploidentical outcome. If you look, for example, on the EFS, it will be going around the 70% range. But it's clearly here, it's been a standard of care in match-related donor transplantation with an excellent outcome if you transplant them early in childhood. Similarly, the match-unrelated donor is a good choice if you identify them earlier. Now, that might be a little bit different in different parts of the world because having a match and unrelated is a bit of a struggle in certain areas around the world. But having a match-related donor also is something that also variable. And for example, recently we had with our colleagues in the adult check, and around 60% of the Saudi population have around matched family donor. And that also opened the area because of high rates of consanguinity, and people may get into finding a donor much easier, even in the extended family sometimes. How about the age effect on the outcome of TDT patients? Those are very important points before going to conditioning regimen, but it's clearly shown that older the age, the lower the outcome, but in transfusion-dependent thalassemia. But really the curve goes down dramatically above the age of 15. So if you are less than 15 years of age, you have a reasonable outcome. Of course, the best if you are less than 6 years of age. So you're talking about 90 plus outcome going down to the 70s and 65. How about the organ function and the classic representation of iron overload? Pissarro and Lucarelli group have already looked at over many, many years, and the patients were identified based on the presence of hepatomegaly, liver fibrosis, and the irregularity of chelation therapy. And although this is kind of a bit debatable in the adult population, but in the pediatric, based on this scoring system, class 1 will have a much better outcome compared to class 3, where they will have a lot of iron overload and organ dysfunction. So in summary, all those three main factors plays a role, and you see it clear by putting the age, an adult. If you look class 3 and adult together, you'll go to 65% range. So that's the big challenge, actually. And this similarly could be replicated in the unrelated transplantation and the haplotransplant. So the question comes to all the time, what type of conditioning regimens we should use? And this is always the standard of care versus all the trials, and how can patient tolerate reduced intensity or something in between like reduced toxicity. So one of the things that also as definition, and I would discuss it here and then we'll come to it during the presentation, it's what's called the pre-transplantation immunization, immunosuppression that can minimize the mixed chimerism and graft failure in high-risk patient transplants. And this approach has been taken by different groups around the world with different approaches, whether in Italy or in Asian countries or India. So one of the options will be hydroxyurea as a thioprin and hypertransfusions. Other groups have been doing fludarabine, cyclophosphamide, and dexamethasone as a pre-transplantation immunosuppressive therapy, and some will give fludarabine and dexamethasone. So now we'll go through historical informations, and we'll go through the type of conditioning regimen in match-related donor transplantation. So I will start going down back to the 80s and the 90s. If you look and try to highlight in red the biggest studies and outcomes, and of course it comes back, of course, to Lucarelli et al. Late 90s and in the 2000s. And if you look at the beginning, so the first one with a large group was 116 patients. The conditioning classically was a BUSI. And if you look at the class 1 and class 2, class 3 definition, you will find the class 1, 94% will do the great job, best outcome. But if you go down to class 3, you will find 61 and 53%. So that's a very challenging thing. So later on, and in the following 10 years, the 393 patients of class 1 and 2 continue to do well with BUSI. However, class 3, there have been some reduction in the cyclophosphamide dose, and that led to some improvement compared to the initial outcome. Later on, ATG was added and by groups, and that could also improve in the outcome. But also other protocols have been emerging in the 2000 era. And one of the big ones, if you look at the table, will be Bernardo et al., where, of course, people will be manipulating and adding thiotepa as an immunosuppressive agent as well. And it has a very good effect. So with this outcome, it was in 2008 around 20 patients, but they've got treosulfan instead of busulfan, thiotepa with fludarabine and ATG. And the outcome included both matched family donor and matched unrelated donor, and they were in the ranging in 95% survival and 85% event-free survival. So those are great outcomes that have been evolving with time. Other groups also have been using other approaches, such as the use of Protocol 26, which I will come to in Italy as well, with a great outcome. Now, if we look further into the number of patients enrolled in the following years, you'll see some area around the world continue on the BUSI, replicating the Italian outcome. So ranges the outcome between 80 to 70. But it was also interesting because some of the group also have started the pre-transplantation immunosuppressive approach. And that you could see by the group, for example, Lee et al. For 30 patients. And they've given those patients hydroxyurea and azathioprine and hypertransfusion, and then followed by the myeloablative regimen here, and in other ones will be reduced intensity. Now, late in 2012, Bernardo et al. Have, the group have already published their 60 patients, similarly with the excellent outcome, 93% as an overall survival and 84% as the thalassemia-free survival. Now, just to catch up on, I'm just highlighting the difference. Many groups continue to do the same, different part of the word, but I will highlight the Gaziv et al. Approach, which is they've done the newer approach with 16 patients with this protocol 26, which I will come to. Compared to the classic BUSI thiotepa, and the outcome was really amazing by the group. So what they've done actually is to give pre-transplantation fludarabine and hydroxyurea and hypertransfusion, and then a BU thiotepa with Cy and ATG. The outcome was very acceptable, and actually it's a change. So many people in the world in the Asian group have adopted a sort of similar approach with modification. And here I would like to highlight the group from Thailand, where they have used the flu-bu ATG only, but before that giving a long course of pre-transplantation immunosuppression, and particularly talking about dexamethasone and fludarabine at day -60. And what's interesting in this group, the median age was 17. So it means they are older patients. And also the outcome is in the 90 and 93% as published by the Italian group. This group have continued to publish later on. I'll mention that in the haplotransplantation as well. In terms of local data in the Middle East, there are multiple studies coming from Jordan, from Saudi Arabia. Dr. Jeffrey have published the 160 patients with the outcome of 90% for a match-related donor overall, and the thalassemia-free is 77%. However, if the outcome is extremely better, I mean, looking at class 3 is lower, but when bucy and fludarabine was used as the evolution of the Italian group, their outcome was also amazing in the 90s. In our center, we did around 48 patients, the initial ones with bucy ATG, but the last 36 patients, thiatipa flu was the main approach with an outcome of 97% and a 94% of event-free survival. One thing to point here, it's mainly class 1 and 2 and less of class 3. And finally, the Ssbmt showed that in a big study that a BU-based, TREO-based is really acceptable, excellent outcome, although we know with treosulfan there is some sort of more mixed chimerism, but this also have already been negated with different approaches by different groups. So how about match unrelated donors? So I'm not going to spend a lot of time in unrelated donor, except that, as we know, the risk of GVHD is higher. And that has been clearly shown in early studies in the 2000 era. And most of the study comes from Italy, from Lanasa et al. And if you look at the regimens, it took exactly the similar approach as match-related donor, but the addition of serotherapy and the outcome of GVHD was a little bit different. Now, if you look here, it was lower, like the event-free survival were in the 70s, in the early 2005, 2007. Bernardo et al., similar to what's match-related, they included the match-unrelated with an excellent outcome for 60 patients, which were divided between match-related and match-unrelated donor. Now, if you look at other approaches as well, as I mentioned earlier, similar, the Thai group also have used their regimen both in related and unrelated and in haploidentical transplantation, but the difference is in haplo they added post-transplant cyclophosphamide, and their outcome is in the 90s. And these are also similar outcomes. People are using TREO-based regimen and or the Thai group. 4 patients come from the Indian group. They use the same, almost the same approach as the Thai group, and with an excellent outcome. So how about alternative donor? And here is the big challenge, because before we were talking about nowadays outcome above 80s and 90s, but now when you go to haploidentical transplantation or cord blood, we have to focus on 2 things. For cord blood, let's just finish it quick. It has been really disappointing in the cord blood that in TDT patients for unrelated cord blood outcome is not as great as the others. And one of the big referred studies by Ruggieri et al., about 35 patients. You look overall survival 60%, and a lot of graft failure and event-free survival is lower. The only study that showed a high number of good outcome is by Jane et al., and they used bucy ATG, but the difference is double cord blood has been used. And in this category of patients, in this study, it showed that the GVHD rate also was very, very high. So it was a high-dose cord blood with double cords. If we look at haploidentical transplantation, early in the 2000s, the multiple group have done multiple things. In Europe, it's mainly the approach with the ex vivo T-cell depletion, as opposed to the PTCY approach in some other countries. The initial studies and tried to put the number of patients above 20. Sudani et al. Was the biggest cohort using this approach, but around 28% of the patient had graft failure. Although the outcome is 93% overall survival, 71% was the thalassemia-free survival. So that was an issue, despite doing pre-transplantation immunosuppression with hydroxyurea as a thioprin and giving a good condition regimen, the graft failure rate was a bit higher. On the other hand, the other groups in Thailand have already looked at the studies using their same approach plus PTCY, and it's very interesting that their outcome is very promising. On the other side, if you look at Prof. De La Fonte and his group in the UK and with a collaboration with the US, they've done hydroxyurea as a thioprin plus hypertransfusion, and a regimen similar to what's used in the Vanderbilt group in the sickle cell, been using ATG, thiotipaflucide, TBI between 200 and 400. The approach was in the 80s, and that was also encouraging initial outcome. How about lately in the last 2 years? Merli et al. From the Italian group have done in non-malignant diseases BU-flu thiotipa regimen with a ex vivo T cell depletion, alpha beta depletion. But out of those 70 patients, 10 patients were TDT. What's mentioned in the abstract, mainly thalassemia, remains a challenge. The overall survival is 91%, but the event-free survival was 60%. Now, the Thai group with 83% have currently the best results in the literature using their approach. But also, if we dig deep into the studies, they were still having some infections, hemorrhagic cystitis based on their approach. Replicating other studies, Jaswal et al. From India have done 5 patients out of 10 hemoglobinopathy using Triaflu, MEL, and PTCY, plus using abatacept after post-transplant cyclophosphamide to decrease the GVHD, also have some promising results, some early results. Our colleagues at the adult, Dr. Mohsen Zahrani, have done 4 haplo patients out of 7 with this approach, with PTCY, the Vanderbilt approach, and the outcome is around 86% with 71% thalassemia-free. And finally, actually, a month ago, the German group have published their 20 patients. 13 of them were haploidentical transplantation using the trio thiotipaflu approach, but again using the TCR alpha beta depletion. And the outcome is amazingly excellent, and then with the haplo 92% as thalassemia-free. Now, I must say the GVHD, acute GVHD, was around 38%, but they were all mild, less than grade 3.
3 minutes, Dr.
Sure. So the coming 3 or 4 slides is just mainly to give you an idea about this concept of the pre-transplantation and what the Thai group is doing. So they start the early phase with dexamethasone, fludarabine at day minus 68 for 5 days. And in between, if the patient has alloimmunization, they keep, and there was a great talk yesterday for DSA and anti-DSA, with using bortezomib, rituximab as a sort of desensitizing the patients. And then follow with another block between minus 40 and minus 36. It's a bit extensive kind of workup, but later on you'll get ATG BU-flu regimen, followed that by the PTCY. On the other hand, part of the evolution of the haplo, this is what have been also discussed by Prof. De La Fonte and his group, hypertransfusion and hydroxyurea with the conditioning regimen with a PTCY approach. And finally, this is the Jaswal et al. Have described the use of abatacept after with PTCY as a GVHD prevention technique. I will refer you to this also very recent publication in the TCT in 2025, where they have also put the Chinese group outcome. And in this meta-analysis or the review, it was favoring myeloblative over the REC and PTIS pre. However, all these outcomes have been looked at. We need to look at it carefully, as both approaches are acceptable depending on center experience. So in summary, this is the evolution of conditioning regimen in TDT patients. It started initially in the 80s with Abusi, Thiotepa was added, then ATG. People have been using treosulfan versus busulfan adjusted dose based on levels. And nowadays, people are having another approaches in the haploidentical transplantation, particularly using the pre-transplant immunosuppression approach. So this will put us in a conclusion that conditioning regimen remains different and very variable between different centers around the world. Although myeloblative conditioning in the pediatric group is well tolerated and very well done, many centers have moved to treosulfan, fludarabine, Thiotepa, and ATG versus busulfan with monitoring level. All seems to be appropriate regimens. The pre-transplantation immunosuppression followed by reduced intensity is a promising approach, especially when we talk about class 3 patients or adult patients. Minding in mind that here we're not talking about gene therapy approaches, which is another approach in some patients, but myeloblative remains a major issue in both approaches. GVHD remains an issue in unrelated transplantation. However, evolution of GVHD treatment and prophylaxis also is something that's also evolving, and routine use of other techniques in the ex vivo depletion and abatacept. Haploidentical transplantation protocols are evolving with both approaches are acceptable at the moment with promising results, and with hopefully in the future better outcome and better approaches will be open for our children and patients with thalassemia. With that, I would like to acknowledge the Ssbmt Hemoglobinopathy Working Party, of course, all hemoglobinopathy patients around the world and all centers contributing, and to our stem cell transplant team, the pediatric and the adult at King Abdulaziz Medical City in National Guard, Riyadh.
Thank you, Dr. Mohammed, for this comprehensive talk. We will keep the questions at the end. Dr. Amr will introduce the next speaker.
So I have the pleasure of introducing our next speaker. Dr. Samir Al-Amoudi is a consultant adult hematology, blood and marrow transplantation, and he's also section head stem cell transplant and cellular therapy at Princess Noura Oncology Center, King Abdulaziz Medical City, King Khalid National Guard Hospital, Jeddah, Saudi Arabia. He's also an assistant professor in medicine at King Saud bin Abdulaziz University for Health Sciences, College of Medicine in Jeddah. So Dr. Samir is going to talk about identifying sickle cell disease and TDT patients for advanced therapy. Now, this is a satellite symposium, which is sponsored by Vertex Satellite. Dr. Samir, go ahead, please.
Assalamu alaikum. Good morning, everybody. Thanks, Mr. Chairman, for the nice introduction. And I want to thank the organizer for this great meeting. And thanks, Vertex, for running this satellite symposium. So in the next 20 minutes, I will talk about identifying sickle cell disease and transfusion-dependent thalassemia advanced therapy. So actually, this is my disclosure. And before that, like just for 10 seconds, you can scan the QR code. This is like pre-event survey. Okay. So, as we know, like in early life, actually, hemoglobin F is the major hemoglobin, and actually, which contain like 2 alpha and 2 gamma. Actually, once the transition happen, actually after 6 months and from gamma to beta, you can see there is increased production of hemoglobin A. And this actually when the symptoms start if the patient is having thalassemia or sickle cell anemia. And it was mentioned, actually showed that like earlier before the era of hydroxyurea, if the patient is having hemoglobin F more than 8.6, better overall survival compared if they have lower actually hemoglobin F. And this is also, you can see any patient with sickle cell anemia, if the hemoglobin level actually is trending, is higher, actually they meant to have like lower symptoms, and even with thalassemia, they'll have lower transfusion, blood transfusion. So is there any way to increase this hemoglobin F? Actually, there is a new modality, advanced therapy, which is the gene therapy. So there is 2 mechanisms in gene therapy. Actually, one is what we call it gene addition. The other mechanism is gene editing. So in both technique, actually, they will screen the patient, and once the patient is eligible for this therapy, you will collect the stem cells. Then either you have the gene editing, or we'll talk about detail later on, or gene addition. So after the manufacturing, the stem cell is actually it's ready, then your patient will be underwent conditioning regimen and infuse the cells and waiting until engraftment. So in gene addition, actually, so you collect the stem cells, and there is a lentivirus. So you inserted this lentivirus. This will lead to production of modified beta globin. So the modified beta globin, actually, if you can see here, actually, it's unpolymerized hemoglobin, so this will lead normal red blood cells and no sicklings. This is in gene addition. So what about gene editing? So gene editing, actually, you don't add any lentivirus. Actually, you put what we call Cas9 and guide RNA. This actually will be enhanced in the DNA. The main reason, actually, or the way this one gonna work, actually, by suppressing what we call PCL11A, which is important in suppression of hemoglobin F. That's why by doing gene editing, you inhibit this BCL11A, which leads to increased production of hemoglobin F. So this, as I mentioned the previous, so usually by doing the gene editing, so you suppress actually BCL11, and this leads to increased production of hemoglobin F, so the patient's symptom will improve. So let's now talk about the data about gene actually editing. So let's start with the sickle cell disease. Actually, so this is like a phase 3 trial. And you can see before talking about the trial, this is like the patient journey. So you will collect the stem cells actually. Then you will do the gene editing until the product ready. Then you will give the conditioning therapy, which is actually myeloablative busulfan, infuse the extra cell, and waiting until the count recover, then discharge the patients. So they include around actually 44 patients. The primary endpoint was free of severe vaso-occlusive crisis in the 12 consecutive months. Secondary endpoint, free from inpatient hospitalization with severe form of vaso-occlusive crisis in the first consecutive months. What are the eligibility criteria, actually? So we'll talk in detail. So this is the eligibility criteria. So I want you to look at the age. So the age is like approved from 12 until 35 years. And the patient should be eligible for autologous transplant. The patient should have normal actually transcranial Doppler. So if the patient has actually high transcranial Doppler, they will usually exclude it. The patient should have a severe sickle cell disease, so at least 2 vaso-occlusive crises per year in the last 2 years. And actually the patient should have beta BSS or PS 0 or beta S beta plus. And of course, the patient should be actually fit like for this therapy. Exclusion criteria, as I mentioned some. So if the patient actually having HLA match, actually at that time, this patient usually will be excluded. And of course, if the patient has alloimmunization to RBC, because you know we are giving myeloablative, so these types of patients require blood transfusion. So if the patient has like alloimmunization, there will be harm of the patient. That's why they were excluded. And of course, if the main reason of our main idea of gene editing is to increase hemoglobin F. So if you have a patient with hemoglobin F, so this type of patient were excluded. And as mentioned earlier about like any abnormal transcranial Doppler or Moya disease not treated usually were excluded from this trial. Other exclusion criteria, as like any criteria, any clinical trial, if the patient not fit actually for this receiving conditioning therapy, they will be excluded. So what is the results of the primary endpoint, which is the patient to be free from actually vaso-occlusive crisis for 12 consecutive months? It's approached around 96.7% actually median duration around 22 months. And here you can see, so this is actually the blue dots from the attacks of vaso-occlusive crisis. And you can see here after XSL infusion, I say you can see the number of red, the blue dots decrease, so the number actually of vaso-occlusive crisis decrease. And what about the secondary endpoint, which is the hospitalization? Actually, you can see 100% approach. This is secondary endpoint. And you can see also the blue dots represent actually the hospitalization. You can see all the patients, they didn't require any hospitalization, which is the major issue with sickle cell disease with recurrent vaso-occlusive crisis. So what about the transfusion-dependent thalassemia? So actually, there's another study, which is a phase 3 study actually. And the inclusion criteria, I'll talk details about it in the next slide. But the primary endpoint is transfusion independent for 12 consecutive months. Secondary endpoint, transfusion independent for 6 consecutive months. So what are the eligibility criteria? Again, the age should be like 1253 with good performance status. And this actually in this trial, they include the patient with homozygous B thalassemia. Initially, they exclude beta 0 genotype, but later on, actually, these types of patients were included. And also, the patient should be transfusion dependent at least 10 units per year for the last 2 years. Exclusion criteria, the same. If the patient is having much related donor, this patient will be excluded. Associated alpha thalassemia and alpha 1 chain, also these types of patients will be excluded. And I mentioned beta 0 were excluded initially. Other exclusion criteria are about the performance, so it's the same like any other clinical trial. So what are the results of the primary endpoint, which is like to be transfusion dependent for 12 consecutive months? Actually, it reached around, in 92% actually of the patients. So you can see here actually, so only like there's 3 patients, actually they not achieve the primary endpoint, but these 3 patients actually achieved this primary endpoint at 14 and 12 and 21 months. So at the end, even there is a late response, they did well to be transfusion independent. This is just to show us there is persistence of hemoglobin F after XSL infusion in patients with transfusion-dependent thalassemia. So now I give you the data about the benefit or the outcome from the doing XSL. So the question now, you have the allogenic stem cell transplant and the gene therapy. So which we'll use actually? So this is actually the journey or the treatment plan for any patient with hemoglobinopathies. Usually prevent any symptoms, symptomatic therapy, pharmacological transfusion, and the only way to cure these types of patients is allogenic stem cell transplant. Having said that, so we know sometimes difficult to find much related donor for patients with hemoglobinopathies. And even if we find a much-related donor, we know one of the complications of allogenic stem cell transplant is the graft versus host disease, which is a major concern for the patients. And this actually is increased if the patient actually is having either unrelated or haplo donor. So, and because there is risk of GVHD, usually we need to give the patient immunosuppressive medication. That's why we maybe increase risk of infection. So in gene therapy, actually, which is because it's autologous, there is no actually eliminate the possibility of graft versus host disease, and no need to identify a donor. So this is just the same things as I mentioned before. So here just to address that in gene therapy, actually there is no GVHD, no need for donor, no graft failure. The only concern is usually we give myeloablative regimen. The other things is the long-term follow-up that is required about the safety of this gene therapy. Here actually this is just to compare between allogeneic stem cell transplant gene therapy, and you can see, and actually regarding in the median time neutrophil and platelet engraftment, there is no significant difference, which is not a major issue. I think the thing that you have to look at regarding treatment-related mortality with around almost 6% compared to 2% in gene therapy, graft failure, 0 in gene therapy, around 9% in allogenic transplant. Of course, acute GVHD, 0 with the gene therapy, around 18% in allogenic transplant. So what the advantage and the limitation of the both allogenic and gene therapy? So for allogenic stem cell transplant, actually the established protocol, it's available most of the centers actually covered by the insurance. The limitation, as I mentioned earlier, identifying the donor, the cost actually for the follow-up of the patient after allogenic stem cell transplant, and it's need lifelong management. And about the gene therapy, the advantage is age flexibility, no need to identify any donor. The limitation is upfront cost. It's not cheap, it's expensive medications, and still it's need a lot of preparation for collection the stem cell and do the gene editing, and of course the limitation need also longer follow-up. So actually there is here specialized working group and Ssbmt, which is this already addressed this issue before. But this is actually the recommendation. So if you have a patient, actually, in case of sickle cell anemia, if you have a patient with hemoglobin SS or hemoglobin S beta 0 genotype, actually, and there is an identified donor, you will take the patient for allogenic transplant. If there is no identified donor and the patient age should be above 12 years, this patient actually will be referred for gene therapy, and if will be assessed. If the patient actually is fit, they can proceed for the gene therapy. And this is the inclusion criteria. So in general, as I mentioned, hemoglobin SS or hemoglobin S beta 0, hemoglobin less than 30, no identified donor. So if you find a match-related donor, you will go for allogenic transplant. And of course, you need monitoring for these types of patients. And here there's general recommendation about each condition actually. So for vaso-occlusive crisis, it should be at least 2 vaso-occlusive crises, required hospitalization per 2 years, recurrent acute chest syndrome. Cardiovascular system, we know the patient with sickle cell disease, they're at risk of cardiomyopathy. So they mentioned if diastolic dysfunction actually, in the absence of restrictive myocardiopathy, this patient actually can be eligible for gene therapy. Pulmonary hypertension should be between 25 and 29. And liver disease, actually, if there is actually this patient have chronic cholestatic hepatitis without hepatic failure, this type of patient will be eligible for gene therapy. Kidney disease, cerebral vascular disease, we know this types of patients were initially excluded from the trial, but they put actually here recommendation. If the patient has abnormal transcranial Doppler, still you can take the patients, but I think to the gene therapy, we need to discuss with the patient about the benefit and toxicity. Aluminization, also one of the exclusion criteria in the previous clinical trial. Still, they mentioned you can use if the patient has aluminization, it can be eligible for gene therapy. Thrombophilia screen, if the patient has actually low risk of thrombophilia or the patient has thrombosis and you can interrupt the anticoagulation, still you can take this type of patient gene therapy. Autoimmune disease, not contraindication for gene therapy. So we need a monitoring. Of course, this recommendation, any patient going for any therapy, they need a follow-up, either short-term or long-term. So, and this is actually, we know that patients with allogenic stem cell transplant are at risk to develop cardiac disease, pulmonary toxicity, and also affect the fertility. But these things that you have to keep it in your mind. This is actually their recommendations. So usually you're worried in gene therapy, as I mentioned, about the myeloablative conditioning with the toxicity. there is genomic editing tools that can be done. So the concern, like, is there any risk of malignancy in the future, actually? So because it was mentioned with the gene editing, actually adding, there is like 2 cases of develop actually two sickle cell patients with gene addition develop MDS and leukemia. But that's why it was stopped. So, and they mentioned actually the acute myeloid leukemia could be related also to busulfan, which is the conditioning regimen that you give it to the patients. One of the things, as I mentioned, is like the long-term follow-up of the gene therapies needed. And this is actually they mentioned actually there is a marker for poor prognosis, and these types of patients should be actually referred for gene therapy. As I mentioned, hemoglobin SS, hemoglobin S beta 0, lower fetal hemoglobin, and absence of alpha thalassemia, and some non-genetic factors like anemia and abnormal kidney disease. And I think by this I conclude. This is just a post-event survey. You can take QR code, and thank you.
Thank you, Dr. Samir, for this comprehensive talk. We invite the speakers to the podium for the questions. Any questions?
So I have actually two questions to Dr. Issa. Please have a seat first. So my first question is regarding the age. You know, some of the earlier studies, patients in their late teenage, 20s, or even 30s, they were included. But we know that patient with thalassemia should have a transplant during early childhood. They have the best result before the iron overload develops. So what is the average age of your patient group, at your center? This is the first question. The second question is regarding GVHD in thalassemia patient. We know that extensive GVHD grade 3 or 4 is not good for any type of transplant for any disease. But mild GVHD is associated with graft versus leukemia effect in patient with leukemias. So what is the effect of grade 1, 2 or mild GVHD in patient with thalassemia? Is it really good? Does it help better engraftment, or is it associated with some complications?
Thank you very much. So in regards to the second question about the GVHD, I mean, typically, yes, we really try to avoid any kind of GVHD and any non-malignant disease. So we don't like any grade of GVHD. And nowadays, I mean, looking at our demographic here, we don't really see a lot of GVHD in our cohort. We've done in our center around 48 patients at the moment. The rate of GVHD is very, very low in thalassemia patient because they're all match related, and in our regimen we didn't see much, but also we keep immunosuppression for a longer. We don't taper early in thalassemia patients. Many of them extend until 9 months to 1 year post-transplantation instead of tapering early at 6 months or so. In the couple of patients, whether in thalassemia or sickle cell, around 10 patients with unrelated transplantation, we recently adopted adding abatacept to the prophylactic regimen to avoid GVHD, particularly acute GVHD, because it did not show much in chronic GVHD. And we have, because we have 2 incidents of GVHD that they were mild, but they responded to steroids and other therapy like ECP in regards to that. So I agree 100%, no GVHD is the best. If you are too much overloaded or you have organ damage, then the risk of GVHD is higher. But that we try to alleviate as much as possible. In regards to the age, as you mentioned earlier, yes, our majority of our age group is less than the age of 10 years who go for transplantation at the moment. In the past, we have challenges with the older age, particularly the engraftment phase, as well as the VOD risk because of iron overload. And with them at many, in the earlier, with those very high iron overload, we use defibrotide for them to decrease the rate of VOD. It is a tough question, but really, early referral is the best before the iron overload happens, because I see the struggle of our colleagues in the adults when they have a patient with thalassemia with iron overload and they're not transplanted earlier in childhood. And in addition to the compliance with iron chelation therapy is the main thing.
Thank you. Any other questions?
Yes. Thank you, Dr. Mohammed Isa, for the nice presentation. I am Dr. Omar from Prince Sultan Pediatric Oncology. Just my question for you. First, how do different condition regimen you mentioned for transplant improve the toxicity and success rate in pediatric thalassemia, and about the choosing of this conditioning, because with the different
I mean, as I mentioned in the presentation, the conditioning regimen is very variable between center. But we are in our center, we use an approach. We use a different. We don't use treosulfan. We don't have a lot of access to it, but we use busulfan targeted level. So our regimen currently is thiotepa, busulfan, fludarabine, which has been replicated in the Italian, some of the Italian groups with a class 3, and they tolerate it very well. We decrease the iron before transplantation. We make sure that the liver iron concentration is very low. We do T2 star MRI, and if we have a struggle and it's very, very high, we confirm with the liver iron concentration with a biopsy in the past, and we try to avoid as much as possible, but we do that. And then we'll be very vigilant during the transplantation in terms of the VOD risks and engraftments. That's in case of match-related donor. Our target level of BU is between 60 to 80 in the pediatric with the addition of thiotepa. It worked very well. We did not have to go to the too much myeloablative to 80 to 100 in the conditioning regimen in our situation.
Just I have like comment and questions at the same time for transplant. How effective in newborn screening followed by early intervention improving transplant success rate in thalassemia?
Can you repeat
How
that?
the effective in a newborn screening followed by early intervention in improving transplant success rate in the thalassemia, just to avoid iron overload?
Sure. That's a tough question, because the newborn screening, as you know, is just implemented recently. Mainly, we go with premarital screening. But again, in thalassemia, the early diagnosis, the better, and then chelation therapy. As I mentioned, 6 years and lower is the best age for outcome for thalassemia patient before the iron overload and end organ damage. Certainly, if you diagnose earlier, you'll be compliant earlier.
Just one more question for Dr. Saeed Al-Amoudi. Really, thank you for your presentation. Just I have questions about the gene therapy. You mentioned about the sickle cell TAL, sickle cell S. What about sickle cell C? Is there any including in this criteria?
So thanks for the question. Actually, this type of patient were not included actually in this clinical trial. So it depends on the severity of these types of patient, how they are doing clinically. And based on it, we'll decide. And as I mentioned earlier, usually not go direct to the gene therapy. So first we need, if there is an identified donor, and show it like in the EHA working group actually. So if there is like HLA match donor, the first option will be allogeneic stem cell transplant. And then it will depend like about the severity of the symptoms, then we can consider gene therapy for these types of patients.
Actually, we have good amount of time, so we can ask more questions. So my question is to Dr. Samir. You know, we have two main types of gene therapy, lentivirus-based therapy and CRISPR-Cas9-based therapy. And there are others as well, but they are still not published and we don't have the results. So in your experience, I know you're not practicing both of them. Both of them have been reported to have similar results and highly successful. In your experience or in your knowledge, do you think which one is supposed to be better in terms of complications, in terms of outcome is probably similar, but in terms of complications, obviously we need to wait for the long-term results, which we don't have as yet.
Yeah, okay, thanks. So just a comment. So we know gene therapy is available here in National Guard Riyadh, and in a couple of months it will be available in National Guard Jeddah. So are in the final steps. So regarding the which gene therapy, so until now nobody know about the long-term toxicity. The good thing about gene therapy, it's like you will give the patient the gene therapy, all the issues or difficulty in the preparation, the patient collecting the cells. Because collecting the cells, you have a large amount of stem cell. You need to collect more than 20 million. And these types of patients, especially the sickle cell disease, they need to be off hydroxyurea, to be in GCSF, which can make things worse, like increase the vaso-occlusive crisis. So the difficulty, as mentioned earlier, is the collection of the stem cells. So once you give the conditioning and infuse the cells, once the patient grafted, will be less complication, not like allogenic transplant in form of the GVHD. But regarding the question about long-term, still we don't know, and nobody knows until that. We have the same concept in the CAR T cell. So in the CAR T cell, actually, we do some modifications to the viral vector. And although there is data about the risk, could be increase the risk of T cell lymphoma, but still this modality of therapy, especially these types of patients. So the only way is just to wait until to see if there is data for that.
Thank you. Any other questions? There's a question in the back.
Thank you for the excellent presentations. So my question is like a practical question. Like the syndrome of having a vaso-occlusive crisis or musculoskeletal pain post-allogenic stem cell transplant. Any special consideration management? I have 3 female patients who are suffering still of vaso-occlusive crisis or pain coming to the emergency like weekly for management of this pain. So, and the other question is that is this phenomena observed also post-gene therapy in sickle cell disease patients or not?
So just to be clarified, so you are mentioning the patient post-allogenic transplant coming with
who are
vaso-occlusive?
suffering of severe pain,
Okay, so
the persistent pain post-allo stem cell
I get
transplant.
it. Okay, so you mean although the patient was cured from the sickle cell disease, still they have the symptom of the pain. So if there's any things happen with the gene therapy, so I'm not sure about any data about that. Yes, about like any, once you do gene therapy for these types of patients, will the pain will under control or not? Especially that, unfortunately, some of these types of patients like dependent on these opioid medications. But I don't know if you have any comment.
They were excluded. I mean, the patients with chronic pain from the gene studies, they were excluded from the trial. But they were a very strict definition of what is chronic pain that they have. And it's very, sometimes it's very hard to differentiate. But those patients really are evaluated fully prior to the trial. Now, does that mean in the future are they going to be included or not? That will depend on the criteria and hospital criteria / more studies in the future.
Okay, thank you. Any other questions? There's a question here.
Thank you so much for both of the speakers. It's actually very exciting that we have many options for hemoglobinopathy now, and it's an exciting time for us. My question, my background is in pediatrics, so what is the lower age limit for offering gene therapy, whether it's the Blueprint or the other Vertex product? And the other is, with all these options, what is the best way to manage hemoglobinopathy in pediatrics before they develop complications and go to the adult colleagues? Thank you.
Okay, so for the lower, so the age were included in clinical trial actually from 12 up to 35. So if the patient is less than 12 years, actually they're not be included for the gene therapy. And with the availability of all these options, as mentioned earlier, like, so if option number one is allogenic stem cell transplant, if you have the donor. If you don't have, let's take it one by one. So let's say sickle cell disease. So you have much related donor, you will go for transplant. If you have Hablo, unfortunately, because they are transfusion dependent, this sickle cell disorder, they are at risk of to have donor specific antibodies. So still maybe we'll find difficulty to find the Hablo donor. That's why after that we'll go for the gene therapy. In transfusion dependent thalassemia, actually, even those one mentioned by Dr. Isa, but in adult actually, allogenic transplant actually it has like high transplant-related mortality, especially in thalassemia dependent transfusion. So because they have splenomegaly, increased risk of graft failure, toxicity, infection. So just this is my personal opinion. Like gene therapy, I think will be moved earlier in case of thalassemia disease patients. But I don't know in the pediatric any.
So the first comment about the age, hopefully with the ongoing trials, the age hopefully will be lower, especially with the long-term outcome and the approving agencies. So we are waiting and watching in pediatrics. In terms of the type of transplantation, I think the major and critical rule is we go for match-related because our outcome is 95% and above. And still, in the match-related versus gene therapy, both are myeloablative therapy. They will cause infertility. They will cause the side effects of that. Now, in the future, if another therapy, a less myeloablative therapy goes to one of each. Now, we know in transplantation that myeloablative is still a standard of care. However, in autologous gene edited or gene addition, if at one point those new antibody-based conditioning regimen will come into play, then the whole story may change. And then it come further higher. But at the moment, we still go that. In terms of haploidentical transplantation, as yesterday was presented, that the outcome by Dr. Fahd Manjoumi, that the outcome in pediatric haploidentical transplantation, in sickle cell at least, is not as good as the adult in terms of graft failure. The graft failure rate is higher, so the haplo is still inferior to gene therapy at the moment in international studies. However, ongoing studies are looking into that because the conditioning regimen in the haploidentical consortium at the moment with the excellent outcome is reaching 90%. So some patients may tolerate that and may not tolerate the myeloablative regimen in the gene therapy as well. So it's a trade here and there.
Thank you so much. I think we will conclude the session at this time. Thank you for both the speakers and the audience. We will go now for the break.
Good afternoon. It's my pleasure to introduce Dr. Giorgio Orofino. Dr. Giorgio is a hematologist at University of Vita Salù San Raffaele in Milano, Italy. His main research and clinical work is on cellular therapy in hematological malignancy and autoimmune disease. He's going today to present CAR T therapy in autoimmune disease. Dr. Giorgio, we are very eager to listen to this new aspect of CAR T therapy. The floor is yours, please.
Thank you, Indy, for the nice introduction. I really want to thank the Ssbmt and the ABMT for this occasion. It's the first time here, so I'm very glad to be presenting this lecture. So I have no disclosure to declare. I don't have to tell this audience the relevance of CAR T cells in the field of hematology. We saw some fantastic lecture today and yesterday on the role of CAR T cells in cancer. We as hematologists, we are aware of the fact that in the future we will always have to be in the field with CAR T cells more and more. But an outbreak in the recent year has been that, surprisingly, those therapies have an enhanced role also in autoimmune diseases. I reported here some of the insights from relevant journals. We had also an important mediatic impact of the fact that those therapies have efficacy in autoimmune disorders. If we go to nationaltrial.gov, this is updated to yesterday, and we look for autoimmune CAR T cells for autoimmune disorders. We have now 91 studies active. Almost all of them are active, recruiting patients. And this is just to say that in the next future, we really will have to learn about these trials and to look how data look like for patients with autoimmune disorders receiving CAR T cells. But what is the main effect of CAR T cells in autoimmune disorder? Why should they work basically well as they work in cancer therapies? We know that in autoimmune disorders, B cells are more than cells that become later plasma cells and produce antibodies, but they are rather orchestrating all the immune response, and they are central in immune dysregulation that is crucial for these autoimmune disorders. We reported in this slide the efficacy of treating CD19 target for CAR T cells. You can see that it's actually expressed by a lot of B cells, from the pro-B cells to the plasmablast. Of course, CD19 is not expressed on plasma cells, but to target those cells, we have other targets like BCMA, as I will show you later. We had, in 2019, so very early, some preclinical data of efficacy of CAR T cells in autoimmune disorders. This is a preclinical model of lupus erythematosus systemicus, in which the author reported an activity in mice treated with CD19 CARs against control. You can see that the survival experiments showed benefit of treatment with CAR T cells in mice compared to no treatment. Moreover, also the biopsies that the author performs revealed that we had an efficacy of the treatment in these mice. I really want to show you that this data was obtained in 2019, and only 2 years later, which is kind of surprising in this field in which preclinical testing generally goes long and it takes more time to be translated into clinical testing, was very rapid. So in 2021, we had the first report of patients treated with CAR T cells. It was published in New England Journal of Medicine. It was, again, lupus erythematosus systemicus patients in which CAR T cells, CD19 CAR T cells, were given. The reports were very interesting. The patient was heavily pretreated with multiple lines of immunosuppressive drugs, and he obtained a complete disease remission. The first report was a very short follow-up, since it was indeed the first patient ever reported to be treated with CAR T cells, and the efficacy rate was surprising. Importantly, in the same year, the same group, by the group of Erlangen, published the follow-up of the first patient, adding 4 more patients to the reports. Indeed, in Nature Medicine in 2021, the authors published the first 5 patients treated with autoimmune disorder and CAR T cells. I want to highlight that all the patients that were reported, the first one was patients that failed all the available lines of therapy at the moment they were treated with CAR T cells. And the follow-up, which was very short, 3 months, demonstrated a full disease response in all of these patients. So we were very surprised by those data that indeed reported an incredible activity, at least in the very short follow-up for those patients. Moving forward to these first publications, we had a number of different reports highlighting the activity of targeting B cell and plasma cells in autoimmune disorders. Indeed, you can see that lupus, systemic sclerosis, but also neurological autoimmune disorders were treated with CAR T cells, and all of those reports were indeed published in very high impact journals, such as the Lancet or New England Journal of Medicine. But to sum up a little bit the experience that we have with CAR T cells, I really want to address this relevant publication in New England in 2024, published by Fabian Müller, indeed from the Erlangen group, in which they have the major expertise in this field, and they're really moving forward this type of treatment for those patients. These are the first 15 patients treated with CAR T cells. You can see that most of them are patients with lupus. We have 3 patients with inflammatory myositis and 4 patients with systemic sclerosis. In these steps, you can see the summarization of the most relevant findings. Basically, all of the patients at the moment of the report had a full, complete disease remission. You can see here that none of them have immunosuppressive ongoing, so they were heavily pretreated patients that received multiple lines of immunosuppressive drugs, and after CAR T cells, none of them was under immune suppression. They were all glucocorticoid-free state at the moment of the report. Moreover, I really want to focus on the reported toxicity of these patients. You can see that all of them experienced CRS, but only G1. Only 1 patient had a CRS G2. Only 1 patient had ICANS, G1 ICANS, and none of them experienced bone marrow toxicity. This is highlighting a low rate of toxicities in this patient compared to patients with lymphoma or lymphoblastic leukemia that have higher rates of toxicities. Of course, we're dealing only with the first 15 patients, so we really need more robust data to show that the toxicity is lower, but in the first report, we indeed had very low rates of CRS and ICANS. Systemic sclerosis, as you may know, is a relevant disease in which also autologous stem cell transplantation has been reported to be efficacious. I will show you a little bit the data in the next slide. But in the severe forms, it accounts for a high proportion of patients with mortality and morbidity in autoimmune disorder. The 5-year mortality of the severe systemic sclerosis is 30%, so it really represents an urgent unmet clinical need. And in this disease setting, similarly to the lupus patient, the authors report an activity of CAR T cells. This is the first cohort of treated patients. We have 6 patients. You can see then 2 of them had cardiovascular and pulmonary involvement, and all of them had an important involvement of the skin. This is reported by the MRSS score, which is very high in those patients. And these are the results. You can see that the EUSTAR activity index was low after CAR T cells in all of the treated patients, similar to the disease index. This is very relevant indeed for us monitoring of that disease. Moreover, the improvement was also present in the skin, which is a relevant component, as I was mentioning in this setting. And the digital ulcers and the Raynaud phenomenon was lowered after CAR T cell infusion. Interestingly, the autoantibodies that are not pathological but are bona fide some markers of this disease decreased after the CAR T-cell infusion, even though in 2 patients started to go up again sometimes after the infusion. So we know that these autoantibodies are not driving the relapse, but of course they can testify some disease activity. So this is to point out that it's really relevant to look at those patients in the long-term follow-up and see how CAR T cells indeed may be able to control disease. Moving beyond, some experience, these are from the group of Kroger in Germany, of CAR T cells, also in neurological autoimmune disorders have been reported. The 2 first patients were published last year in Med. No ICANS and no CRS, thus suggesting that also the presence of autoimmune disorder within central nervous system is not driving the ICANS. This is something very relevant. The patients that were treated were patients with progressive MS. We know from the transplant experience that these are the most difficult patients to treat, since they have indeed a progressive disease, and also autologous stem cell transplantation. It's very difficult to achieve results in this setting. But the relevant findings here is that CAR T cells did expand in the blood. They were present within the CSF, at least in 1 of the 2 patients, and they accounted for the vast majority of circulating lymphocytes within blood, but also in the CSF. The authors reported an activity, a target activity of CAR T cells, since you can see here that oligoclonal bands were reduced within CSF in the treated patient. We have to say that the follow-up is very short, and 1 of the 2 patients experienced a new lesion after CAR T cells. This highlights that maybe in this disease setting, CAR T may not be such as efficacious as in the other autoimmune disorders, but the patient selection and of course also the disease selection is very crucial. We really want to see how they act in the field of relapsing remitting MS. But what's happening in the peripheral tissue in patients treated with CAR T cells? I really think that this slide summarizes very well what is the difference among CAR T cells treatment and conventional monoclonal antibody treatment. These are biopsies taken from patients before CAR T cell infusion, after CAR T cell infusion, and after treatment with rituximab, which is a monoclonal antibody that we know very well. You can see that after CAR T cell infusion in the lymph nodes, CAR T cells are able to completely erase the CD19, so the B cell compartment, and this is not happening with rituximab therapy. I really think that this is very informative also for other CAR T cells conditions such as tumors. You can see that CAR T are really able to go in periphery, and they're really able to eliminate B cells more profoundly than what monoclonal antibody can do. This was published last week in a rheumatology disease, and it's really motivating the efficacy of CAR T cells, I think, in the field of autoimmune disorders. Moreover, again, in April 2024, the authors described a new toxicity, so a new toxicity beyond CRS and beyond ICANS, which is named LICATS, Local Immune Effector Cell-Associated Toxicity Syndrome, in CAR T cell treated patients with autoimmune disorders. So it's very specific of patients that receive CAR T cells. The authors report 4 different grades. This was published in April in Lancet Rheumatology. And what they describe is that it's a toxicity mediated to what we saw before, so the local penetration peripheral tissues of lymphocytes of CAR T cells. It generally presents very early, so in the first 20 days. It's associated with inflammation, and it's very peculiar. You can see down on the left side of the slide that different diseases have different forms of LICATS, potentially explaining the involvement of autoimmunity, for instance, in inflammatory myositis, in which muscles are really the point of the inflammation. We can see that LICATS involves generally muscles. You can see how skin is also very often involvement, and the treatment is generally steroid. The authors performed a biopsy of the skins, and they showed that no major infiltration of immune cells were present, thus suggesting that this phenomena is more mediated by inflammation, by vasoreactivity, more than tissue penetration, suggesting that these complicants may be a mild complicants that could often be seen after CAR T-cell infusion in autoimmune disorder patients. Moreover, I also wanted to report this data that I think they are interesting. We had the first report of relapse after CAR T cells in autoimmune disorder patient. This was a 45 years old woman patient treated with CD19 CAR T cells with inflammatory myositis. The patient received CD19 CAR T cells, and you can see here in the B panel that the score after the first infusion in blue got better. So the patient had an efficacy of the first infusion of CAR T cell treatment with CD19, and then the patient relapsed. After relapse, the investigators decided to treat for a second treatment with CD19 CAR T cells, and surprisingly, no benefit was observed. You can see here that in the B panel, the muscle score after the second infusion in violet, no efficacy was present. So the authors decided to investigate what was happening in this patient, and they were able to isolate some CD19, anti-CD19 CAR T antibodies. I think this is really important. So these are patients that have autoimmunity, they have tendency to develop antibodies, and this is one of the first reports of patients that develop antibody anti-CD19 CAR T cells, that they are also probably involved in the fact that these CAR T cells are not able to expand. So the first time the patient had the expansion of CAR T cells, but the second infusion was not associated with expansion. This is testifying that those antibodies could be relevant in this field, and of course should be studied also in cancer patients. So the authors decided to have a short course of daratumumab and then change CAR T cell target. They used BCMA CAR T cells, so the third CAR T cell infusion for this patient, and surprisingly, you can see here that the muscle score got better again. So changing target in this complex field got an amelioration of the disease. This is, I think, very relevant also for understanding the biology that is behind the CAR T cell activity. Moreover, in autoimmune disorder, the field is rapidly moving. We have some reports of allogeneic CAR T cells. Of course, the role of CAR T cells is different. We need some immunomodulation more than target. So probably more than in cancer, we can have we can tolerate less survival, less benefit. And these reports published in Cell last year, reports on the allogeneic CAR T cells for 3 patients, 2 with systemic sclerosis, 1 with immune-mediated necrotizing myositis. The authors had a complex gene engineer to avoid GVHD, and again, some clinical success was reported. There is also space in autoimmune disorder for bispecific antibodies. The competition with CAR T cells, it's very similar to the one we're looking at in lymphoma and leukemia. We don't have time to go through this, but of course, by mediating B-cell depletion, they could be very, very effective also for autoimmune disorder, just similar to CAR T cells. And moving beyond, we have some preclinical experience also with CAR T regulatory cells. So we are engineer CAR T cells, regulatory T cells, in order to recognize the autoimmunity sites, the specific autoimmunity niche, expand, and have some immunotolerance activity against autoimmune disorders. This work is very nice work published in 2044 in Nature Communication by Matteo Doglio, and it really shows how in a preclinical model, CAR T regulatory can give an immunosuppressive state in order to counteract autoimmunity in this disorder. It's a lupus model. For this, we have now some guidelines that have been recently published, led by Dr. Raffaella Greco, from which we are positioning CAR T cells in autoimmune disorder in the field, since we have a lot of experience that is now ongoing. And we are launching also with the Ssbmt a survey in order to assess the real-world data of CAR T in autoimmune disorder. If you're interested, please contact me. I am one of the investigators in this study, and we're launching the survey in these days, so we are exploring how the field is moving. So just to sum up this first part, CAR T cells showed incredible benefit in the field of cancer. We are now seeing that they are able also to counteract autoimmunity. We have a lot of conditions. We really want to point out how the efficacy of this treatment would be in the long term. We have a lot of challenges. Of course, we have to assess if they work, if the disease activity is sustaining during time. And of course, we really want to look at toxicity more in detail and in longer follow-up. The elephant in the room here is second malignancies. Of course, we're dealing with patients without cancer. We're dealing with patients with autoimmune disorders. So we really want to look well at the data of second malignancy. And for this, we need time to assess the efficacy of those treatments. The final part of the presentation is regarding the other cellular therapies that we've been knowing in the field since now 25 years or 13 years, which is autologous and transplantation in autoimmune disorders. You can see that the trend in Europe has grown up for at least until the pandemic. Then we had a stop due to the pandemic, but we are aware that numbers are still growing. You know that transplantation, the main indication are for multiple sclerosis and systemic sclerosis, which are the main indication in which we showed some activity in these diseases. These are the main indications, so we are aware that transplantation is an active therapy for autoimmune disorders with a lot of benefit reported. I really want to mention that we have indeed a lot of works and a long follow-up of this patient. These are some works that highlights the therapeutic implication of transplant. I want to report the presentation by Kirill Girzov at the 51 annual meeting of the Ssbmt in Florence. He was presented at the Presidential Symposium, the reports of the larger cohort of patients with autoimmune disorder, more than 500 patients with 90 months, so a very long follow-up for this condition, highlighting that we have very long-term follow-up data in different CAR T cells. And just to conclude, I want to briefly report one of the experience we have with transplantation and rare neurological diseases in our hospital. We have the two cases of patients with neuromyelitis optica. Neuromyelitis optica is a rare neurological condition different from multiple sclerosis, which generally presents with optic neuritis and other neurological symptoms. It's a very progressive disease with few treatments available, and very importantly, it has a pathognomonic but also pathological autoantibodies, which is anti-aquaporin 4 antibody. We had two patients that were treated in our center 15 and 16 years ago, so really long follow-up. There were two patients with very aggressive disease. The first one, a short course of disease. The second one, the longer one. They were positive with autoantibodies. And the both of two already underwent autologous stem cell transplantation. So we really did not have any other option for those patients. So we decided bravely, because it was one of the first reports, to treat them with CAR T cells, with allogeneic stem cell transplantation. And we indeed treated them with transplantation. The two patients, okay, yeah, I'll be brief for the final part. So we treat them with transplant. We had a matched related donor and an unrelated donor from the registry from the second patient, and we use peripheral blood stem cells. This is the course of the two patients. You can see that the first one is now stably without new lesion after 16 years after transplantation. You can see the MRI images, which are completely negative for new lesions. The second patient had a similar course of disease, so really high efficacy treatment in a very hard to treat disease setting. We studied the immune reconstitution. We saw that the patient had a normal immune reconstitution in the long-term follow-up after treatment, and we were able to document an expansion of T regulatory cells. So really, we want to point out whether these T regulatory cells are the one that mediates the benefit of the long-term follow-up of the patient treated with stem cell transplantation for rare autoimmune disorders. Now the patients are well. They are indeed 16 and 15 years after follow-up. They have full donor chimerism. One of the two patients also became father of children, and the EDSS lowered from 8. He was to wheelchair to 2. He's now able to walk and have a normal life. Similar happened also to the second patient. Just to conclude, this is a summarization of the different effects that we have from CAR T cells and stem cell transplantation. Of course, we have longer follow-up for stem cell transplantation, shorter for CAR T cells. We really know well the toxicity associated with hematopoietic stem cell transplantation. We really want to assess in the long term what happens in patients treated with CAR T cells. As I was mentioning, they seem to be very effective. We really want to look better at toxicity rates, in particular at second malignancy. And for this, the registry and other entities are very important, and they play a key role in the study, in post-authorization studies. So I really want to thank all the team in San Raffaele, especially my mentors, and of course the Ssbmt for giving me the possibility to be here today, and you for the attention. I will be glad to take the question if you have it.
Thank you, Dr. Georgi, for the outstanding presentation. We'll leave the questions to the end. Dr. Ala, my colleague, will introduce the next speaker.
Morning, everybody. It's my pleasure to introduce a dear colleague of mine, Dr. Wael Al-Nizi. He's a highly experienced hematologist and the program director of hematology fellowship program at King Fahd Specialist Hospital, Dammam. Dr. Wael obtained the Saudi Board of Hematology and continued his further training in allogeneic stem cell transplant in University of Toronto, Princess Margaret. Dr. Wael Al-Nizi will be talking to us about the role of allogeneic stem cell transplant in PNH in the era of complement inhibitors. Dr. Wael.
Thank you, Ala, for the nice, kind introduction. Good morning, everyone. Welcome to Eastern Province. I hope that you enjoyed it here and have a good time in Al-Khobar. So in the next 25 minutes, I'm going to elaborate about the updates of allogeneic stem cell transplantation in PNH. So my presentation is divided in three parts. The first part is briefly about the PNH as a pathogenesis, pathophysiology. Then we'll go briefly on the complement inhibitor, and then finally about the update of transplantation in PNH. So PNH is a rare clonal hematopoietic stem cell disorder that 40 to 50% of PNH clone are presented in aplastic anemia, and 25% of patients with aplastic anemia had PNH clone. This leads to also to an uncontrolled complement activation and thrombosis and bone marrow failure following the clone expansion. So that was started very, very long time ago, up to 1882, when Dr. Paul Strobing, a German physician, who described the red blood cell breakdown, but unfortunately his effort was not appreciated, and it was not known as Strobing syndrome, for example. And this until 1911, between 1911 and 1928, the two physicians or scientists, Marchevava and Michelli syndrome, and that's what's called the PNH syndrome at that time. However, this continued to be understanding that disease process until the 1930s, when Louis Belmore, Jordan, and Ham test was introduced, when the blood sensed to the acidic environment, the red blood cell breakdown. However, the Ham test was giving a lot from false positive results and other cases other than the PNH. Then between 1960s and 1990s, all the progress and the development of understanding the alternative pathway complex, the decay accelerated factor, and membrane inhibitory reactive lysis, and flow cytometry, that was progressed, and the technology of the flow cytometry was improved over the time. Until then, we understand the disease, we understand how to diagnose, but until 2007, the diagnosis of PNH, the treatment of PNH was only supportive care. And 2005, British Commission of Standard Hematology mentioned in the last paragraph, there is a clinical trial about C5 monoclonal antibody, and this is what happened. The first C5 monoclonal antibody was introduced, as we know, as eculizumab. So the PNH is a somatic mutation of the BIGA gene that leads to failure of synthesized GBI anchor protein in hematopoietic stem cells, and this will lead to loss of CD55, which is DAF, and the CD59, which is MIRL, on the surface of red erythrocytes. That leads to intravascular hemolysis. And hypercoagulable state is also contributed either because of degree of hemolysis or platelet activation, procoagulable particles from the GBI deficient erythrocytes. So, don't know how to point, yeah, okay. So a normal process, the complement pathway, when it's gets activated, it's and the red blood cells are protected by these anchor protein and the surface of red blood cells. However, once you lose it, the membrane activating complex attacks the red blood cells and causes the lyzed red blood cells. That's simply how the PNH intravascular hemolysis happens. So that's chronic hemolytic anemia occurs, dark stain urine because of the free hemoglobin in the urine, and some symptoms related to the nitric oxide depletion. And it is in form of bone, muscle pain, esophageal spasm, and fatigue, irrespective to the degree of hemolysis. So the flow cytometry is the gold standard of diagnosing the PNH by recognizing the deficiency or absence of the CD55 or CD59 and fluorescent labeled aerosol, which is bacterial toxin that binds with high affinity selectively to the GBI anchor protein. So it has a very high sensitive rate. And this is not just making it the gold standard for PNH diagnosis, but also it's important to assess the clonal size and the follow-up and monitor for the clonal expansion. So this is the first part. The second part is about the complement inhibitor. This is the study that relates to the first C5 inhibitor approval. It was published in New England Journal of Medicine back in 2006, assessing the eculizumab and paroxysmal nocturnal hemoglobinuria, or PNH for short. And this is what happened. From placebo to eculizumab, the LDH, which is a hemolytic parameter, it's going down to the almost nearly normal level. And the red blood cells recovery was improved with eculizumab and over the placebo group. And this eventually eventually leads to the list of transfusion support in the eculizumab group versus the placebo group. This is a study I think everybody knows about them when it was approved as a treatment for PNH. But in the long-term run in 2011, in Blood, it was published that showing that, sorry. Oh. Yes, okay. So, as you can see, there's overall survival for all patients with eculizumab almost nearly to the normal population after 5 years of study observation. And then they subcategorized them, and they found that patients who are older than 70 years old, they have inferior outcome than patients who are younger than 70 years old. And there is a very clear difference in survival between the eculizumab and the pre-eculizumab era. Then after that, in 2018, you can see the ravulizumab with the ALXN210 study, and this was published in Blood Advance in 2018. This ravulizumab is another C5 inhibitor, but with a prolonged or extended half-life. The eculizumab has a half-life of 8 days to 15 days, but in ravulizumab is up to 52 days. And this showed that a steady state or controlling the LDH in the trial itself. But when they try in the 301 study, when they're comparing the ravulizumab versus eculizumab, because of the extended half-life, the ravulizumab has shown a benefit in transfusion avoidance, normalization of the LDH, and also in controlling the symptoms and the breakthrough hemolysis and the hemoglobin level as well. Other complement inhibitors are the market. C5 is a terminal complement inhibitor. Now these are the proximal inhibitors. In the PNH, when you continue to give C5 inhibitors, then another mechanism by the proximal complex pathway causing the extravascular hemolysis. And that's why the newer drugs and newer medications are coming and came to the market, such as C3 inhibitor, like pegcetacoplan, iptacopan is a factor B inhibitor, factor D inhibitor like fembricopan or PCBXC9930, and these can be given as solely or in combination with C5 inhibitor. So this is a summarize of the complex pathway. Here is a classical pathway, a lectin pathway, and the alternative pathway. This is a terminal, the proximal pathway, and this is the terminal pathway. This in form of C5. And now you see the eculizumab, ravulizumab, crovalimab. These are a good example as a target of C5 inhibitors. While C3, we have the pegcetacoplan as a proximal inhibitor, factor B, iptacopan, or factor D, daracopan, or fembricopan, as mentioned in the previous slide. So now we'll go to the third part, which is transplant and PNH. So this is a large observation study from French group. It was published in Hematologica in November 2012 by Dr. Delator and colleagues. And the number of patients was 211 patients with a median age of 30 years old, and with almost identical distribution between classical PNH and the PNH in a setting of a bone marrow disorder. The indication of transplant was 62% in patients with aplastic anemia, and the patients with the classical PNH was 70%, and 25% were in patients with thrombosis. 65% of patients were actually the identical sibling, and the source of the stem cells, majority of patients were 64% from bone marrow and 34% from the peripheral blood stem cells. And the conditioning regimen that was all equal between cyclophosphamide and busulfan, cyclophosphamide TBI, cyclophosphamide ATG, and fludarabine-based regimen. GVHD prophylaxis was cyclosporin and methotrexate in 73% of patients. Now, let's see the survival rate. The overall survival in these patients for 5 years was 68%. But when they subcategorize these patients between the recurrent hemolytic crisis, aplastic anemia, and thrombotic event, as you can see here, the 5 years over survival in recurrent hemolytic crisis was 86%, and the aplastic anemia was 69%, while thrombotic patient with history of thrombosis was 54%. That means the patient with thrombosis, they are at risk for to have an inferior outcome. However, between the related and non-related donors, actually match was not different between the two groups. A second study is also from France, from Valet and a group, and which was published in 2018 in Hematologica. So 21 patients with PNH, 13 patients with aplastic anemia and PNH, 6 patients with transfused classical PNH, and 2 patients with non-transfused classical PNH. As you can see here, with different, all of them that non-myeloablative, except one case in the classical PNH, with only 3 patients who are mismatch unrelated donor. The rest are match related and match unrelated donor, with almost equal between the peripheral blood and bone marrow, and the cyclosporin mainly, as was the GVHD prophylaxis, either with methotrexate or MMF or cyclosporin alone. The grade 4 GVHD, acute GVHD, was found in 2 patients with aplastic anemia and 2 patients also in transfused classical PNH. The deaths happened in 6 patients from the 21, and the majority of patients, main reason for deaths were the infection. So, and the overall survival at 6 years was 67.7%. The third study is from Fred Hutchison. It was published in BMT Journal in 2019. They calculated 55 patients from 1970 to 2015. 17 patients were classical PNH, and 38 patients were PNH with bone marrow disorder. 6 patients from the 55 patients that received eculizumab and acute grade 2 to 4 acute GVHD was found in 61.8% of patients, while a severe acute GVHD was found in 12.7%, and chronic GVHD was found in 57.8%. The overall survival, it showed as 70% on the whole group, but there was no difference between the condition regimen, whether RIC or MAC, pulmonary disorder, or classical PNH. And the causes of death were infection, with 47% of the dead patients, and hemorrhage 21%, and only 5.3% from other causes. Allah Akbar. So the next study that I'm going to share with you is a large study from the Polish adult leukemia group, which was also published in a BMT journal. We're studying the 78 patients from the transplanted between 2012 to 2016, 51 patients with PNH with bone marrow failure, and 27% with classical PNH. Median time from diagnosis to allotransplant was 12 months. 94% of patients were heading for RIC conditioning, and 66% used the triosulfan. I want to remark that there was no eculizumab was given in these patients, despite that this is even up to 2016. And the reason for that is the accessibility and availability of the eculizumab in Poland. The 3-year overall survival was 88.9% in classical PNH and 85.1% in PNH with bone marrow failure. And the 3-year overall survival without thrombosis was 50% and 92% in classical PNH. However, this was not statistically significant despite the difference between the percentages. And while the PNH with bone marrow failure was 83.3% and 85.3% in patients without thrombosis. The grade 2 to 4 acute GVHD was found in 23%. 1-year incidence of chronic GVHD was 10.8% in bone marrow failure with the PNH, and only 3.7% in patients with classical PNH. As you can see in this Kaplan-Meier curve, that there is no difference between the type of or category of the PNH, either a BMF or bone marrow failure or classic PNH. Now we'll go to the main event. This is an abstract that was published in ASH last year, a multi-center study of a retrospective analysis with a collaboration between the Ssbmt and the severe aplastic anemia walking study in the period from 2011 to 2020. And these are the endpoints that they use: overall survival, disease-free survival, event-free survival, neutrophil and platelet recovery, primary and secondary graft failure, grade 2 to 4 acute GVHD and severe GVHD, chronic GVHD with limited or extensive, and the lastly is the GVHD-related relapse-free survival. So, this means it's a larger number than the French study that I mentioned, the first study for addressing the transplant, which was published in 2012. So it was 259 patients from 125 centers who underwent a stem cell transplant for PNH between the 2011 and 2020. As you can see here, that the distribution was equal between female and male gender, the younger population, and the time between diagnosis and the allotransplant was median with 10 months. The PNH category was almost equal between both groups, and the clinical representation of transplant was also equal between both groups. And the majority of the patients were match-related donor, with 47.5% match sibling donor, and 37.1% with match-unrelated donor, and 12.7% with mismatch unrelated donor. The source was also equal between both groups, but for the conditioning regimen, the RIC was a majority with 78.2%, and the myeloablative was 21.8%. The GVHD prophylaxis used with ATG 69.2%, and the calcium inhibitor was 14.6%, alemtuzumab was 11.5%, and the PTY only 4.7%. The group, the study, they sent a questionnaire to the centers about the details of the PNH treatment. And they've received 147 reported patients about eculizumab. Yes, 42 patients, and no, 105 patients. So, In terms of engraftment, 87% of patients achieved neutrophil engraftment by day 28. 75% of patients achieved platelet engraftment by day 40. And in terms of the percentages of graft failure, 4% had a primary graft failure and 5% had secondary graft failure by 3 years' time. In terms of acute GVHD, between the 2 to 4 and the severe GVHD, 13% of patients had acute acute GVHD between 2 to 4, and 6% they had the severe GVHD. While in the chronic GVHD, 7% had limited chronic graft-versus-host by 3 years' time, and only 4% had extensive chronic GVHD. So an overall survival, which was 82% in 3 years' time, and the GVHD relapse-free survival was 74% in 3 years' time. What about the age differences and the donor differences? The age differences, it was observed that younger patients, the patients who were younger than 40 years old, they had a better outcome with 84 and 86% at 3 years' time respectively, and who's older than 40 years old has 70%, overall survival was 70% 3 year time. While the donor type, match-related or match-unrelated, match-sibling or match-unrelated, so they have better outcome with 87% and 82% and overall survival at 3 years' time. But in mismatched, it was only 65, despite that the number are less than the match-sibling and match-unrelated donors. What about the conditioning regimen? We know that triosulfan is widely used and popular in the PNH. So triosulfan it showed a 95% at 3 years' time, but it was not different from all other conditioning regimen, especially the cyclophosphamide alone or fluci or busulfan based. And the GVHD prophylaxis, there was no difference between calcineurin urine inhibitor and the ATG and elotuzumab based group. What about the PNH subcategory? Okay, so there is no difference between the PNH subcategory, either classical or aplastic anemia with 88 versus 84%, and the clinical presentation as well between hemolysis, thrombosis, or aplastic anemia without hemolysis. And the thrombosis, this is an important question to be addressed. Remember the French study in the 2012, we said that thrombosis had an inferior outcome. However, in this study, it didn't show any difference between that the patient has a history of thrombosis or not. I think maybe because of the improvement and advancement of the conditioning regimens in patients with transplant. Now, the last part in this, from this abstract is the eculizumab. So 1 of 5 patients did not receive eculizumab, and the reason for that is 46.7%. The treatment is not available, and 36.2% was not indicated. While the patients who were on eculizumab were 43% not discontinued before the transplant, and 54% was discontinued because of the major reason for that was lack of benefit. So, because of inaccessibility and availability, as mentioned earlier, and the previous slide, that means there is no difference in overall survival in both groups. However, this needs to be addressed more and more in the near future. So that they conclude that the outcomes of PNH patients receiving allogeneic stem cell transplant has improved in the last decade with increasing overall survival. Except age and donor type, they could not identify any patient transplant-related factors associated with a better outcome. Even disease-related factors, subcategory or the clinical presentation, even thrombosis was not associated with the survival difference, but they could not prove the impact of eculizumab because of the availability and accessibility of the treatment and Ssbmt centers that participated in the study. Complement inhibitor remained the standard of care for hemolytic PNH patients. However, allogeneic stem cell transplant can be considered an alternative option in case of non-availability of complement inhibitors or a specific clinical setting. So in summary, treatment of PNH has significantly advanced over the past 2 decades. Complement inhibitors remain the standard of care for classical PNH. Allogeneic stem cell transplant use in classical PNH has declined significantly since the introduction of complement inhibitors. Hematopoietic stem cell transplant is indicated in patients with bone marrow failure or those refractory to complement inhibitors. Treosulfan fludarabine-based conditioning regimen are a viable alternative to busulfan-based regimens in classical PNH. The use of peri-transplant C5 inhibitors may be beneficial in reducing complement-mediating complication in form of intravascular hemolysis. And here I conclude, and I would like to thank you all for your attention.
Thank you very much, Dr. Wael, for this very rich presentation. We'll open the floor for questions for both Dr. Wael and Dr. Arufino. Maybe I'll start with the first question to Dr. Arufino. So it's very interesting to see how the CAR T cells are moving to treat benign diseases. Now it's very interesting to see that the B cell depletion was profound, and that's probably resulted in less incidence of CRS and ICANS. But how did not translate into high risk of infections? Were those patients, very well covered, or what happened there?
Okay. So I think this is a very relevant question. We know that in the first phase of CAR T cells, they do not have higher impact of infections. We do not know in long term what happens. So as I was trying to point out, we really need more robust data to have the real numbers. We have few patients. I think that those patients are patients that do not receive chemotherapy before, differently from the others. So in that sense, probably they have different bone marrow involvement, different pre-treatment situation if compared to our CAR T cell patient, which are generally pre-treated with leukemia or lymphoma. I think this changes a lot. A part of this trial have also the immunoglobulin supplementation within the protocols they established. So this is another point point important, I think. So they go towards a B-cell aplasia, so they have higher risk of infection. We saw that a part of those patients have an B-cell immune reconstitution, so not all of them have continued B-cell aplasia. They can reconstitute B cells after treatment. Whether this is associated with disease relapse is not known, but at the moment it doesn't seem so. It seems that B cells goes up again and they are not the pathological one. This is something that we saw also in transplantation patients.
Thank you very much.
Thank you.
Please go ahead.
Thank you so much, both speakers. Giorgio, thank you for a very informative lecture. Well done. I have two questions. Are there any guidelines about when to use CAR and stem cell in autoimmune disease? We know that these are not a first-line sort of management for autoimmune disease. And for what disease? You showed MS, for example. And MS is not a B-cell-driven disease, so you would expect that CAR will not work for that. My second question, so the first one is about, are there guidelines when and for which disease to use CAR and the stem cell? And the second question, why do you think rituximab does not deplete B cells in lymph nodes?
Okay, sorry, I'm not hearing perfectly. I think the first question is when should we use
Are there guidelines, international guidelines, when to use CAR and stem cell in autoimmune diseases?
Okay. So which indication
and
you mean?
Which indication? Yeah.
Okay. Sorry, it's not functioning very well.
I'm sorry, it's my question wasn't very clear.
Okay. No, I got it. So we have to see, we have some recommendations that are already established for transplantation. For instance, in multiple sclerosis, we know that relapsing and remitting patients may benefit of transplantation, in particular if they fail previous treatments. I think that at the moment we still have to currently understand what are the right indication for CAR T cells. For instance, probably progressive multiple sclerosis is not being very effective in this treatment. So we really need to point out which is the right moment in the therapeutic algorithm for patients with autoimmune disorder to point out when is the right timing for CAR T cells. In stem cell transplantation, we know it better since we've been using it for a longer time. So that's the first part. The second part, I think that this is the peculiarity of CAR T cells. So they are lymphocytes. They can go in the lymph nodes. they are not only available in blood, circulating blood, but they can go there. And this is the difference. This is why I think they could be better also to be specific, in particularly because they go in the lymph nodes, they go in the tissue in which B cells are there. I think this is relevant also for cancer. So probably the activity of the peripheral and anatomic specific activity could be really a trigger of functionality of CAR T cells. And I really suggest you to go through that paper because it really describes well how CAR T cells go in the tissue. So thank you for the question. It's very relevant.
Thank you very much. I'm a neurologist, so I feel like a fish out of water here. But I came to listen to the latest on the use of CAR in autoimmune disease. So I'd like to give a perspective, and we work very closely with Dr. Wael and colleagues in our hospital. I think the challenge with autoimmune disease is that it's, even if you pick one autoimmune disease, it could be heterogeneous pathologically compared to when you speak about treating lymphoma. And there is a very big difference in the clinical aspect. In lymphomas, you have precision diagnosis from a cellular perspective, whereas in a condition like MS, everything we know about the pathology is either by, for some reason, we did a biopsy or post-mortem. So it's very challenging. And to the colleague's question about the use of B-cell therapy, in the history of MS, B-cell therapy came late, and now it's mainstream. And the hope for clinicians and patients is to have something that's a cure rather than something that you would have to redose. And I think what you said about patient selection is crucial. And I would recommend that maybe we should work together with Wael and everyone to produce an explainer for patients. Because maybe we need to be more aggressive and start earlier, because that's where the difference would be realized. Similar to, I mean, I think we will be hearing about hematopoietic stem cell transplant in MS. Patient selection is critical. And the selection process is not so easy in real world. And I appreciate what you said about registries. Is in real world, it's a whole process, especially now that we have so many options. And so even from a medical legal perspective, we need to be very clear and aggressive. I think it's the two sides, and I don't know if you have any comments on that from your experience in Italy.
Okay, thank you. I really want to thank you, and I appreciate the presence of a neurologist in here. I totally agree with what you said. I really think that the outcomes of transplantation of cellular therapies are totally dependent of patient selection, because of course selecting the right patient is saying that we are offering him the best possible therapy. My personal experience, the part I love the most of this field is that we have to interact with neurologists, with rheumatologists, and I really think that is the multidisciplinarity of these aspects are the one that really gets toward the better treatment options for patients, since we hematologists are, let's say, offering that treatment, but of course the disease activity evaluation, the impact on patient quality of life, which is central, must be assessed together. So what we do in our center, we have a multidisciplinary unit team, and we see patient with the involvement of other specialists. And I really think this is crucial, because the indication, the right timing of disease must be selected by the expert of this disease. So I really think that moving the only option to move these fields abroad is to have multidisciplinary team and multidisciplinary unit in order to really assess the benefit, but also the toxicity, because we are in a timing in which we really have to dissect the toxicities. Because, okay, we are looking at some very nice data of preliminary efficacy, but we have less than 1 year of follow-up. So you have longer follow-up of other treatments, and we really want to compare. The other aspect is that I think that we will need randomized trials. This is a key aspect. Of course, we are before that, but I think that in the next years, and one of the trials that I reported are trials that compare treatments. So, but thank you for your point of view, which is very important, I think.
Commenting the previous comment. I think we know, looking back to the history, initially when we get the rituximab and we get the JAK inhibitors, nowadays the non-hematology service, like rheumatology and in dermatology, they are using those agents. Example, dermatology, they have almost 9 molecule JAK inhibitor, they use it. The dermatologists, they are using it. And they are using rituximab. Most of it actually, it's not based in real, very good evidence. And even if you look to the guideline to the American Society of Hematology, there is many indication for use of those immunomodulating without good trials. It's really unfortunate. Ideally, we should have good trials, and we are having tons and tons of illnesses and serious illnesses, like in the neurology. And we have this tool, which is immune modulator, and I'm quite sure that it's coming in the future. And maybe in one day that our neurology colleague, they will use CAR-T more than us. Okay. Question to Dr. Weil. I really enjoy your talk, as usual. So I cannot understand, especially at the molecular level, why some of the BNH patients, they progress to aplastic anemia, although we know that the mutation is in the PICA, and this is only not expressed in the red blood cells. It's also expressed in the stem cells, and maybe the antibody is eradicating everything. And given the cost of the medical treatment, and we have the alternative, which is the bone marrow transplant, what is the initial choice, the first choice, if I refer one of my patients to you, he is BNH who is in need for treatment? Is it stem cell, molecular, or you will guide him based in that he is having good chance that he will progress to aplastic anemia?
Okay. So on regard why the patient has aplastic anemia or the damaging of the hematopoietic stem cell, is according to the degree of the deficiency of the anchor proteins that are available in the hematopoietic stem cells. However, this can helps the cells to survive. But the problem is that the classical BNH is a totally different story. You just, all the problems that you have in the peripheral blood, especially the red blood cells. The red blood cells, they don't have the proteins in the surface, and then you see the hemolysis. Now, which one I will choose? I will see the category of the patient. If the patient is aplastic anemia, the transplant is the thing that you will go. But if the patient has no aplastic anemia, preserved cells in the peripheral blood, but you see hemolysis and maybe thrombosis, then you can start with a complement inhibitor at this point. And where the patient does stand for transplant in this particular patient, it's mentioned there in their abstract if the patient is in a specific clinical setting. And I think that means the refractory to multiple lines of treatment. The terminal inhibitor, then proximal inhibitor, and if the patient is refractory, then the transplant is the only thing to go at this particular situation. Yeah.
According to the prices here in the kingdom?
Well, we know the C5 inhibitors are expensive. We have to admit that. But now with the extended half-life, which is pravolizumab, I think if you think it in the long term, it is cost effective. As you can see, the survival of these patients, almost 90%, almost similar to this normal population. So why want to jeopardize the patient health with transplant, the risk of infection, et cetera, although that I'm a transplanter, but I don't recommend at this particular point. But in the plastic anemia, yeah, it's very clear answer. You go for transplant. No point for giving complement inhibitors at this in this setting.
If there is no question, I have one last question to Dr. Giorgio. So in your case, in the case series that you present from that is published in BMJ, there is one patient only who developed ICANS, and that same patient developed CRS. So is there any characteristics related to that patient, like he's an older age or his disease is active? And the other question, you mentioned that there is late immune effector, LICATs or something like that, related to the CAR-T in autoimmune disease. Why don't we see that in CAR-T due to hematological malignancy? Is it mainly immune process, or what's the exact mechanism?
Okay, I think I'll start from the second part. I think it's a really relevant question. And I really think this is also giving us some insights on the biology of the underlying disease. So we're, let's say, understanding what's happening in the disease with the treatment effects, because it's peculiar that we have some inflammation in the sites in which we could expect autoreactivity. So probably in these tissues we have some pathological B cells that somehow the CAR T cells are counteracting. I think, but this is just speculation, this is something that could happen also in the toxicity of a patient with hematological malignancies. Probably the activation, the ICANS, the CRS can be mediated to the presence of peculiar pathological B cells in some tissues. So the difference is relevant. Of course, I would expect also some toxicity like LICATs in patients that have like lymphoma, since they are generally inflammation mediated, so it's not that they are absent. But they are peculiar of this subset of patients, so I think that could be an explanation. So that patient have higher levels of pathological B cells in some particular anatomical niche, and CAR-T goes there and they inflame that, and probably they mediate also the long-term results. So this is trying to speculate on biology with treatment response, so it's not so fair, but I would say something like this. And the first part, the toxicity were CRS G1, ICANS G1, and it was treated with steroid. I'm not sure that they describe some peculiar characteristic. I have to go through the paper to tell you correctly this, but they describe it as a mild toxicity that with steroid treatment was solved rapidly, so it was not a serious adverse event. Thank you very much for the question.
Thank you very much for this great discussion. With that, we'll conclude this session. Thank you.
Thank you.
Session. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So we'll start our afternoon session. And we'll start with the first speaker. It's a pleasure to introduce my colleague, Dr. Mohsen Al-Zahrani, who is a consultant adult hematology and stem cell transplant and the head division of adult hematology and stem cell transplant at ancillary therapy at King Abdulaziz Medical City in Riyadh. Dr. Mohsen Al-Zahrani did his hematology fellowship in Dalhousie, Halifax, Canada, followed by another 2 years of fellowship in hematopoietic stem cell transplant and lymphoma in Halifax, Canada. Dr. Mohsen Al-Zahrani is going to present a very interesting topic about a local experience of transplant in multiple sclerosis. Dr. Mohsen, welcome. The floor is yours.
Thank you, Dr. Reynas, for the nice introduction, and thank you for the scientific committee for inviting me to present about transplant for multiple sclerosis, a project that's going slow, but hopefully that soon will launch fast more cases to undergo transplant. So before we start, we have to talk about Dr. Riccardo Saccardi, who's one of the pioneers for autologous transplant for multiple sclerosis, who died in 2024, and he was the chair of the Autoimmune Disorders Working Party in the Ssbmt from 2004 to 2008. He led many clinical trials, writing guidelines, many scientific committees. He has a lot of contribution to the field of the autologous transplant for multiple sclerosis. And he led the JASI committee under the Ssbmt for 4 years, so he had a lot of contribution to the quality development. He is originally from Florence, where was the last Ssbmt in 2025 held. And also he was involved in the initial Ssbmt meeting in, I think it was 2008 in Florence, Italy. So in the last meeting, it was recognition of his dedication to the transplant for multiple sclerosis. So multiple sclerosis is autoimmune disorders that affect the brain by causing demyelination and neuronal loss. And there are many disease-modifying agents that are very effective, but also stem cell transplant, especially autologous stem cell transplant, is one of the important therapies for this disease for the last 20 or 25 years. And high-dose immunosuppressive therapy with autologous transplant may induce sustained remission in comparison to other disease-modifying agents. This was taken with permission from Autoimmune Disorders Working Party. This is the last update about transplant activity for autoimmune disorders. As you see, more than 4,600 patients underwent stem cell transplant as part of the Ssbmt registries, and numbers are increasing with time. And these are the different diseases with different indications for stem cell transplant. The commonest one is, as you see, multiple sclerosis. More than 2,500 patients reported to the Ssbmt registry, followed by other diseases. The second most is the systemic sclerosis. So these two diseases, multiple sclerosis and systemic sclerosis, the autologous transplant is the standard of care for these diseases. And these are the activities based on the countries. Some countries are very active, like United Kingdom, Italy, Germany. And if you see down there in the tail, Saudi Arabia with some activities for transplant for autoimmune disorders. Multiple sclerosis is the commonest disease undergoing autologous transplant, and year by year, the number of transplant is increasing for multiple sclerosis. Again, some countries, they are more interested for transplant for multiple sclerosis. Saudi Arabia reported 11 cases. So transplant for multiple sclerosis is autologous transplant. Basically, we see the patient, if he fits the criteria, he undergo eligibility and workup, and if he is fit, he will undergo collection of the stem cells by cyclophosphamide plus GCSF. Then after that, the pre-transplant workup will be done. Then the patient will be admitted for the procedure, where he will receive the conditioning regimen and then reinfusion of the stem cells, and then a period of neutropenia, usually less than 2 weeks, then quick recovery and discharge from the hospital, followed by long-term follow-up and maybe physiotherapy if needed. So how does it work? Basically, it causes the transplant here causes immune resetting. When we give the high-dose chemotherapy, we will ablate all the hematopoietic stem cells and autoreactive lymphoid cells. Then we reinfuse the new stem cells that will recover a new immune system, naive T cells and B cells that will not cause autoimmune activity against the neurons. And this is how it works. Some definitions important for us as hematologists to know, because these are used by our colleagues in the neurology, but it is used in selection for patients for autologous transplant. This score, which is Expanded Disability Status Scale, EDSS score, is used as a screening patient to be eligible for transplant. For us as transplanter, we use ECOG, Karnofsky, but this is used for multiple sclerosis. So it's from 0 normal until 10 or 9 completely dependent. So most of the guidelines, they said patient can be included in transplant up to the 6 or 6.5. Before that, after that, like patient wheelchair bound or bed bound, he is not eligible for transplant. Another definition, NIDA, or no evidence of disease activity. So post-transplant, we have to assess for relapses clinically and by radiologically by doing MRI. But also in this NIDA, so they depend on clinical assessment, no relapse, no disability progression, and no MRI activity. And this is a common endpoint for many of the clinical trials. This is a retrospective study done by one of the pioneers of transplant for multiple sclerosis, Richard Perth from Chicago. As you see, the care for autologous transplant compared to disease-modifying therapies is outstanding significantly in favor of transplant, but this is a retrospective study. Also, regarding the NIDA, you see the effective transplant is much better than in preventing relapses compared to other disease-modifying therapies. And also in this publication, they collected all the studies using very effective disease-modifying agents and autologous transplant. And as you see, the proportion of the patient who had relapses below, 80% or more than 90% of patients who underwent transplant did not have any relapses. Compared to those with disease-modifying agent, majority will have relapses. So very clear here, the effect of transplant is much better than other disease-modifying therapies. But despite this is unfortunately retrospective studies or collection of studies. Based on this, we don't receive a lot of referrals for patients to undergo autologous transplant. The transplant for MS is a safe procedure. As you see, this is a large number of patients done also by Dr. Richard Perth. 150 patients underwent transplant. Transplant-related mortality is 0. So it is a very safe procedure. Fortunately, now there are multiple randomized studies comparing disease-modifying therapies, very effective disease-modifying therapies, to autologous transplant. And I think the result of these studies will change the algorithm of management of these patients. I'm sure it will be positive in favor of transplant, and based on this will change the pathway and the guideline for referring patient for transplant earlier. So this is when we want to select patient for transplant, first thing we have to take in consideration the neurological variables. As you see in the scale up, If it is in the green, the patient is recommended to undergo transplant. If it is in the red, it's not recommended. In the yellow, it's uncertain. So the variables here, if the age is less than 45, this is a good candidate. Disease duration less than 10 years, good candidate. Focal inflammation by MRI, multiple inflammation or high inflammation, this is a good candidate compared to those who had MRI with no active inflammatory lesions. EDS score less than 4 compared to more than 6. Cognitive impairment, no versus major cognitive impairment. And the type of the MS. The relapsing remitting, based on many studies, they are the one who benefit from autologous transplant compared to those who had secondary progressive or primary progressive. Subsequently, those in the green scale, so if they fail one highly effective disease-modifying therapies, they are eligible to undergo autologous transplant. While those in the yellow or the red can be considered if the risk of the procedure is low, meaning that the patient doesn't have comorbidities to make him having a high risk of mortality or morbidity. Plus EDS score is increasing despite treatment, plus there are clinical or MRI inflammatory activities within the past 12 months. Regarding the hematologic variables, so if there is no medical comorbidities or no infections, good performance status, and the patient already has family planning or has children, this will be a good candidate compared to those who have multiple comorbidities like renal, liver, or other comorbidities, or active infection or poor performance status. And we see here in the table more description of the previous pathway. So those who are suitable for transplant, younger than 45, disease duration less than 10 years, relapsing remitting, EDS score less than 6, capacity to give informed consent, and markers of disease aggressiveness. Regarding the type of the conditioning regimens, as you know, there are myeloablative, there is reduced intensity, and non-myeloablative. Here we need myeloablative or strong immunoablative regimens. So we have the high intensity regimen like CyTBI, then we have BEAM, then we have the intermediate or lymphoablative or non-myeloablative cyclophosphamide and ATG. And these are the type of conditioning regimen reported to the Ssbmt registry up to March 2016. You see the commonest regimen here was BEAM, 58%. With some patients, the second one is cyclophosphamide ATG. But we know BEAM is really myeloablative regimen, and the patient need to be very fit to undergo BEAM. Here also showing the type of the conditioning regimen based if there is increased myeloablation or increased lymphoablation. So the Canadian protocols like BEAM or CyTBI, they are myeloablative and lymphoablative. HALT MS is also BEAM. And MIST protocol, which is cyclophosphamide ATG, mainly depend on lymphoablation. So this is the protocol that we are using, and currently is the most popular regimen used for conditioning for MS, which is cyclophosphamide 200 milligram per kg and ATG 6 milligram per kg. And this is the initial report from Richard Burt in 2015. After this, there was shift in the utilization or the commonly used regimen toward the cyclophosphamide ATG and less use of other regimen like BEAM ATG. So since that publication in 2005, we have more increase of cyclophosphamide ATG compared to other regimens. For our center, we started in 2018. Our experience, we gathered with our colleagues in the neurology department, and we put the local guidelines, indications, treatment protocol. So the patient will be initially assessed and referred to us by neurology, then he will be assessed by us. We use the condition immobilization regimen cyclophosphamide GCSF, targeting more than 5 million per kg CD34, and the conditioning regimen is cyclophosphamide plus ATG. Supportive medications, prednisone for 8 days to prevent activities of MS during the conditioning. GCSF from day 3 plus prophylactic antibiotic plus hemorrhagic cystitis prevention by hyperhydration, Mizna, and folic catheter with high-dose cyclophosphamide. This is the regimen that we are using, cyclophosphamide plus ATG, a lot of supportive regimens. And we did a retrospective review of our cases. So we did 9 cases. The median age was 35. The oldest one was 43. 6 male, 3 female. The median duration of disease, 7 years. One patient had 14 years of disease duration. And the disease subtype relapsing remitting, 6 cases. Neurobehaget, 1 case. NMOSD, 1 case. And one patient had 1 activity of MS, but he was very interested to go autologous transplant, and we did for him transplant. The median EDSS was 5.5, median number of previous therapies 2, number of relapses last 2 years pre-transplant 2, comorbidities there, mobilization and conditioning was mentioned. So these are the follow-up now, 959 days. And the first patient underwent transplant now completed 7 years. The median CD34 was 11 million. Stem cell collection was in day plus 12. Median platelet engraftment 15, and median ANC engraftment was day 9.
Sorry, 1 minute.
Okay, so limited number of transfusion and duration of hospitalization was 22 days. So after a median follow-up of 2.6 years, clinical relapses, none of the patient has any clinical relapse. None had progression, and none had MRI activities. So all patients are surviving, no relapse, transplant-related mortality. Toxicities, acceptable toxicity, mucositis, febrile neutropenia, respiratory infection, hemorrhagic cystitis, no patients, CMV, 4 patients. 5 patients had admissions, but for different reasons or for infections, no ICU admissions. So in our local experience, very well selected MS patients, we think the outcome is excellent, and it's very encouraging to refer and to do more patients. We need longer follow-up, we need larger cohort. It is a safe procedure, and based, I think, on the currently ongoing randomized clinical trial. Once that we will have the result of these randomized studies, we will have more patients to benefit from the autologous transplant. For the first 7 years since we started the protocol, we had only 1 or 2 cases referred to us, but this year we had 10 cases already referred to us. So involving neurologists is very important, and getting their interest is very important to be involved and refer cases to us. I would like to acknowledge and thank our team and our patients and their families. Thank you very much.
Thank you very much, Dr. Mohsen. I think we'll keep the questions at the end of the session. It's my pleasure now to welcome our second speaker, Dr. Samir Amoudi. He's a consultant adult hematology and stem cell transplant and the section head of stem cell transplant and cellular therapy at Princess Noura Oncology Center, King Abdulaziz Medical City, National Guard. He's also an assistant professor in medicine at King Saud bin Abdulaziz University for Health Science College of Medicine in Jeddah. He's going to talk to us today about the Jeddah local experience, mainly in CAR T cell therapy in the relapsed refractory lymphoma. Dr. Samir, the mic is yours.
Thanks, Mr. Chairman, for the nice introduction. So today I will talk about CAR T cell in my institution, which is National Guard Hospital, Jeddah. So as we know that actually CAR T cell was approved as initially third line. We have 3 products like Axicell, Tisacell, and Lisocell. Then 2 of the products, Axicell and Lisocell, were approved as a second lines. In my institution, we have only Axicell. Yes, I think National Guard Riyadh, they have Axicell and Tisacell, even King Faisal Special Hospital. We don't have Lisocell in Saudi Arabia. As we know, CAR T cell makes huge difference in management of relapsed refractory diffuse large B-cell lymphoma, because usually these types of patients, they are chemo-resistant, even if they achieve partial remission and then underwent autologous stem cell transplant, majority of them actually will progress after 2 to 3 months post-transplant. That's why CAR T cell makes a huge difference. So actually the CAR T cell program in my institution was started in May 2023, so still less than 2 years. So until now, we have actually 27 patients had infused with CAR T cell, and like I mentioned, we have Axicell products. So what are the disease features for these types of patients? So when you look actually these 27 patients, actually 24 patients had diffuse large B-cell lymphoma, and 3 of them are follicular lymphoma. And we know that early versus actually early and primary refractory diffuse large B-cell lymphoma, they do worse compared to late relapse. So when you analyze the 24 patients, actually, you can see around 54%, which are the 13 patients, actually they are primary refractory. 6 patients, they are early relapse, and 5 patients are late relapse. So as you mentioned, CAR T-cell approved as second line and third line. So what these types of patients, so how many CAR T-cell at the second line, how many CAR T-cell beyond the second line? So as you can see here, actually 19 patients, actually they had CAR T-cell as a second line. 8 patients CAR T-cell beyond the second line. It depends either follicular lymphoma or third line in case of diffuse large B-cell lymphoma. So these are the 27 patients. It shows the number of prior lines of therapy. So just to show that this patient had 4 lines of therapy, this follicular lymphoma patients. The majority, they had only 1 line of therapy. Some of them have 2 lines of therapy. But as you can see, most of them, they have actually 1 line of therapy before the CAR T-cell. So we know once we collected the lymphocyte, and because the manufacturing usually takes like 3 to 4 weeks, and these types of patients are actually, they can primary refractory relapse, they cannot wait long time without any therapy. That's why we give what we call bridging therapy. The aim just to keep the patient stable. So the aim of bridging therapy not to put the patient in CR, just to keep him stable, fit until the product is ready. So in my institution, actually, we are using BOLA-based regimen bridging. So you can see here, actually, we used BOLA-based regimen in around 21 patients. It depends, BOLA-R or BOLA-R-GMOX. 4 patients require radiation as a bridging therapy. 2 patients did not require any bridging therapy. At that time, most likely disease burden was very low. So, and this actually the BIT CT after the bridging and before the infusion of CAR T-cell. As you can see here, 13 patients, the majority, they have like DEVOL 5 before infusion of CAR T-cell. 6 patients, they are partial remission, and 8 patients are complete metabolic response. So what are the results? So actually so usually once we infuse the CAR T-cell, we assist the patient by doing BIT day 30. Then it depends on the response. If the patient achieves complete metabolic response, we'll do BIT day 90. But if the patient achieves partial remission at day 30, we need to do BIT at day 60. So BIT day 30, actually, here you can see we have 25 patients because there is 2 patients still not yet reached day 30. So 16 patients, actually, they achieve complete metabolic response. 5 patients, they are in partial remission, and 4 patients, unfortunately, they have progression disease. So what about these 5 patients? As mentioned, if they are like having partial remission BIT day 30, we need to do BIT day 60. So BIT day 60 was done. 2 of them, 2 from 5 patients, actually were converted to complete metabolic response. The other 2 continue to be in partial remission. Third, unfortunately, the 5th patient, his disease progressed. What about the 16 patients who had achieved complete metabolic response at day 30? Actually, 15 from 16 patients continue to be in CMR. Only 1 progressed at that time. So until now, actually, I have like the total 27 patients. 24 are still alive. 3 actually they passed away. Main reason, disease progression. And this is the same. So this is just the percentage. And what about, so we talk about the efficacy. So what about the toxicity? And toxicity, mainly we're talking about CRS and ICANS. So we know that actually in like ZUMA-1, they used, I put in cohort 6, sometimes you can use steroid prophylaxis to decrease the incidence of CRS and ICANS. So here actually we used steroid prophylaxis in around 21 patients. 6 patients did not require any steroid prophylaxis. The reason we're using steroid, because at the time when we started the CAR T cell, so we are a little worried about the toxicity and especially if the patient has like active disease. But with time, starting actually gradually decrease using the steroid, even if the patient has active disease, because the team already start to have some experience with how to manage toxicity. So CRS, so all the patients, they develop actually CRS. We define that at least by developing fever. Unfortunately, we don't have a way to differentiate. Is it like febrile neutropenia, just febrile neutropenia, or this cytokine release syndrome? That's why we assume any patient who had fever after infusion, this is CRS. So all of them, they have CRS, but what about the grading of CRS? If you look here, actually 21 patients, they have grade 1 CRS, and 5 patients have grade 2. We haven't seen grade 3 or 4 CRS, so just grade 1 and 2. The majority are grade 1. And this is actually reflect number of tocilizumab doses given to the patient at the time when they develop CRS. Usually, our protocol actually, if the patient spike fever, will wait 24 hours, and actually we start antibiotics and we'll manage as febrile neutropenia, then we'll wait 24 hours. If the fever not subside, we'll start to introduce tocilizumab. You can see here actually, this is actually the number of tocilizumab doses, 0, 1, 2, 3, and this is the number of patients. So 2 patients did not require any TUSI, 3 patients require dose 1, 2 doses, 3 doses, and actually majority, like 15 patients, they require 4 doses of tocilizumab. What about using steroid as a treatment of CRS? You can see here 16 patients actually did not require any steroid to treat CRS. They managed by the tocilizumab. 11 patients required steroid to treat CRS. What about ICANS? So in the 27 patients, actually 23, they did not have any ICANS, only 4 patients. And what are the grade of ICANS in these patients? So 2 of them, they have a grade 2. There is no grade 1. There is no grade 2. And 2 of them, they have grade 3. And we haven't seen any patient with grade 4. ICU admission, actually, we have those who develop ICANS as a grade 3. Actually, they needed ICU admission, but actually, they stayed in the ICU only for 48 hours. After that, they were discharged from the ICU. The rest, they did not require any ICU admission. What about GCSF? We know neutropenia common with the CAR T cell. So in our institution, we'll wait 2 weeks. If the patient neutrophil not recover, we introduce the GCSF. So as you can see here, actually 19 patients actually they required GCSF. 7 patients did not require any GCSF support. So from the 27 patients, actually we haven't seen any death after the lymphodepletion in the first 30 days. Only 1 patient actually, after 1 year, progressed disease, and his disease from those who achieved CMR, after 1 year, only 1 patient had progressive disease. So conclusion, CAR T-cell showed excellent result in relapsed refractory non-Hodgkin lymphoma, acceptable toxicity profile. Of course, the limitation is short follow-up and a small number of patients. It's retrospective. Of course, before my conclusion, actually, I want to thank all the team, actually, the physician, nurses, pharmacists, BMT coordinator, stem cell lab, and pheresis unit, neuro and ICU team for their great support. And thank you.
Thank you, Dr. Samir. Very nice outcome and very nice presentation. So we will move to the third speaker. Dr. Zahra Shamasi is going to talk about local experience in chronic GVHD. Dr. Zahra Shamasi is a consultant adult hematology and stem cell transplant at King Fahd Specialist Hospital in Dammam since 2019. Dr. Zahra Shamasi did her adult hematology training, followed by BMT fellowship in Canada, University of Ottawa. Welcome, Dr. Zahra. The floor is yours.
Thank you. Thank you, everyone, for the invitation. My talk today is about KFSH experience in chronic GVHD and what's new. I will touch on base on pathophysiology of chronic GVHD and the evolution of the GVHD treatment in the last couple of years, and touch base with the steroid refractory GVHD definition and treatment, and I will end it up with local experience presenting 2 cases in our center. As you all know, the GVHD is post-allogenic transplant complication. It's classified into acute and chronic based on the timing. Acute GVHD usually occur in the first 100-day post-allo transplant, affecting mainly gut, skin, and liver. Chronic GVHD is autoimmune disease characterized by chronic inflammation and depleting and fibrotic changes. Overlap GVHD is usually had this both acute and chronic features, and it can affect other organ of the acute GVHD like lung, muscle, joint, and genitourinary symptoms. The incidence of chronic GVHD is usually 30 to 70, up to 70% in the patient post-allogenic transplant with the classic GVHD prophylaxis with CNI and antimetabolate. Unfortunately, it's carry high risk of mortality and morbidity post-transplant and affecting the quality of life of the patients. Unlike the acute GVHD, the chronic GVHD is affecting the immune tolerance of adaptive and innate immunity of both donor T cells and B cells, alloreactive and autoreactive way. Alloreactive and autoreactive led to antigen-presenting cell activation, which lead to inflammation and fibrosis and end organ damage. As we probably know, that pathophysiology of chronic GVHD is usually divided in 3 phases. The phase 1 is from the donor hematopoietic stem cells and alloreactive T cells. The phase 2 is from the donor hematopoietic stem cells and thymic injury and dysfunction of both T and B cells and NK cell. The phase 3 is usually the chronic inflammation and fibrosis, which led to the irreversible damage in chronic GVHD. The treatment of chronic GVHD, usually we use the systematic corticosteroid, which carry varied response rate between 50 to 55%. Additionally, another immunosuppression didn't show any much benefit. This table summarized the randomized phase trial that done in the field, adding other immunosuppression to the corticosteroid, which failed to show any benefit apart from adding CNI. Nowadays, we moving from targeting general inflammation with corticosteroid to more targeted therapy affecting the pathophysiology of the disease, as we are better understanding the pathomechanism of the disease, like JAK2 inhibitor, ROCK2 inhibitors, proton tyrosine kinase inhibitor, and aiming of that reducing the long-term morbidity and toxicity of the steroid. One of the challenging things of us is when the patient is not responding to the steroid or developing steroid refractoriness. As you probably know, chronic GVHD is a progression, while the steroid refractory is a chronic GVHD progression while in the prednisolone more than 1 milligram for 1 or 2 weeks, or stable GVHD while in prednisolone more than 0.5 milligram per kg for 1 to 2 months. Steroid dependence and ability to taper that prednisolone below 0.25 milligram per kg in at least 2 unsuccessful attempts, at least 8 weeks apart. And the most hard part to deal with is the long-term complication and unacceptable toxicity, including recurrent infection, AVN, DM, steroid-induced myopathy, and osteoporosis. This slides actually summarize the pathogenesis, how understanding the pathogenesis of the disease help us to find a new, better drugs to treating chronic GVHD, starting with ibrutinib, which is a protein tyrosine kinase inhibitor, affecting both B and T cell proliferation, production, and autoantibodies. Blemosidel is ROCK2 inhibitor, which affect the Th17 and follicular helper T cells, decreasing them and increasing the Treg and subsequently decreasing the fibrosis. Ruxolitinib is a JAK2 inhibitor, which reduce cytokine production and proliferation. And the last one is oxetolumab, which was recently approved last year, which is CSF1 receptor inhibitor monoclonal antibody, which reduce the cytokine production in the monocytes and macrophages. We'll start with ibrutinib. Ibrutinib is the first drug to get approved based on phase 2 trial with overall response rate 67%, with more than 70% maintaining the response more than 20 weeks, with a reasonable safety profile, and most important part that most of the patients in the trial were able to taper the steroid to lower dose and avoid the long-term toxicity of the steroid. Ruxolitinib is JAK2 inhibitors. In RICH3 trial, it was comparing the ROX with the best available treatment with the primary endpoint overall response rate at 24 weeks. The results at 24 weeks was in favorable of ruxolitinib with 50% overall response comparing with 25%. And the secondary endpoint, the best overall response was 76 compared with 60% in the best available treatment arm. More importantly, the median failure-free survival at 24 weeks was longer with ruxolitinib, 18.6 months versus 5.7. With ruxolitinib was safe drug, and checking the safety profile, it was comparable between the two arms with no major side effects. Based on that trial, the ruxolitinib get approval in 21. Moving to the next study, Rockstar trial. It's a phase 2 trial comparing 2 doses of blemosidel for patients who received minimum 2 lines of therapy, and primary endpoint was overall response, and the secondary point was safety and free FFS and overall survival. The results was impressive in both doses of the blemosidel, 74% in 200 milligram daily and 77% in the 200 BID, with safety profile with median time to response within 5 weeks. And this led also to the approval of blemosidel in July 2021. This graph basically shows how the response was maintained through all organs, including the lung, with safety profile of the medication in heavily treated patient with multiple line of treatment. Moving to the last drug approval last year, axatilimab, based in AGAVA 201 trial in patients with receiving minimum 2 barrier line, including ibrutinib, ruxolitinib, and blemosidel. This was phase 2 trial testing 3 doses of axatilimab, which is IV medication given every 2 weeks by 0.3 milligram Q2 weeks, or 1 milligram Q2 weeks, or 3 milligram Q4 weeks. The primary endpoint was overall survival for the first 6 cycles, and the secondary was the symptom reduction and sustained response rate with organ-specific response rate and the safety profile of the drug. The result was impressive. The 0.3 milligram dose showed 74% response rate with median time to reach 1.7, and 60% of the responder maintained their response up to 1 year. You can see in the left is the how's the dose 0.3 was more effective than the lower, the other two doses, and also the overall response was maintained through the, or was sustained through the organs, including difficult organ like lungs and eyes. Last year in the ASH, there was update about response analysis of AGAVA 201, which showed basically that most of the response will happen by day 56 if they get response with the lower dose, 0.3 milligram Q 2 weeks. And moving now to the last part of my presentation, which is clinical cases in our hospital. I will present two cases. The first one is about young patient, is 26-year-old, diagnosed with T-cell rich B-cell lymphoma, stage 4. He was treated initially with R-CHOP 6 cycle. He was refractory, salvaged, and consolidated with autologous stem cell transplant. Unfortunately, he relapsed shortly after that, so we elect to transplanted him in March 2022. His early course post-transplant complicated with acute GVHD grade 3, involving skin, liver, and gut, treated with IV methyl and cyclosporine. Subsequently, the patient had a major complication, required multiple admission with recurrent infection, AFib, CMV viremia, acute kidney injury, including lung aspergillosis. As you know, he had acute GVHD, so subsequently he developed chronic GVHD. In November 2022, he developed moderate chronic GVHD by NIH criteria, treated with steroid and cyclosporine. And subsequently, he also still had complication from the steroid, recurrent infection, developed metabolic syndrome, DM, and was not tolerating the steroid very well. We weaned him from the steroid in September 23. After exactly 1 week from stopping the prednisolone, while he's still in cyclosporine, he flared. So we elect to, giving the toxicity that he developed with the steroid, we elect to start him in second-line ruxolitinib. He responded to ruxolitinib very well without even adding the steroid. We were happy about the result at that time. While we tapered him in the ruxolitinib, unfortunately he flared in June 2024 when he reached the low dose of ruxolitinib. He had a flare in the skin, mouth, also worsening, developing lung GVHD, bronchiolitis obliterans. So at that time we resumed, actually we increased the dose of ruxolitinib and started him on FAM. Despite that, he was not much improving. He started to develop localized skin lesion, morphea-like lesion, and also worsening of his chest symptoms in form of recurrent infection. So we give him rituximab 4 doses with partial response. Between December and March, we had much kind of control of his disease in form of normalizing his liver, improving his oral symptoms and his oral intake, but he kept developing new localized fibrotic skin lesions in upper and lower limb with the persistent chest symptoms and worsening in his BFT and HRCT. In this table, you can see that his FEV1 was improved when he was in ruxolitinib to 85%, but with the tapering of ROX, his FEV1 was decreased again, and then meanwhile, he had active GVHD disease in other organs. So in March, like by definition, he had severe GVHD by an IH criteria, and we elect to started him in a plomocidil 200 daily. And since then, he's in the first month, he didn't have much change in his symptoms, but he didn't develop the new symptoms. And actually, I saw him last week, and he started to have improvement in the localized fibrotic lesion in his lower limb, with softening of the changes of the skin, and changing in the discoloration as well. And he didn't have any infection or chest symptoms since we started him in plomocidil. So we are optimistic that he will respond.
1 minute.
I will move to the second or the last case of my talk. Is Mr. A is a 28 years old male with high-risk AML, monocytic type, diagnosed back in 2019. He was transplanted in July with conditioning BUSI and GVHD prophylaxis, cyclosporine, and methotrexate. Early transplant course was completed with TMA, required switching him from CNI to MMF, and also he developed late onset VOD, was treated with defibrotide. He developed chronic GVHD in October 2019. It was severe by NIH criteria, skin, liver, mouth, and eye. Treated with steroid and MMF. He improved initially. In January, with the tapering, he had mild flare. Responded to increase the steroid. Subsequently, we tried to every time we tried to taper him, he was flaring, so he was labeled as a steroid dependent, and we started him in a second line ibrutinib. He improved with ibrutinib, additionally to increasing the steroid, and he did well. We kept tapering both steroid and maintained ibrutinib for minimum 6 months, then we tapered him. In April 2021, he was off ibrutinib. Because of the prolonged history of steroid use, he developed adrenal insufficiency, requiring replacement, and after a couple of months of stopping the ibrutinib, he presented again with severe flare-up of skin, muscle, I remember also mouth, and then we resumed ibrutinib with the steroid. He responded nicely, but took him longer time to get off the ibrutinib and also the steroid. Meanwhile, he had other complications other than adrenal insufficiency. He developed bilateral AVN of the hips and recurrent bone infection. Initially, while he was still in lower dose of ibrutinib, and later on, after even he stopped the ibrutinib. In December 22 and February 23, he developed septic arthritis, osteomyelitis, required hospitalization for a couple of months, and IV antibiotic with drainage. In August 23, 2023, he had again osteomyelitis, required the drainage with positive culture, and he was treated with prolonged course of Bactrim. I would like to conclude my speak, and thank you, everyone.
Thank you very much, Dr. Zahra. Very difficult complication indeed. So it's my pleasure to introduce the last speaker of this session. He's presenting a very interesting topic, the WU-CAR 007, an anti-CD7 allogenic CAR T-cell therapy for the treatment of T-cell malignancies. Dr. Ayman Kabakibi is currently the CEO and Executive Vice President of Research and Development of WuGen, a US-based clinical stage biotechnology company developing allogenic cell therapies for the treatment of oncology and autoimmune disease indications. He has over 2 decades of experience in drug discovery and development in a large pharma and biotech companies. Most recently, he co-founded Talic Incorporation, an immuno-oncology company developing novel antibody drug conjugates, and served as its vice president. Dr. Ayman, the floor is yours.
Thank you very much. Thank you for the kind introduction. You must have spoken to my mother. I'd like to thank Professor Ahmed and the organizers for inviting me to give this talk, and it's my distinct pleasure to be with all of you here in this wonderful meeting. So we heard a lot yesterday and today about CAR T cell therapies. So yes, another CAR T talk, but I'm going to take a little bit of detour here in 2 aspects. The first one is that this is an allogeneic CAR T. It's not an autologous CAR T, similar to the ones that we've been hearing about for the last day and a half. And secondly, the disease of interest is a T cell malignancy. It's not a B cell malignancy. These are my disclosures. Okay, I'm not going to belabor this because it was covered very elegantly by a lot of presenters, but suffice it to say that the approved autologous CAR T therapies have truly revolutionized patient care in B-cell malignancies. There are currently 7 approved drugs, 5 targeting CD19 for the treatment of B-cell leukemia and lymphomas, and the 2 on the right targeting B-cell maturation antigen and for the treatment of multiple myeloma. We saw this covered very well, high response rates, probably curative for a subset of patients have been achieved, often with minimal long-term toxicities. Now, that doesn't say that there were no short-term toxicities, but long-term toxicities were very mild. However, there are some challenges with autologous CAR Ts. As you know, that the cells are sourced from the patient, and therefore they are damaged from chronic exposure to multiple line therapies, including chemotherapy. The long manufacturing, wait times, it's 3 to 4 weeks currently. It's getting better, but we're not quite there yet. And some of these patients really can't wait for 4 weeks. There's still a likelihood of manufacturing failure, which would be an unfortunate outcome for patients that have already committed to this. And the high manufacturing cost, which was referred to yesterday as the financial toxicity. So allogeneic CAR Ts can address these challenges because the T cells are sourced from a healthy donor. So the benefits of allogeneic is that the harvested cells are healthy, they're not compromised. The product is an off-the-shelf, ready for use, literally within 24 hours from demand. There are usually multiple lots available, multiple doses available, so we don't have the situation where there's a manufacturing failure. And it's more affordable and efficient. Basically, the cost of goods are substantially lower than the autologous CAR Ts. The unmet need that we addressed at Wogen, the company that I'm a part of for the last few years, is that even though there are T-cell malignancies are more aggressive and have inferior prognosis than B-cell malignancies, there are still no approved CAR T therapies for these diseases. In fact, for T-cell malignancies, when sort of the orphan child, there have been no approvals in the last 20 years since Nelarabine in 2005. So why is that? Well, as you can imagine, it's really difficult to target a T cell with a CAR T, right? There are some limitations associated with that that need to be overcome by genetic engineering, which is exactly what we did at the company. The first limitation is that because the malignant T cell and the normal T cell express the same surface antigens, it's essentially impossible to completely separate a normal T cell from a patient with a T cell malignancy. And therefore, the product would contain malignant cell. The solution for that is to source the cells from an allogeneic source, from healthy donors, so you don't have this issue of contamination with the malignant cell. But the problem that this solution brings is that the allogeneic T cells induce graft versus host disease. The solution for that is to delete the T cell receptor on the CAR T so that mitigate the alloreactivity so that it would not attack the recipient tissues. So that's the first genetic engineering by deleting the TCR by CRISPR-Cas technology. And the last challenge is that CD7, which is the receptor that is highly expressed on T cell malignancies uniformly, especially in the leukemia setting, is also expressed on normal T cells. So if you generated a product, these CAR T cells would recognize each other, kill each other by a process called a fratricide. And to get around this problem, the solution is to delete CD7 to eliminate the cells killing each other during the manufacturing process. So WuCAR7, which is the name of the product, and that's what I will be using for the rest of the talk, is a dual-edited, CD7 targeted allogeneic CAR T for the treatment of T-cell malignancies. This is an overview of the manufacturing process. The T cells are sourced from a normal donor. They contain CD7, obviously, and the T cell receptor. We use CRISPR-Cas technology to delete both CD7 to prevent fratricide and the TCR receptor alpha constant to prevent graft versus host disease. We arm the cells with a CD7 targeted CAR. the cells are expanded in the lab to generate billions of cells. Any residual T cells that still express the TCL receptor are removed by magnetic beads. The product is formulated and cryopreserved in bags or vials, ready to go upon requests. And a single lot can generate approximately 50 to 100 doses. And therefore, it is commercially viable and it's ready to go. So let me tell you about the disease that we have been interested in. It's T acute lymphoblastic leukemia lymphoma, which I will refer to as TALL-LBL. It really presents, everyone that I talk to here, hematologists tell me that there's a huge unmet need, and that's exactly our impression as well. TALL-LBL is a disease where it represents 15 to 25% of pediatric and adult ALL cases, the remaining 75% being B-cell diseases, leukemias. TLBL is the most common non-Hodgkin's lymphoma in children, representing around 25% of NHL. The TLL and LBL are actually considered the same disease. They're just spectrum of the same disease, with TLL having greater involvement of the bone marrow, usually more than 20-25% the bone marrow, that's a TLL. LBL usually has no or less bone marrow involvement. TLL-LBL is an aggressive disease with high rates of relapse and mortality in both children and adult. Children and adult ratio is usually 50-50. These kids have the disease usually at a young age. Despite the initial responses rates, the disease TLL-LBS has very limited treatment options in the relapsed and refractory setting, and I'll get to that in a second. And CD7, which is the antigen of interest here that we are targeting, is suppressed essentially on 100%. So you can think of CD7 on a TLL like the CD19 on a BALL. So you don't need a companion diagnostic to identify the patients. So for the treatment paradigm, like I said, once the patient is diagnosed, chemotherapy is first line of therapy. 70% or higher numbers respond, you get complete remission. The patients get consolidated and maintenance. If they're MRD negative, hopefully they get an allo transplant because truly it's the only way forward for potential cure. And unfortunately, most of these patients would relapse. And the other 30% or so are refractory to treatment. They don't even respond at all. So we have this relapse refractory population, and this is the population that is unfortunately in trouble. The reason is that there's only one approved drug, nelarabine. It's usually given alone or in combination with chemotherapy. Sometimes it's moved to first line. The responses for the nelarabine are poor. The composite complete remission rate is around 20% with a median duration of response of less than 2 months. And the patients would relapse again, and the next line of therapy, they get salvage therapy, physicians try venetoclax, daratumumab, anything in their disposal just to get a response. But unfortunately, none of these are approved, and they have poor outcomes. So the population that we went after is the relapse refractory TLL-LBL. So we conducted a clinical trial. This is a phase 1, phase 2 clinical trial. Enrolled 26 patients total in this design. It's standard design, dose escalation, cohort expansion. In the dose escalation part, it's the patient would receive a lymphodepletion chemotherapy composed of fludarabine, 30 mg per meter square per day, cyclophosphamide, 500 mg per meter square per day times 3 days, then a single dose of WUCAR7 on day 1, and then they get assessment of toxicity and assessment of response on day 28, months 3, 6, 9, and 12. 4 dose levels were used. 100 million cells was DL1, transitioning 300, 600, 900 million cells. And based on the toxicity profile, the 900 million cell dose was selected as the recommended phase 2 dose. We transitioned and enrolled 13 more patients with this dose, but we enhanced the lymphodepletion from the standard lymphodepletion that was in the dose escalation. So essentially added another dose of fludarabine and double the dose of cyclophosphamide, and I'll show you why on subsequent slides. The patient population that was included in this trial included adults. This is where we started, and the FDA reviewed the data, and they allowed us to drop the age to 12 years old. So we enrolled approximately 5 or 6 patients that are between 14 and 18 years old. This slide shows the demographics, the patient demographics, and the disease characteristics. The median age was 30, the range of 14 to 69 years old, so younger population, primarily males, which is characteristics of this disease, is usually mostly white, 90-something%, which I left off the slide here. The ECOG performance status was 0 or 1, 1 being 62%. The number of prior lines of therapy, the median was 4 with a range of 2 to 7. The baseline bone marrow blast count, the median was 50% with a range of 5 to 95%, some really high tumor burden in some of those patients, actually quite a few of them. Prior transplant was at least 1 transplant, some had more than 1 transplant, were 40% total, 10 patients. Bone marrow disease was around 40% of the patients. Extramedullary disease was 26%, and bone marrow and EMD were around 25%. So approximately 50 or so % of the patients had EMD involvement, which is known to be a worse prognosis for this disease. As for safety, the cytokine release syndrome was in 88%. Majority was grade 1, grade 2, 69%. 5 patients, 19% had grade 3 or more. 2 of those were grade 4 CRS, but they were managed with supportive care and completely resolved within the first 1 or 2 weeks. Immune effector cell associated HLH-like syndrome. There was 1 case of grade 2 in this population. ICANS, we observed 2 grade 1 ICANS in this trial. Graft versus host disease, there was 1 event of grade 2. We don't see anything greater, grade 3 or more. Prolonged cytopenias, there was 1 case in grade 1, 2, and 1 case in grade 3. 3 patients had grade 5 events. 2 of them were deemed unrelated to the treatment, and 1 was related to the treatment and had extremely proliferative. This patient, unfortunately, is a really unfortunate case where this young lady was transported from a war zone in Gaza to Europe. She had 95% bone marrow blast and counts and very proliferative disease by the time she made it to Europe. Unfortunately, she expired a few days after she received the therapy. So, which really highlights the need for having an allo product for this, because a lot of these patients can't wait 30 days to get treatment. As for responses, overall, the drug was effective, surpassing the standard of care. Shown here in the waterfall plot is the magnitude of response versus % reduction from baseline tumor burden. Except for dose level 1 with the white bars, we saw responses in all dose levels, DL2, DL3, and DL4. But the majority of the responses, as you see here, were in the recommended phase 2 dose of 900 million cells with enhanced lymphodepletion. And at this dose, the overall response rate was 91%. And the
2 minutes of time.
2 minutes? Okay, and the CRC, I speak really slow then. Okay, all right, I'm gonna run through this. The CRC was 73%. The duration of response shown here, the longest duration of response was 10.7 months. The overall response, 6.7 months. The RP2D was not reached. 8 patients were bridged to transplant, and they successfully engrafted. This is one of the clinical vignettes. This is a patient with refractory TLBL, received the recommended phase 2 dose, and you see that the difference between day 0 and day 28, he achieved a complete remission. I'll go, maybe I can skip this one here. Similar, this is a young lady who had blast 55%. She had received multiple lines of therapy, including an autologous CD5 CAR T and 2 transplants. She received the recommended phase 2, responded, MRD negative CR, received a 3rd transplant, and she received a remission and still in remission 9.5 months later. PK, the product expanded pretty quickly and nicely, achieved peak levels on day 10 to 14, declined, but it persisted for around 3 months, and there was no difference between the area under the curve between bone marrow patients with bone marrow disease or AMD disease, suggesting that it doesn't matter really whether the drug expanded. We saw no anti-HLA antigens and drug and ADAs for the product. Let's see here, what do I have? Enhanced lymphodepletion showed better PK than standard lymphodepletion. This is why we went for enhanced lymphodepletion. And this is the regimen that we use. I'm going to skip this one here. This is, so based on this promising data, the agency gave us the green light to start the pivotal trial for this disease. We have sites open, 2 disease populations. The first one is relapse and refractory, and then MRD positive, basically after first line, MRD positive. And the age is adults and pediatrics. The agency allowed us to drop the dose to 1-year-old. Okay, we have all kinds of indications accelerated from the agency. 3 sites are open in the United States, but this is intended to be a global trial in Europe, Korea, and Australia. I'm going to skip this because I was going to tell you here that it could be used for teen and Hodgkin's lymphoma because CD7 is expressed on teen and Hodgkin's lymphoma patients as well. We have a vignette of a clinical trial that we have there as well, and we see responses. And the summary, I think I covered it well here. I don't have to summarize it. So how is that for speed?
For the question sessions. So questions for the speakers? Yes.
Thank you. A question for Dr. Al-Zarami. Actually, 2 questions. What is your experience using the 2 gram meter per square meters with cyclophosphamide? Do you have a problem with mobilization for patients with MS? We usually use 4. And the second one, maybe I missed this part, but do you have experience with fertility preservation in these patients?
So for the first question, we are using 2 gram. We admit the patients, put the central line for them. Those who with limited mobility, we put Foley catheter for them with good hydrations. I don't remember the exact number, but a good number of them developed febrile neutropenia, well managed. Collected very well, day plus 12, and then immediately discharged. Some of them, we keep them just to, after the recovery, to complete the workup for transplant. So it is very well tolerated.
It's all in the outpatient setting?
No, inpatient.
Inpatient.
We do it inpatient, yeah. We never did any outpatient with mobilization. The second question regarding the fertility. So we don't do it. Unfortunately, one patient blamed us why they did not discuss this with them. So from now on, we are going to refer this patient, female, to fertility clinic, female like oncology fertility clinic, and male we have the sperm banking, so we will offer it to male patients. But I think this is very important. Thank you.
Suggestion and question. Again, I think the problem with the recruitment of patient to like MS in the trials, because the neurologists, they don't know that you have the facility and you are capable of doing this. So I think it's really very important, communication with other colleagues, not only in MS. There is tons and tons of cumulative evidence in other connective tissue disease like severe lupus and so on. And my question also was about the CAR-T, CAR-7, is I saw that it's an international study, and maybe the Far East, they got most of the T-cell. But still, we have a good number of patients here in the kingdom. You know, we are in between the West and the East, so we are in the middle. So there is a chance that you consider the kingdom, especially the transplant center, as part of participants?
Thank you for the question. Yes, the short answer is yes. The follow-up is when, right? So we, obviously being in the United States, we open sites in the United States. We continue to open sites in the United States. We intend to go, it has to be a global trial, because really in order to recruit fast, we have to have patients from all over the world. We can't only rely on the United States. That's our assessment. And yes, I have been discussing actually with Dr. Ahmed about that, is that yes, absolutely, there's a chance. We would be interested in opening sites in Europe. North Korea is a place where there's been a lot of interest there as well. Australia, we are about to open Peter Mac in Australia. And absolutely, we would be delighted to discuss the possibility of opening a site in the kingdom.
Yeah, excellent presentations from all speakers. Thank you. Dr. Ayman, question about these CARs. I might have missed that. What's the median follow-up of those patients? And also the CARs survival. And I know you missed the pharmacokinetic because of the speed, but it would be nice just to give us a hint of the fate of those CARs, and do they get to, you know, the exhaustion and others like the...
I'm sorry, I missed the first part because I could not hear you, Dr. Ahmed.
The median follow-up.
The median follow-up, oh, thank you, yes. So the median follow-up, okay, so the protocol for the phase 1, phase 2, the phase 1, phase 2, the protocol is for 2 years on this trial, and if patients basically make it beyond, they transition to a long-term follow-up protocol. So, because we use lentivirus, there's a requirement to follow these patients up for 15 years. Every time you use a viral transduction into cells, you have to follow them up. So we have quite a few of the patients, I believe 4 or 5 patients still remaining, but they transitioned from the initial protocol to a long-term follow-up protocol. And then we basically assess them on a less frequent cadence. So every 6 months they get assessed. So this is still ongoing for quite a few patients in the long-term follow-up protocol.
Sorry, one last question, short question, Dr. Wael.
Yeah, thank you all. Dr. Mohsen, I have a question for you about you have 9 patients that enrolled in your MS with the autologous transplant. Are you, in your protocol, are you doing the MRI for these patients before you proceed for autologous? And if yes, when you do this assessment, is it before mobilization or just after mobilization? And would you marrow these patients before you proceed with the mobilization? Thank you.
Yes, it is part of the workup. Most of these patients, they already do workup with the neurologist, but if it was not done within 3 months before transplant, we do the MRI for this patient to have it as baseline and then complete work like follow-up post-transplant. So we do it before mobilization. And then we do it 3 months, then 1 year, and then 2 years, like annually.
Okay, thank you everyone for attending. Sorry, we're just behind the time. If it is a short question, yes. Sure.
Short question for Dr. Samir. Interesting data about their local experience in CAR-T. So the rate of neurotoxicity was very low compared to what we see in general, real life world data and also the clinical trial. So any explanation for that?
First of all, the number of patients are very small. Second, I think, you know, still we're not doing like patient CNS involvement. I think this is also one of the reasons. This is the only explanation that we have. Oh, thank you.
Okay, thank you, everyone. We'll have a short coffee break. Everyone is expected to be back at 2:30, so we can start the next session.
including talks on MRD-driven treatment in AML, gene therapy for sickle cell anemia and thalassemia, approaches to cellular therapy in relapsed refractory B-cell ALL, and the role of mismatched unrelated donor transplant using post-transplantation cyclophosphamide. Please engage with our speakers today. The best outcomes are to have a great exchange of ideas. I also invite you to learn more about us, the ASTCT, and our mission to improve the application and success of hematopoietic cell transplantation and related cellular therapies. It's a true honor to share this knowledge with all of you today and with the global community. So I hope you enjoy this session and have a wonderful rest of the conference.
Our next speaker will be Dr. Antonio Jimenez. Dr. Antonio Jimenez is an associate professor of medicine in Division of Transplantation and Cell Therapy at the University of Miami, Sylvester Comprehensive Cancer Center. His work centers on overcoming biological and non-biological barrier to allogenic transplantation, with a particular focus on the use of the mismatched graft sources. He's also committed to improving outcome in high-risk myeloid malignancies, especially acute leukemias, by optimizing transplant strategies and reducing post-transplant relapses. Dr. Jimenez is actively involved with National Marrow Donor Program and its initiatives to expand transplant access. He has co-led multiple NMDB-sponsored multi-center trials and currently serves as network co-clinical for the Access, Optimize, and Accelerate studies. In addition, he has secured independent funding to investigate the relapse prevention through novel clinical trials. He serves on the editorial board of several journals in transplant and cellular therapy and is an active member of the ACT, Ssbmt, and American Society of Hematology. Dr. Jimenez is going to give a pre-recorded talk, but he will be with us after for question and answer.
Good afternoon, everyone. I want to thank the Saudi Society of Blood and Marrow Transplantation for the kind invitation to participate in this year's Congress. My name is Antonio Jimenez, and I'm an associate professor of medicine in the Division of Transplant and Cell Therapy at the University of Miami. Today, we've walked through how MRD intersects with transplant decisions in AML, from whether to proceed to transplant to how to manage patients afterwards. And rather than just reviewing the data, I will try to frame this talk around key clinical questions that we face every day. These are my disclosures and conflicts of interest, and I will be discussing the use of an off-label investigational pharmaceutical product. So in ways of background, I think it's important to recognize that I think we all know that now that morphological remission has never been enough, and it really is insufficient to define disease clearance in AML. Measurable residual disease, or MRD, is now established as the strongest independent predictor of relapse and survival across multiple studies. And MRD status is formally incorporated into most current guidelines, including risk-adapted strategies by both the ELN and NCCN. And it's important to remember that MRD not only informs prognosis, but it's really increasingly driving many of our therapeutic decisions both before and after transplant. We can use several platforms clinically. By far the most commonly used one is flow cytometry, and it remains broadly available, but has a lower sensitivity, and we do encounter issues with how to reproduce and operator variability. PCR-based assays, they truly offer much deeper sensitivity for null targets, such as NPM1, But of course, as we all know, it has very limited applicability. NGS, and most recently error-corrected NGS, has expanded applicability, variable sensitivity, but we continue to have challenges around cost and harmonizing assays. Prior to transplant, MRD status informs us of an individual patient's relapse risk. For many patients, can also inform the urgency of the transplant, and for other patients, the choice of conditioning. After transplant, MRD surveillance offers us a window for preemptive or therapeutic interventions. And depending on the context, we can use blood or marrow samples to track disease. And across both settings and pre and post-transplant, MRD really is not just prognostic, but potentially actionable. And I think this is important to remember. And now I want to go through some of the key clinical questions that will shape our talk today. I want to walk through them one by one, trying to focus where the data is a little bit stronger. Also talk about areas where uncertainty remains, and discuss a little bit how we are adapting in the clinical space for these gray areas. The first question is, are our tools sufficient, and should MRD guide whether or when to proceed to transplant? Can we safely defer transplant when MRD is negative? Can we, and is there a benefit to erase MRD prior to transplant? Can conditioning intensity modify risk based on MRD? How should we monitor after transplant? And when and how should MRD drive our post-transplant interventions? And I want to finish by discussing sometime about the gaps that remain for future studies. So I want to start with our first clinical question, and that is, how should MRD inform risk stratification? And perhaps more importantly, are our current tools good enough to accurately risk stratify patients heading into transplant? And the short answer is not yet. There's a few things we know. MRD clearly informs relapse risk and survival, but it really matters how we measure MRD. So I'll be talking a little bit of the pre-measure study. This was a critical step in showing that traditional flow cytometry often fails to distinguish high-risk patients. And error-corrected NGS can identify patients at substantially high risk for relapse and death. Even for patients who appear to be in morphologic remission, flow cytometry couldn't really reliably predict outcomes. But I think it's important to remember that the pre-measure study didn't address whether we should delay transplant based on MRD status, and I think that's an important consideration. But what these studies show is that if we're going to use MRD to inform any part of our transplant strategy, whether that's which conditioning or surveillance or post-transplant interventions, we need more precise tools. And I want to show you what that looks like. The pre-measure study was an important step in understanding what was the prognostic value of pre-transplant NGS-based MRD on post-transplant outcomes. This was a multi-center study led by the Ssbmt, looking at patients undergoing first allotransplant in CR1 for AML. All these patients had a remission blood sample collected within 100 days prior to transplant, and the final analysis including a cohort over 1,000 adult patients. We assessed MRD using error-corrected NGS with a gene panel that included NPM1, FLT3-ITD, IDH1 and 2, and KIT. On the left, you can see that relapse rates by MRD status were significantly different. 68% of MRD-positive patients relapsed compared to just 21% of MRD-negative patients. And while I'm not showing that here, that translated into a difference in 3-year survival, 39% versus 63%. Right in the middle, you can see survival based on flow cytometry defined MRD. And this was reported by each individual center. I think it's important to mention that. But as you can tell, the curves are essentially overlapping. And on the right, when MRD was assessed with error-corrected NGS, survival curves separated clearly. And this really highlights why platform sensitivity matters. In this particular study, flow cytometry failed to meaningfully distinguish outcomes, while NGS reliably stratified risk heading into transplant. So to bring this together, I guess the one key message here is MRD is a key prognostic tool before transplant. when we use error-corrected NGS, we can get much sharper stratification compared to traditional flow cytometry. But I think it's important to remember that its application remains limited in routine practice. One caveat is to remember that this data doesn't support transplant timing based on MRD status, and that clinically, the most general strategy continues to be proceed with transplant once remission is achieved for most patients, and I'll discuss that later. But with that said, MRD status still carries major value, and it helps us think about how we can tailor conditioning, how to monitor after transplant, and identify the patients that might benefit from preemptive interventions. But I'll come back to those strategies later in the talk. So now let's move into the next question. Can we safely defer transplant if MRD is negative? Even among patients undergoing allogenic transplant, MRD negativity does not eliminate relapse risk. So if we see on the pre-measure study, around 20% of patients who were MRD negative still relapse after transplant despite this very highly sensitive error-corrected NGS. And I think it's important to remember or reinforce the fact that MRD negativity reduces risk, but does not guarantee a cure. Many other studies have investigated whether in selected cohorts who achieve MRD negativity, transplant deferral with close monitoring might be a safe strategy. And I want to walk you through that data on the next few slides. Here we can see that several trials support a selective deferral strategy. In the Ssbmt AML 1310 trial, MRD negative intermediate risk patients, and these patients were assessed by centralized flow cytometry, receive an auto rather than an allo transplant. And these patients achieve a 79% 2-year survival, which was comparable to MRD positive patients receiving an allo. In the Ssbmt 12 study, MRD negativity was assessed primarily by quantitative PCR targeting known mutations, or by flow cytometry when necessary. And on patients who remain MRD negative following consolidation and avoided a preemptive transplant strategy, we can see an impressive 91% survival at 2 years. And data from the NCRI AML 17 and 19 trials, looking at patients, these are patients with commutated NPM1 and FLT3-ITD, show that MRD negativity really helped refine the transplant decisions. For these patients, MRD negative patients didn't really derive a clear survival benefit from immediate transplant, even though there was a signal for higher relapse. And this really highlights the need for nuance in transplant decisions. Generally speaking, in favorable risk AML, MRD negativity may allow transplant deferral if we can do close monitoring. But for patients with very high risk features, that's your TP53 patients, complex monosomal karyotype, or other adverse genotypes, MRD negativity doesn't really neutralize relapse risk, and early transplant remains strongly favored, and perhaps really the only way to offer a curative treatment to these patients. Let's now move into the question of whether we should attempt to eradicate MRD before transplant. So one thing we know is MRD positivity pre-transplant is clearly associated with higher relapse rates and lower survival. So it would be intuitively appealing to try to deepen remission before transplantation, but it's important to remember that no prospective trials have shown that delayed transplant to attempt this MRD clearance has any impact on outcomes. And another important thing to remember is we have to be careful about the risk of delaying transplant in someone who's otherwise ready. We have the risk of relapse, clonal evolution, and treatment toxicity, which are all very real. So let's go briefly and review the limited available data for this particular question. Some studies suggest that additional therapy can convert MRD positive patients to MRD negative. One of these studies is the VIALE-A trial. In this study, 41% of patients achieve MRD negativity with a combination of Ven/Aza, although for most cases, prolonged therapy over many cycles was necessary, over 7 cycles, actually. A single center study, this was actually an MSK study, found that in a cohort of over 200 patients, about a third of MRD positive patients converted to MRD negative patients after additional therapy. But this conversion was much more likely on patients with lower risk mutations such as NPM1, CBP8, or KIT, whereas patients with very adverse genotypes or complex karyotypes had really persistent MRD despite additional treatment. We have circumferential evidence that deeper remissions are associated with improved transplant outcomes. One example is the ratified trial. We see here that the addition of midostaurin to chemotherapy improved survival in FLT3 mutated AML, including patients who later underwent transplant. But it's important to know that MRD status was not formally assessed and ratified, so we have to interpret this data carefully. MRD interpretation is heavily confounded also by underlying disease risk. And we also have data from cooperative studies, including the ALPHA and HOVON-SAC trials, that show that allotransplant provided protection for relapse and improved survival for both MRD positive and MRD negative patients. So the data is fairly mixed in this regard. Critically speaking, no randomized trial have directly compared MRD-directed therapy versus an immediate transplant strategy. So how do we use that data clinically to make decisions? This is a controversial topic, but my general approach and the approach from many other groups is, in clinical practice today, patients with high-risk genotype, including complex karyotype, TP53, proceed directly to transplant once remission is achieved if a suitable donor is identified, even if MRD persists. Again, particularly with TP53 mutated disease, is a controversial topic, and ideally these patients should be treated, transplant or not, in a clinical trial. In contrast, selected lower risk patients, particularly those with NPM1, CBPA, or targetable mutations like IDH, can be considered for MRD-directed therapy if they're not fit for immediate conditioning. But we have to also remember the risk of delay in transplant, including the risk of over-relapse or clinical deterioration. The real answer here is that we really need large genomically annotated prospective trials to help guide future practice in this particular space. Now that we have discussed MRD status before transplant, another key question that I want to cover is whether transplant conditioning intensity can modify outcomes, particularly for patients with MRD-positive disease. We know that MRD positivity clearly predicts worse transplant outcomes, but the role of conditioning intensity remains less clear, and it becomes a question of is less more or is more more. I want to walk through that data, starting first with studies suggesting that intensification might not make a major difference. So several studies suggest that more intensive conditioning does not fully overcome the adverse impact of MRD. One of these studies is the NCRI Figaro trial, and this trial compared an intensified RIC regimen, Flam-Sub-U, to standard RIC in older adults, and really show, as we can see here, no improvement in overall survival or relapse incidence, regardless of conditioning intensity. In a similar way, the NCRI ML17 trial among patients with NPM1 mutated AML, conditioning intensity had no impact in survival outcomes for MRD positive patients. On the flip side, several studies suggest that intensified conditioning may improve outcomes in MRD positive patients, or more is more. To the left here, a secondary analysis of the 0901 showed that patients with detectable mutations by NGS had significantly lower relapse rates and higher survival if they receive a MAC compared to a RIC conditioning. A retrospective study from the Ssbmt registry, not pictured here, found that younger MRD positive patients had higher relapse rates and worse leukemia-free survival when treated with non-intensive conditioning. Here in the middle, we can see that in the pre-measured study, conditioning intensification also improve outcomes in younger MRD positive patients. And even the choice of chemotherapy in reduced intensity appeared to have an impact on MRD. In this particular trial, the use of melphalan containing reduced intensity also correlated with lower relapse rates. And in the HOVON-SAC trials, patients with FLT3-ITD mutated AML and MRD positivity had lower relapse rates and better survival when they received MAC compared to RIC, without an increase in non-relapse mortality. So to summarize here, MRD positivity before transplant is associated with lower outcomes across all conditioning intensities. However, we have growing evidence suggesting that myeloablative conditioning might improve the outcomes in selected MRD positive population, particularly in younger fit patients who can tolerate more intensive regimens. At the end of the day, the choice of conditioning must integrate MRD status, underlying disease risk, and patient-specific fitness. And we do need large prospective trials, specifically stratifying by MRD, to better define optimal transplant conditioning strategies. After transplant, MRD monitoring is crucial. The persistent or reappearance of MRD is strongly correlated with relapse. And while there's no general consensus, at our institution, we generally perform marrow MRD assessment around day 100, and especially for high-risk patients, every 3-4 months for the first year, and every 6 months until year 2. Peripheral blood monitoring is feasible for specific markers like NPM1 or FLT3-ITD, although discordance with marrow results can happen. And I think it's important to remember that surveillance enables early intervention and is essential to optimizing post-transplant outcomes. When MRD persists or reappears after transplant, it generally should drive intervention. Some of our options include accelerated immunosuppression tapering, which is usually the first step, DLI, or when possible, targeted maintenance therapies. It's important to remember that timing is key, and early intervention offers the best chance to prevent over-relapse, which is, of course, much more challenging to treat. And ongoing trials are helping define the optimal approaches for MRD-guided interventions. So what's the current evidence for MRD-guided interventions after transplant? And the short answer is we have very limited prospective data, and most come from retrospective series. Most of these retrospective studies suggest that DLI can achieve meaningful responses in the setting of molecular relapse. We also know that maintenance therapies like gilteritinib in FLT3-mutated AML can have survival benefits. While the phase 3 Morpho trial showed no difference in relapse-free survival, there was a pre-specified group analysis that showed a benefit in patients with detectable MRD, and these showed reduction in the risk of relapse by approximately 48% compared to placebo. And I think that an important message is that consistent MRD surveillance remains essential to enable preemptive interventions before over-relapse, which is, of course, much more challenging to treat. So what are the current gaps and the potential for future directions? And I think I list some of the few that I consider to be the most important. I think number one, we really need standardization across MRD platforms. Number two, prospective trials linking MRD to specific therapeutic interventions. Number three, understand for how long and when we should be giving maintenance to patients. Definitely integrate MRD into transplant eligibility and risk models, and understand a little bit better MRD dynamics post-transplant in different AML subtypes. And many trials, ongoing trials, are shaping the future. In the interest of time, obviously can't include them all, but some of the key studies that I want to discuss very briefly. The MEASURE study by the NMDP, looking to optimize post-transplant relapse detection using a more refined molecular MRD assessments. The Amadeus trial is testing oral azacitidine maintenance. The INTERCEPT platform is randomizing MRD-positive patients to interventions versus surveillance. The MILO-MATCH, it's an MRD integrated into multi-platform trial designs. And a little bit of advertising here. It's our own trial at Sylvester. We're looking at a combination of Ben-ASAP plus DLI for high-risk AML after transplant. And the majority of these patients are patients with detectable MRD before or after transplant or very adverse genotypes. So our trial, this is a phase 1 dose-finding study targeting patients with very high-risk AML. And we define very high-risk AML as patients with pre-transplant MRD undergoing reduced intensity or non-ablative allogeneic transplant, post-transplant MRD at day 30, irrespective of conditioning intensity, and patients with very adverse genotypes, such as monosomal karyotype or TP53-17P mutated disease. All patients receive a year of treatment with venetoclax with 6 cycles of low-dose azacitidine, and every patient receives a first dose of DLI with additional doses 2 and 3 if there's persistent MRD. We have enrolled 4 patients to date, and I'll be happy to share some of these results in the next year or two once we have them. To summarize, MRD is an essential prognostic tool before and after transplant. It should inform risk-adapted strategies, but really should not delay transplant once remission is achieved. Conditioning intensity and post-transplant interventions can help mitigate MRD-associated risk, and our field is moving very rapidly towards fully MRD-driven therapeutic models. So I think the future is bright. There's still a lot of questions, but a lot of people are doing a lot of good, fine work to try to answer some of these questions. So for the last slide, I want to share how I approach the MRD in clinical practice. And I titled this last slide, MRD Mostly Rational Decisions, because in reality, and being fully transparent, there are a lot of open questions. And I think many of us are still trying to figure out how to use this information better while new data comes out. So this is my approach to MRD guided care. So number one, for most adverse risk patients, I recommend upfront transplant in CR if these patients are fit. For patients with high risk ELN, the relapse risk is high and MRD often remains detectable. So I really try to anticipate the need of post-transplant strategies, ideally in the context of a clinical trial. For favorable risk patients with persistent or recurrent MRD, it depends. If they become MRD negative after additional therapy and are borderline fit, I'm very comfortable with a watchful wait and close MRD monitoring if possible. And I think that's the one part that is challenging. If these patients go back to their referring doc, we need to make sure that we have a close communication and close MRD monitoring is done. Allotransplant is of course still an option, especially if they have a suitable donor and they don't clear their MRD. In intermediate risk AML, I typically recommend transplant in CR1 for suitable patients. But for MRD negative patients who are borderline fit, surveillance might be reasonable. For MRD positive patients, additional therapy can be considered on a case-by-case basis. When it comes to the question of eradicating MRD before transplant, I do consider it, but I wouldn't delay transplant just to achieve MRD negativity. We all know that outcomes are better if you clear it, but that's not always possible, especially for high-risk patients. And losing the window for transplantation is something that has happened to many of us. So great if it happens, but we don't sit and wait for it if the transplant timing is right. Conditioning intensity based on MRD, and to that I'll say conditioning intensity does make a difference, definitely. So for MRD positive patients who are fit, I really try to ablate if possible. For patients who are not fit, I consider intensified RIG. If the patient is able to tolerate, I try to incorporate melphalan, or we try to incorporate novel treatments, ideally on the context of a trial. And finally, in my day-to-day practice, I'd use NGS when available and try to interpret the results in context. The pre-measure study supports its utility, but I think it's important to acknowledge the applicability, timing, and standardization still has a long way to go. This is my contact information. If anyone is interested in exchanging ideas or asking questions after this talk. And I want to acknowledge the work of my colleagues at the University of Miami, as well as the team behind the pre-measure and the measure trials at the NMDP. And I'm also grateful for the institutional support of our AML IIT. And of course, I want to thank the Saudi Society of Transplantation and Cell Therapy for this kind invitation. And of course, all of you for joining me today. And I'll be happy to take any questions.
So we can have a question while Dr. Jimenez is around. So if you have any question, please. Any question? So if no question, I would like to ask Dr. Jimenez. MRD using NJS at this stage of decision. What is, I can see in the last paragraph in the table that you are using NJS to decide whether to go for transplant or not to go, or to go for further chemotherapy. So can you explain a little bit about this part?
So we do use MRD. So like when we use NGS, I think it's important to recognize that we have different platforms, right? And not every platform is available to every center or every provider. And unfortunately, we're also bound a little bit by questions of insurance and coverage. The regular commercial NGS that we use, NeoGenomics panel or Foundation panel, they typically have lower sensitivity, but I think they're very useful to help you assess what's the landscape before we move into transplant and which mutations you can track. If you have the ability to use error-corrected NGS, which is much more sensitive, that's one I prefer. I think it's prognostically important and it's potentially actionable if you have a targetable mutation and you can wait. Say, for example, you have a patient that has detectable FLT3 ITD or detectable IDH1, and they're receiving lower intensity chemotherapy, and you don't have a donor secured. I think it's very useful so you can continue treatment with the aims of eradicate MRD as much as possible. But if a suitable donor has been identified, the patient is in remission, and good disease controls has been achieved, I don't necessarily push for more chemotherapy and delay transplant to achieve that MRD.
Yes, please.
Yes, thank you very much. Great review, very useful for us. How do you time the MRD analysis for favorable risk patients? Is it after induction and end of therapy, or you follow after that with other MRDs?
We do it both. So, and it really depends whether or not you go into transplant or not. So before transplant, we do at the end of induction, and I think that's for favorable patients that get your standard 7-3, 1+5 or similar regimen. And then we follow after each consolidation. Unless the patient has a young matched sibling donor, and this really depends on center practice, we don't anticipate that we move to transplant immediately. So we continue to follow after each consolidation. If we decide that that patient needs to go to transplant because there's persistent MRD, or they have some other high-risk factors, extramedullary disease or concurrent mutations, then I monitor MRD the same way I do it with most patients after transplant, which is we do it at 100 days. We check again every 3 months for the first year, and then every 6 months for the second year. If a patient, we make a decision not to proceed with transplant because they have achieved MRD negativity, or even they have MRD positivity with good risk, but we don't have a suitable donor, or the patients are not fit for transplant, then I think it's very key for us. That patient typically goes back to their hematologist. And I think one key factor is we say, well, make sure that that patient goes into close surveillance. We just really need to be faithful to that. And because our window to intervene is much more, or opportunities to intervene are much more efficient if we are able to capture MRD right on time. So for that patient that does not go to transplant, and if we have a very reliable marker like NPM1 or core binding factor, or then we can follow those patients very closely. I would say every 1-2 months for that first year if we don't go to transplant.
One last question. Just need your experience with venetoclax in patient, in all the elderly patient who has MDS AML or MDS with excess blast. what is your experience with venetoclax, especially with myelotoxicity?
With myelotoxicity, so yeah, venetoclax has really, it really changes, it has really changed the way, venetoclax and many of the targeted therapies, it really has changed the way we think about MRD, because now we can offer, especially for, when we think of this MRD and the value of MRD, I think one important population is older and frail patients, that we are going to be limited in the conditioning that we can give. And now that these patients receive venetoclax for induction, we're seeing a couple of things. Number one, you achieve, it's possible to achieve deep remissions before transplant, and I think that will be the one population in which I will say, I wouldn't wait for achieving MRD clearance before proceeding to transplant, but you can afford, while you prep your patient for transplant and you identify a suitable donor, to get a few cycles in, and MRD is achievable on many patients to receive venetoclax. In the post-transplant setting, one question that we get all the time is, would you consider, especially for a patient that achieved disease response, or for a patient that had a very high-risk genotype, a patient with TP53 or a patient with other high-risk mutations, would you consider a maintenance strategy? And the reality is, we don't have enough data to recommend that now. There are ongoing trials. There's the Viality trial with AbbVie. We have our own IIT. I think it's important to remember that as you mentioned, venetoclax is very myelosuppressive, and we have to monitor dose adjustment, and particularly after transplant, the myelosuppression risk is real. So the way we approach it after transplant, we dose reduce, and we do it ideally in the context of a trial. If the patient develops resurgence of MRD, then it makes sense we are permissive and are a little bit more aggressive with our venetoclax dosing until we achieve MRD negativity, and we can combine that with DLI in the appropriate patient. But again, I think, to be fair, I don't think they're standard. I think the advantage of venetoclax and other targeted therapies, they allows us to achieve deeper levels of remission, which is particularly important for poor risk patients. If you have a patient with TP53 that's older and you cannot ablate, and you cannot really get into even a decent CR with some good disease control, transplant is unlikely to help. So really helps a lot before transplant, and in select patients can be used after transplant, understanding the risk of myelosuppression, and ideally this should be done in the context of a clinical trial.
Thank you very much, Dr. Jimenez, and we're going to have to move on and shift gears now to Dr. Leslie Lehman. Dr. Lehman had attended Harvard College and received her MD from Duke University. She completed her pediatric residency and pediatric hematology oncology fellowship at Dana-Farber, and currently holds a position as an associate professor in the division of stem cell transplant at Dana-Farber. She also has a special interest in improving global healthcare and enabling, had been collaborating with other countries like and cities, Baghdad, Mexico, Rwanda, Egypt, to essentially build their pediatric stem cell experience and enable delivery of cellular and gene therapy. We come from the East Coast, and this is an area that's highly prevalent in hemoglobinopathies, and I think this is the exact right topic to talk about. Gene therapy for sickle cell anemia and thalassemia. To you, Dr. Lehman. Thank you.
Thank you for having me. I cannot seem to get my slides back to the first one. Let's see. We're sort of in the middle. There we go. Is that good for you? So I see a different screen up than you see. Can you hear me? Can you hear me?
Yes, we can hear you. With the
Okay.
slides.
I just can't get the, okay, so you can hear me, so that's good. Now let's deal with the slides. I tried to load them before, but it wasn't really possible. What do you see? Oh boy. Let's see.
We can hear you. I believe they're working on the slide. Yeah.
All right. Well, thank you very much for having me here. That's perfect. While we're talking, I wish I could be there in person. I've had many trips to the kingdom and have enjoyed them all, including a relatively recent vacation to Al Ula, which is unbelievably beautiful. So, as you said in your very kind introduction, this is a really important topic, and there is a ton of information, but not a lot of answers. And I want to talk about the information we have, the answers we need, and some of the barriers to actually getting those answers. So we're going to talk about gene therapy for the hemoglobinopathies, which really means sickle cell disease and transfusion-dependent thalassemia.
Can you hear me?
If it's
Not
possible
really.
to share your full screen. Yeah, if it's possible to, okay, we can see the presentation now.
Okay.
Thank you.
Great.
There we go. There we go. I think we're okay now. All right, great. So, it's interesting in the later stages of my career to really step back and try to see the patterns and how new technologies have evolved. And so gene therapy started, if any of you are old enough to remember, for very, very rare diseases that were immunodeficiency diseases, common gamma skid, basically. And that was in the 90s. Was set back because of problems with leukemogenesis, and then started evolving again, and really is available for a lot of incredibly rare diseases, adrenal leukodystrophy, Duchenne's muscular dystrophy, and all of those are important, but they aren't really global diseases. And when gene therapy hit the stage for hemoglobinopathies, it really is the first time that I think it has addressed problems that are of global significance. And transfusion-dependent thalassemia, which is how they talk about the indication for gene therapy, so I'll call it TDT, and sickle cell disease are major disorders, and about 6 million people are affected globally, with about 500,000 new births annually. So this is a new playing field for both for the field and for the people that are working on the problem. Very relevantly, as people said, these diseases tend to be concentrated in the African and Middle Eastern area of the world because of the genetics with the global population. Now, obviously, they're worldwide diseases, but it is an amazingly prevalent problem, both thalassemia and sickle cell disease in the Middle East. And I think people that don't come here that much, think of it more as a Mediterranean, a Greek problem or a sub-Saharan African problem, but it really has concentration in the Middle East and India, as you can see as well. So what were the previous therapeutic options for these major hemoglobinopathies? So basically there were two. There was supportive care, and that has evolved over the years. For thalassemia, it means monthly transfusions and management of the iron burden. And for sickle cell disease, it meant good supportive care in the old days, then the advent of hydroxyurea, and a bunch of other supportive care strategies, many of which have not delivered on their early promise. But from really the 70s, it became obvious the allogeneic stem cell transplant, where you got rid of the marrow of the patient and replaced it with the marrow of a donor, could offer curative therapy for these diseases. And unlike, I'm trying to think of a good example, unlike Fanconi anemia, these diseases are really limited to the bone marrow. And so if you can replace the bone marrow completely, you really can offer curative therapy. So, what are some of the risks and benefits of doing the different approaches that we had to date? So, for supportive care, it was lifelong therapy. You needed regular medical follow-up, and so many diseases, including, as the previous speaker was saying, even AML that you wouldn't think, really end up being disproportionately affected by access and equity. And so, if you lived in Boston and got a safe blood supply from our hospital, getting monthly and had access to chelators, monthly transfusions weren't so bad. If you lived in Africa and or India or Egypt, where there's hepatitis C in the blood supply, that became a different story. So you needed to have the transfusions, you needed to have regular medical follow-up. For sickle cell disease, you needed daily medication with hydroxyurea. For thalassemia, after a few years, daily chelation. There was geographic restriction of where you could live. And so I've had people choose to go to transplant because they wanted to be able to travel the world. And even though monthly transfusions weren't so bad for thalassemia, they wanted to work overseas and, Habitat for Humanity, and that wasn't possible. And then there's a progressive accumulation of toxicity. And I think that's a problem in general for pediatrics. And this isn't a pediatric only conference, but many of the ones I go to are. And so not so bad for us, but then we pass on to our adult colleagues, somebody who has a lot of both medical and psychological toxicity. And then there's the ongoing risk of mortality. People die from hemolytic transfusion reactions. People die from stroke with sickle cell disease. People die from pulmonary hypertension, and you don't know when that's going to happen. And these definitely can't offer a cure. And in the best case scenario, these can be said to be transformative. So hopefully many of you have had a subset of your population with sickle cell disease who have very, very few complications on daily hydroxyurea, and they're compliant. They take, penicillin, or they get seen with a fever and don't have a lot of the other symptoms. Allogeneic transplant requires a donor, and that is ideally a matched sibling donor, but the field is growing to other alternative donors, both unrelated and half-matched or haplo. Maybe most importantly, you need to have a center with expertise in transplant for benign hematologic disorders. And transplanting for leukemia is very different than transplanting for sickle cell disease or thalassemia. Medically, it's different, but also psychologically, because with leukemia, if you don't get a transplant, you are very likely to die of leukemia. And with sickle cell disease or thalassemia, you have the possibility of living, you absolutely will live for months and probably years and maybe even decades. You need to give high doses of chemotherapy to ablate the marrow, and there's a risk of transplant-related mortality. That risk in the matched sibling donor setting ranges from 5%. And so what I tell parents is even the best transplant center and the best patient going into the transplant room in an allogeneic transplant confers a 5% risk of mortality. And then with an older or more frail patient, it can be up to 20%. You need immunosuppression medications for 6 to 9 months. There's a risk of graft failure that the graft won't take, and a risk of the graft attacking you with GVHD. And then there's the long-term sequelae. But the only thing allogeneic offers you, and it still is the only thing that can offer that, is the possibility of a cure, so that you no longer have sickle cell disease or thalassemia. So that was what we had to offer about 10 years ago. And then gene therapy came on the scene. And it was initially, and I'll do this through the talk, it was initially called it was initially sort of spoken as a cure. But the companies have walked that back and really said that now it can be called a transformative approach, not a curative approach. And hopefully it will be curative in some people, and hopefully the field will get better, and it may be always curative, but right now it would be transformative. And what is gene therapy? Well, it is genetic modification of cells. And so because of that, it's under the shield of BMT, and this can only be performed in America and in Europe by BMT centers, because you're actually modifying cells. And basically, you take the patient's cells, and we'll talk more about the steps in a second. You somehow correct them. You somehow get the corrected product into the cells, into the nucleus, into the DNA, and then you have it integrates into the cellular DNA, and then is both there in the cells and there in the progeny of those cells. And so it becomes part of the genome. The traditional gene therapy that's been around now for 20 or 30 years has used viral vectors. And and one could talk about the actual process of gene therapy for days. So I'm going to skim over this and take questions if people want later. But you had to have a virus, and traditionally the viruses were adenovirus or retroviruses, HIV virus, for example, and that tagged on to what you wanted to add into the genome. Viruses are very good at getting through cell membranes, getting into the nucleus, being integrated into the DNA, and making a functional protein. A new therapy that's been around now for about 10 or 15 years and is still evolving is gene editing, where you don't need a viral vector. You still have to get the corrected thing into the cell, and that uses a process called electroporation, which pokes holes into the cells, and the long-term effects of that are still not really known. But you make a corrected gene and then get a functional protein that way. But you still have to get this into the nucleus of the cell. So the process, it sounded when I first, and I started practicing without gene therapy and have grown up, gene therapy and I have sort of grown up together. And it sounded great, right? You auto transplant. Everybody loves auto transplants instead of allo transplants. You collect the cells. We're very much pros at collecting cells. We collect cells for auto transplants for Hodgkin's disease and in pediatrics neuroblastoma and brain tumors. So easy. You collect the cells, you send them off, they get corrected. We don't really care about that. You get them back, they're frozen, you do an auto transplant, and everything is good. It turns out to be harder than that for a variety of reasons and a very, very long process. So the first step is collecting the cells from the bone marrow or the peripheral blood. The entire field is shifted to peripheral blood collection and collection by pheresis because you need a lot of cells, and those just aren't obtainable from the bone marrow. And to talk now a little bit about some of these problems, how do you collect cells? Well, you give chemotherapy and then stem cells go out into the periphery, but that's not good for thalassemia and sickle cell disease. So you traditionally give GCSF, but sickle cell patients cannot get GCSF. It's a black box warning because the increased white count that comes with that is associated with vaso-occlusion and stroke. And so people have been using the CXCL9 breaking agents, plerixafor, and now beginning to use a new, perhaps better one, motixafortide. But it's not as easy to get the cells as you would think because of the agents you can use, and also the patients have had very revved up marrows that have been doing ineffective erythropoiesis for decades sometimes, and they're not very good mobilizers compared to a 2-year-old with neuroblastoma. Then you get the cells, and in the initial days when this was just a research product, then the cells went to your lab and you fixed the cells however you did it. Now, with the commercial products that I'm going to focus on most, and I should have said in the beginning, I have no conflicts to disclose. With the commercial products, you have to send these cells off by courier to the lab associated with the company. They fix them. They tell you that they have enough, that they meet the specifications, and then they send them back to you. And you have a frozen product of these modified stem cells. And then the easy part for us as transplanters is you reinfuse the cells. And from the beginning, people have felt that you needed to give some chemotherapy in order to make space for the corrected cells. In all honesty, there haven't been very many trials of not doing it that way, but the FDA labels and all of the research have been doing it that way. And so you give single agent busulfan, make space, infuse the cells, and the cells engraft. The acute toxicities are really quite manageable. So now I'm talking about gene therapy for sickle cell and thalassemia on either published research trials or the FDA-approved products. And so you get nausea, vomiting, anorexia, as you would expect. Some mucositis, not very bad. It's single-agent busulfan. Some need red cell and platelet transfusions while you're doing it. There's hair loss, and there's been some noise about more permanent hair loss with single-agent busulfan in these patients. You can have fever. There's definitely possibility of veno-occlusive disease, especially in thalassemia with iron overload. There are no specific guidelines about how low the liver iron needs to be, but in pediatrics at least, it has not been a major problem, and you end up staying in the hospital 3 to 4 weeks. And so compared to allogeneic BMT, what are the advantages and disadvantages? So really, it's mostly advantages. So there's less chemotherapy. For gene therapy, it's busulfan alone. For allogeneic BMT, it's busulfan and something, cyclophosphamide, fludarabine. People have tried reduced intensity conditioning in alternative donors, but there's problems with mixed chimerism, but you definitely get more than busulfan alone. You don't require any immunosuppression afterwards. There's no risk of graft rejection. There's no risk of graft versus host disease. You don't need a donor. And we are beginning to learn about the long-term toxicities, but theoretically, they would be be fewer than there would be with myeloablative conditioning for allogeneic transplant, or at least we understand what the toxicities are. So where are we today? So today in the USA, we have 4 FDA-approved products for the hemoglobinopathies, and they are made by 2 companies, Bluebird and Vertex, and there are 2 for thalassemia and 2 for sickle cell disease, and presumably there will be more coming down the pike. So for transfusion-dependent thalassemia, there's Integlo, and that was the dates that are there are the dates that they became FDA-approved in America. And so that was approved in August of 2022. And for the thalassemia products, the indication is having transfusion-dependent thalassemia. So they don't care what kind of thalassemia you have, what hemoglobin you have, hemoglobin, sickle, beta zero thal, whatever. If you need transfusions, you're approved. And you have to be, and I could not get this slide to change, you have to be greater than or equal to 4 for Zynteglo, not 12, and you have to be greater than or equal to 12 with all of the other gene therapy products. The other product, and we'll talk about some of the differences, the other product is Casgevy, made by Vertex, and that was approved in January of 2024. And again, same thing, you have to have transfusions, and you have to be greater than or equal to 12 for Casgevy. For sickle cell disease, Bluebird has a product that goes with Zynteglo. It has a different name. It's called Lyfgenia, but they're identical products. So there's, four indications, but only 2 products by 2 companies. And for that was approved in 12 of 2023. Casgevy the same month was approved, and for those you have to be greater than or equal to 12, and you need to have a vaso-occlusive crises more than 2 over 2 years. So it's only about pain crises to be eligible. So how are these products different? Again, Lyfgenia and Zynteglo are by Bluebird Bio. Vertex makes the Casgevy products. So Bluebird adds a modified beta globin gene that is better at carrying oxygen and better at carrying hemoglobin. And it is a traditional gene therapy product in a way, in that the gene is inserted via a lentiviral vector. It's the HIV-related vector, so people will test positive for HIV afterwards. It's inactivated. There's no HIV risk at all. And it corrects the alpha-beta globin gene imbalance. Vertex is newer in terms of technology, which is both good and bad. It means there's less experience, but it isn't using a viral vector. It uses CRISPR technique, and it uses the electroporation, which is sort of jiggling the cells around and making holes in them so that the corrected cells get in. And it edits the erythroid enhancer of BCL11A. And it doesn't edit, at this point, there's not the technology to actually edit the hemoglobin or to add hemoglobin for thalassemia, or to edit the hemoglobin for sickle cell disease. But what it does is keeps the switch from fetal hemoglobin to adult hemoglobin by knocking out BCL11A. And that research, as the shout out, was done in our hospital. It came from Stu Orkin years and years ago. And hopefully we'll end up, it's won a lot of prizes, maybe the Nobel Prize. So you can leave fetal hemoglobin turned on. And then you get pancellular elevation of fetal hemoglobin. And patients' fetal hemoglobins run in the 20 to 40% age, with some of the newer research trial-based editing, not published data yet, presented at ASH, et cetera. They can get up to 40 and 50% of fetal hemoglobin. And so it doesn't use a viral vector, and it doesn't put in a different kind of hemoglobin, and there's much shorter follow-up for this technology. So what is the efficacy? Well, we don't know is the answer. And so now that they're FDA approved, and this is really the take-home message of my talk that I think is most relevant to me, at least you can decide, is that once you have FDA approval, you have no mandating reporting, and we really don't know. But the efficacy based on the trials leading to approval, which were based on very few small numbers of people, I will show you. So what were the endpoints of the trial? So the endpoints were transfusion independence in thalassemia and resolution of vaso-occlusive crises in sickle cell disease. So they did research trials. Those were the endpoints. They reported on who met the endpoints. The real world data, now that these are FDA approved and being used, is scarce, and reporting is not mandated. So for Zynteglo, there were 2 studies. You can see the number of patients. There were 22, 32, 36 patients. And they had, and some of them didn't have beta zero. But what they found is that 100% of patients got transfusion independence going forward, and the median duration of that was not reached, and the time reporting was 12 to 39 months. Okay, so from between 80s. So if you in study 1, it was 91%. In study 2, it was 86%. But if you really looked at the patients who had a beta zero thal, it came close to 100%. And what about the Casgevy product? So the New England Journal published in 2024 an interim analysis, and 91% of patients became transfusion independent. 32 patients had sufficient follow-up. This was a multi-center study, 13 sites over 5 years, and there were 3 failures in there. 2 patients, which is concerning, were transfusion independent for months and then required transfusions again, and 1 patient decreased the transfusion needs by 80%, but still had transfusion needs. So, that is for thalassemia. So what I would say in summary of thalassemia is that somewhere, and what I tell patients is it looks like somewhere over 85% of patients will become transfusion dependent for a long period of time. But we don't know if it will be forever, for sure. And what really worries me, and I tell patients, is, and there's no good data at all about who will not become transfusion independent, and it is a bit related to vector copy number. So when you get the product, you can have some idea, but then there's people who got good products who also didn't become transfusion independent. For sickle cell disease, as I said, the primary outcome was the absence of severe vaso-occlusive crises for at least a year during a 24-month period follow-up. For the Vertex, 93% met the primary outcome, and for Lyfgenia, 88% met the primary outcome. So I would say the same thing for sickle cell. Over 85% of patients become pain-free of severe VOC as the trial was set up, and those are the endpoints. What are the long-term possible effects? Well, there's 2. There's busulfan related. So as those of you who are transplanters will know, there's really scarce data on busulfan alone as a conditioning regimen. We never used it before gene therapy. You could be infertile. We don't know. We offer fertility preservation to everyone. There could be busulfan-related lung disease, alopecia I talked about, and secondary malignancies from busulfan. And then gene therapy-related, we worry about insertional oncogenesis when you use a viral vector that it inserts into a mutagenic site, and then secondary myeloid malignancies from any of the gene therapy products. And insertional I'm just worried about time because we're also a little late. Insertional oncogenesis is when the viral vector inserts into a site you don't want it to, and then it causes leukemia, and you can see the viral vector in the leukemic cells, and that's how you know it's insertional oncogenesis. There was some seen in the sickle cell trial. There was an unexpected safety event in the Lentigo and sickle cell trial from Bluebird, and it was initially put on hold. And at the end of a very long story in these Bluebird patients that had leukemia, it was not insertional oncogenesis. It ended up the leukemia cells did not have the viral vector, and it was thought to be related to the propensity for clonal hematogenesis, hematopoiesis that is seen in sickle cell patients. Already they're known over the long term to have more risk for AML, and that when you take corrected cells, a small number of them that already had some clonal hematopoiesis, put them into a patient, expect them to expand, that you can see leukemia. We thought this may stop the trials, but as they increase the vector copy number, there have not been these results reported, and whether it's just kicked the can down the road or whether they have managed to get rid of this remains to be seen. And then the final thing I can answer questions about but don't want to dwell on is the cost. For the FDA-approved products, they're between $2 and $3 million for the product, and that does not include the cost of collection and transplantation. So what is the current state in the US? If you have hemoglobinopathies, you can continue best supportive care. You can undergo allogeneic stem cell transplant for cure. You can have a matched sibling transplant, which is standard. We have a good idea of the risks and benefits. The cure rate is over 90% for children and young adults. You could look for a trial, or some centers offer off-trial alternative donor transplants. Unrelated donor haplotransplants have had a lot of steam behind them at Hopkins with some early promising results. Or you could enroll in a gene therapy trial, and there's many of those trials going on nationwide, or you could receive one of the 2 FDA-approved products. So how do we advise patients? We don't know. There's no data. And for me, it was really my own transformative moment when a patient was asking me, what should I do? How should I wait? Should I go to allogeneic transplant? Should I go to gene therapy? Which gene therapy? And there was no data. So and I told them, I usually have a feeling and can advise you, but in this circumstance, we really don't know. And I always meet with patients with my colleague, who's a hematologist, Erica Ezrick, who's on the research trial from our institute with me. And we say it ends up being very patient dependent. It depends if you have a matched sibling donor. Most people, though it's not written down, and some insurance companies are following it, recommend matched sibling donor transplant if you have one over gene therapy, especially if you're young, under 16, under 30, it changes. What is your age? Because the morbidity of transplant will change with that. What are your comorbidities? One of our gene therapy patients was morbidly obese, had sleep apnea, had sickle cell disease. His risk for allogeneic transplant would have been huge. He barely was sick in the auto transplant of gene therapy. And then patient values. Do they want something tried and true, like matched sibling donor transplant? Do they want no risk of transplant-related complications? Then they should do supportive care and hope that better supportive care comes along. Do they want to be on the cutting edge? Do they like research trials? Do they feel better with FDA-approved therapies? And then cost. In America, so far, insurance companies are mostly supporting the cost of these products, but that will not be true worldwide. It may not stay true in America. And then what areas do we need for investigation with these products? The eligibility. So the eligibility is way too broad, and it says nothing about the level of iron in the liver, much less can you have had a prior stroke. So you can have had a prior stroke, but the number of patients who received the product on research trials with a prior stroke are under 10, and those patients did not get strokes later, but the follow-up is very small. And can you have had a prior allogeneic stem cell transplant? I get asked this routinely. The package insert doesn't say you can't, but is it really okay to go in with some donor chimerism, no donor chimerism, do an auto transplant, you're getting busulfan twice, all of those issues. For conditioning, some people think you should get more to decrease the risk of clonal hematopoiesis afterwards, that leaving some damaged cells behind is bad. The holy grail is obviously getting less and doing targeted therapy, targeted conditioning against stem cells where you would not get any chemotherapy. Being investigated, not ready for clinical trial yet. We need to know what happens when you get only busulfan. There's early data that you preserve your vaccine responses, maybe preserve your fertility. Probably depends on how much your fertility had been impaired by your sickle cell disease and thalassemia iron deposition up to then. That needs to be looked at. And then we really need to look at other endpoints besides transfusion independence and resolution of pain, bone health, and pulmonary hypertension and stroke, obviously, which are the scariest morbidities for sickle cell disease. So what people are doing is making real-world consortia where we get together, we say that we'll report our data. The advantages is that it's real, maybe. The disadvantages are great. It's not real. It's biased. Who decides to report? You have to come from an institution that will pay for you to report. There's no funding available for these as yet. The data is incomplete, and you don't have to participate. And in a research trial, if you don't report your data, you lose your NIH funding. And here, there's not much of a carrot and definitely no stick. So to conclude, I think the vision for the future would be to continue to build gene therapy so that every region and every country has a center of excellence that can provide affordable and safe gene therapy for these diseases, and that the long-term follow-up is supported so that both efficacy and toxicity can be captured. And I think that's doable. There are already beginning gene therapy programs in Saudi, in the Emirates where I work. This will happen for sure. Bullet point A, I worry more about bullet point B, that there will be the infrastructure and the financial support to get the long-term effects from it. And today, if you have a hemoglobinopathy, you have organ toxicity, transfusions, pain, hospitalizations, psychological burden, and still a shortened lifespan, even in a resource-rich country. And I hope that tomorrow there will be a safe, accessible, one-time procedure that will provide curative therapy, not just transformative therapy. And this is a little boy that I gave a sibling, the elder of the boys, I gave a sibling transplant to, 15 years ago, and he's perfect. And so we have to make sure that gene therapy can offer something better and safer than that. And I'll end there. Thank you.
Thank you very much, Dr. Lehman. I think you're with us online, right, for a couple of questions. Is that right? Yeah.
Yes, that is true.
Yeah, okay. Dr. Wael?
Thank you, Dr. Lehman, for the very nice, comprehensive talk about the gene therapy and advancement of gene therapy. My question, I know maybe require a 2 hours debate. It's about the, you just mentioned it, that expansion of the eligibility of gene therapy. We know that the trial that you mentioned that recurrent VOCs is the most of the patient selection, but not including other organ dysfunction such as hepatopathies, recurrent acute chest syndromes, or even strokes. So can you comment on expansion of the eligibility? I know it's maybe it will take a long time, but in a brief, thank you.
Well, I'll give you a short version. So the VOCs for the FDA approved products, okay, so for the research trials, you have to document the VOCs. Some of them say you have to be in the emergency room or in the hospital. For the FDA approved products, they're self-reported. And what I have found, for better or for worse, is that anyone who has acute CHAS or the other sickle cell complications, when you ask them, they really do have enough pain crises to make eligibility. So the eligibility is really not a hindrance for the FDA-approved products. Whether it's whether it's going to fix their problem or not is unknown, but they can get the FDA-approved products. And I think Saudi is beginning Casgevy, right? I think gene therapy is starting in the kingdom.
We are setting
now,
the infrastructure, yeah, true. Yeah.
And so if you look at the package insert and talk to the companies, I bet you anyone with sickle cell disease over 8 to 10, right? You have to be 12, over 12 to get the product will meet the eligibility requirements. If you ask them, if you say, have you had pain, 3 or 4 times in the last year, they will meet it.
Thank you. Any other question? No? Okay, thank you very much, Dr.
All right.
Lehman.
Thank you.
Thanks.
And it will be in person.
I didn't hear that. Okay, thank you very much. We're moving on to the next.
Our next speaker is Dr. Lori Muffley. She is an associate professor in the Division of Blood and Marrow Transplantation Cellular Therapy. She's an expert in cellular therapy for adults with acute leukemia. She leads several national and institutional clinical trials aimed at improving outcome of bone marrow transplantation and CAR T-cell therapies for adults with acute lymphoblastic leukemia and acute myeloid leukemia. She also conducted population science research to improve access to care and outcome among these patient population. She serves on board of directors for the American Society of Transplantation and Cellular Therapy, and the NMDB, and is a member of editorial board of Blood Advances and Hematologist. Her work is funded by the Leukemia and Lymphoma Society, the NIH, the California Institute of Regenerative Medicine, and various industry partners. She is going to speak about approach to cellular therapy in relapsed refractory B-ALL in adult.
Hello, my name is Lori Muffley. I am an associate professor of medicine at Stanford University. Thank you very much to the organizers for inviting me to give this talk. The title of my talk today will be Approaches to Cellular Therapy in Relapsed Refractory B-cell ALL in Adults. Here are my disclosures. So I thought it may be best to frame this discussion in the context of a case. So this will be a case that is a takeoff of a patient in my clinic. This is a 43-year-old male with Philadelphia chromosome-like negative B-cell ALL with a normal karyotype and no adverse molecular features. The patient received induction therapy with rituximab plus hyper-CVAD. He achieved a first complete remission with MRD detectable by NGS MRD at 10 to the minus 4. The NGS MRD that we most commonly use in the United States is the clonoSEQ assay. Following cycle 1, the MRD persisted through cycle 4 of R hyper CVAD, now at a level of 10 to the minus 5. He then went on to receive 2 cycles of blinatumomab, and the result following blinatumomab was that his NGS MRD was down to 1 residual cell with his clonal IGH sequence per million examined in the bone marrow. At that point, he underwent a myeloablative matched unrelated donor allo transplant. He engrafted, had no graft versus host disease, and was tapered off immunosuppression by 5 months post-transplant. At his 6-month post-transplant disease evaluation, he was noted to have 113 residual clonal cells per million, and by flow cytometry, 0.01% B-cell ALL that expressed CD19 and CD22. So the question is, what should we do next? So in the United States, at least, we have an array of options, including chemotherapy, inotuzumab, blinatumomab, brexacaptogene autoleucel, and obicaptogene autoleucel. And today, we're speaking about cellular therapies, and so we're going to be focused on brexucel and obe-cel. So here is a figure or a table of the 3 currently commercially approved CAR T-cell therapies targeting CD19 in acute lymphoblastic leukemia. This table displays the similarities and differences, and so I will walk through each of them. So brexacaptogene autoleucel has been approved for adults 18 and older with relapsed or refractory ALL since 2021. The other name for this product is Tecartus. Obicaptogene autoleucel was approved late 2024 for adults 18 and older with relapsed refractory ALL. And tisagenlecleucel, or Kymriah, has been approved for several years now for children and adults up to the age of 25 who are in second or greater relapse. Now, I think it's important to look at the characteristics of each of these CARs because they are not the same. We'll start at the bottom. So the co-stimulatory domain, which is very important for CAR T-cell function and behavior, differs between these 3 products. You can see brexacaptogene autoleucel has a CD28 co-stimulatory domain, while obe-cel and tisacel have 4-1BB co-stimulatory domains. The transmembrane domain and the hinge region also differ between the 3 products. And then importantly, the antigen binding domain differs. And so each of these 3 CARs binds to CD19, but FMC63, which is used most commonly in commercial CD19 CARs, is what is used in brexucel and tisacel, whereas obe-cel has a unique CAT fast-off binder. This is a proprietary binder that differs from FMC63, and we will review this in a few slides. So I'm going to start by going over the data that led to the approval of brexucel in relapsed refractory B-cell ALL in adults. This was the ZUMA-3 clinical trial. This trial included 71 enrolled patients, of whom 55 were infused. So a relatively small sample, but certainly a novel approach, which is what allowed for the approval. And you can see here, the green stars actually, since we're basing this in a case, the green stars represent what our clinic patient, the patient I'm presenting, have in common with the ZUMA-3 population. And so the median age of the trial of treated patients was 40. The majority of patients were male. The majority of patients were white. 71% had an ECOG performance status of 1. None of these patients, importantly, at time of enrollment had CNS involvement. They were all CNS 1. Majority of them had received 3 or more prior lines of therapy, including blinatumomab, 22% inotuzumab, 42% prior allo. And then when we looked at the bone marrow, blasts at baseline, you can see that the majority of patients had greater than 25% bone marrow blasts when they enrolled in this trial. The brexucel ZUMA-3 met its primary CR/CRi endpoint. as well as its secondary MRD endpoint. And so you can see here that the overall complete response or complete remission with incomplete hematologic recovery was 71%. The MRD clearance, 38 out of 39 CR/CRI patients were MRD negative by flow cytometry. And one of the important features was that patients who had a bone marrow blast percent of over 75% had a lower rate of complete response. And we've seen this in most CAR T-cell studies for ALL, where very high blast burden in the bone marrow associates with inferior response. What about the toxicities? So this is important because this CAR T-cell is a CD28 co-stimulatory domain. And as you can see, the rates of CRS were 89%. That's any grade. And that's actually, very common in CAR T-cells to see fever. But the rates of neurologic events with this CAR were quite high, so 60% in the Ssbmt. Now, when we look at grade 3-4, we see a combined 24% grade 3-4 CRS rate and 24% grade 3-4 neurologic toxicity rate, including one death due to neurologic toxicity. What about the follow-up? So this was the original report in the Lancet. At the time of this report, there was a median of 16 months of follow-up. You can see here on the left, the relapse-free survival, and on the right, the overall survival. Of course, not surprisingly, in purple, the patients who achieved a CR or CRI had improved median relapse-free survival of 14 months. Patients who did not achieve a CR/CRI, on the right, their overall survival was quite poor, whereas patients who did achieve a CR/CRI, at this point in time, the median overall survival was not reached. Now, the investigators did do several follow-ups of this initial 55-patient cohort. This was one of the follow-ups published a couple of years ago. At this point, when this paper came out, there was 26.8 median follow-up, 26.8 months. And you can see the 18-month relapse-free survival was now 35%. So a third of patients remained in remission and alive. However, when you look at the data and you really parse it out and look at the patients who did not receive a transplant after CAR T-cell, you see that only 6 of 39 of these patients were in CR/CRI without additional transplant. So 6 patients at this time cut. And then they actually updated their data again. And now with even further follow-up, so 38 months of median follow-up, you can see, and I've highlighted here, 4 were in ongoing remission without receiving additional transplant or anti-cancer therapy. And 6 of the 10 patients who got a subsequent transplant were alive. So, I think these are important data because this CAR gets a lot of patients into deep remission. The 1-year relapse-free survival is impressive, but there does tend to be a fall-off, particularly among patients who don't get further therapy. And so now turning back to our case, just as a reminder, this is a 43-year-old male with Ph-negative ALL. He got R-hyper-CVAD, went into transplant with very low-level MRD by NGS of 1 residual clonal cell per million. He received a myeloablative unrelated donor transplant, did very well, but then had an MRD CD19 positive relapse at 6 months. He underwent a T-cell collection with the plan for Brexucell. He did not receive bridging therapy because his level of disease was quite low, 0.01%. He received Flu/Cy standard dosing followed by Brexucell. He experienced grade 1 CRS and grade 3 ICANS after Brexucell, both of which resolved with steroids and tocilizumab. His day 28 disease assessment showed that he was in a complete response. His NGS MRD was now negative, and he had no detectable B cells. So the question is, what should we do next? Are we done? Is he cured? Do we need to retransplant him? Do we need to do something else? Do we have data to suggest or hint at what we should do? So I'm going to turn now to real-world data. And so we have a consortium in the United States. At the time of this publication, there was approximately 30 centers, and we now have well over 40 centers participating. But This was the first publication to come from this consortium, termed the ROCA Consortium, and included 226 patients who were apheresed for standard of care Brexucel, not on clinical trials, across the United States, 211 infused. And this cohort that was published was 189 patients with at least 3 months of follow-up for patients who are alive. And so in this real-world data set, interestingly, you can see that among the patients who received Brexucel, half of them were either MRD, were in complete response, as you can see in the pink on the table on the left. Half of them were in complete response, some of whom were MRD positive, but you can also see there were 28 patients treated who were MRD negative. And this is really a practice pattern we've seen in real-world studies of CAR T cells with ALL, both in pediatrics and adult. The other interesting thing when you look on the right and you see the pink was, remember in the Ssbmt trial, patients had to have CNS1 disease, so no involvement. But in the real world, patients with CNS 2 or 3 are actually being apheresed and receiving Brexucel. So 18% had detectable CNS ALL at the time of apheresis. So now I'll just walk you through some of the response data that we saw in this population. So among the patients treated, the CR with follow-up, the CR/CRI rate in the real world was 90%. So very, very high response rates here. 79% were MRD negative by whatever assay was used. And among those patients with CNS 2 or 3 disease, interestingly, almost all of them converted to CNS1, and 12 of these patients converted from CNS 2/3 to CNS1 with CAR alone, meaning they did not receive intrathecal therapy as bridging. What about the toxicity in the real world? Well, it's pretty similar to what was seen in Ssbmt. So 84% of patients treated, despite the low disease burden at time of apheresis, experienced CRS, most of which was low-grade CRS. The bigger problem was ICANS. So you can see 56% of patients receiving Brexucel experienced ICANS, and the grade 3/4 rate of ICANS was 31%, which is a bit higher even than the clinical trial. And this was a bit surprising because, remember, a lot of these patients have very low burden disease, but these are what the data showed. Now, when we look at efficacy, this is with a median follow-up of just over a year. I'm sorry, the median progression-free survival was 9.5 months. At 12 months, 48% of patients were alive and in remission, and the median overall survival was not reached. So pretty similar to the Ssbmt 1-year estimates. Now, we did perform a multivariable analysis, this looking at variables associated with improved progression-free survival, and we did see some important variables. So one was that age at CAR T cell did not appear to adversely impact outcome. If anything, the older adults seemed to do a bit better. Prior transplant was associated with much improved progression-free survival. And this has been seen now in a few different studies, real-world studies across the world of Brexucel, that patients who received transplant prior to CAR had better outcomes. And we hypothesized that this may have to do with T cell fitness. It may have to do with a graft versus leukemia response. And then finally, and importantly, we looked at this several ways using time-varying analysis, as well as landmark analysis, which I'll show you in a moment. But we did see that the use of either transplant or tyrosine kinase inhibitor maintenance for Ph-positive ALL was associated with significantly improved progression-free survival. And you can see there were some variables that showed no association that are listed at the bottom with progression-free survival. In terms of what looked to associate with inferior outcomes, prior inotuzumab and the use of bridging therapy, which has been shown in other CAR studies, and these are probably both surrogates to adverse disease biology. So we did perform a landmark analysis. We also did, as I mentioned, time-varying covariate analysis, just to really try to understand the impact of transplant and TKI use. And what you can see here, when we landmarked at 2 months post-CAR and just included patients who were alive and in remission, The use of transplant was associated with a hazard ratio of 0.49, p-value 0.06 in terms of favorable PFS. TKI hazard ratio of 0.25, p-value of 0.02. And then we looked at also the association of NGS MRD response to Brexucel, and you can see patients who we were interested in this particular analysis in whether the use of consolidation with transplant or TKI was really dependent on whether or not patients were MRD positive or negative post-CAR. And we saw that the use of consolidation or maintenance was improved in patients who were MRD positive post-CAR, as shown in this figure, as well as in patients who achieved an MRD negative response to CAR, really strengthening the point that with this CAR at least, the use of consolidation or maintenance, be it transplant or TKI, seemed to associate with improved progression-free survival. So back to our case, he received Brexucel, he had grade 1 CRS, day 28, he was in a CR, NGS MRD negative, and no B cells were detected, and we left off by saying, what should we do next? So we did talk to him about a second transplant. He declined, as do really all of my patients. I would say it's very, very uncommon for my ALL patients to be open to second transplant. So we decided that we were going to track monthly clonoSEQ MRD and B-cell aplasia from his peripheral blood. And at 4 months post-CAR, his clonoSEQ remained negative, but we did detect the recovery of normal B cells. And so is this prognostic? What does this mean? And so what we found in our real-world consortium in the United States was that NGS MRD actually, at the time that our initial publication was put together, was only used in fewer than a third of patients. So it was very difficult. That practice pattern makes it a bit difficult to understand its true impact. And we also found that there's a lack of uniform approach to monitoring for B-cell recovery post-CAR in adult ALL. However, the pediatricians do this much more frequently and much more consistently. And there's a very nice paper by the pediatric group here in Blood Cancer Discovery, really looking at these two variables, NGS MRD and B-cell aplasia. And you can see that for children who receive CAR T cells for ALL, this combination of NGS MRD and not recovering B cells, so ongoing B cell aplasia, leads to really like a 75% plateau in EFS. And this is, you can see, several months post-CAR. However, having either B cell aplasia loss or MRD coming back is associated with worse EFS. And so at least in children, it does seem like loss of B cell aplasia is significantly important. I'm gonna just take a moment to talk, since we're talking about children in the pediatric group, about an analysis that was done comparing Brexucel to Kymriah or Tisacel amongst AYAs. So this is another US consortium study looking at patients between the ages of 18 and 25 who are eligible for either Brexucel or Tisacel in relapse. And so here you can see, and this was just published in Blood Advances, and here you can see one of the major findings of this study, which is looking at toxicity differences with Brexucel in blue and, with Tisacel in blue and Brexucel in red. You can see here the rates of overall CRS in AYAs was higher in Brexucel, although grade 3, 4 CRS did not differ. But really, and this is really not a huge surprise, but what differed tremendously was the rates of ICANS, both any ICANS and grade 3, 4 CRS ICANS, which were much higher in the AYAs receiving Brexucel. In terms of complete response and MRD negative complete response, there was really no substantial differences. And then in terms of survival probabilities, again, really statistically no significant differences between these two CARs. Interestingly, we did see a hint that perhaps Brexucel had a higher numerical 12-month PFS, but no statistical difference. So back to our case, our patient declined a second transplant. He did have B-cell recovery at 4 months post-CAR, but remained clonoSEQ NGS MRD negative. We did at that point, this was actually a real case, this was a couple years ago, we did decide to give him a DLI and start him on pump maintenance. And that was in part because he had not ever received pump maintenance because he had come to transplant. And, you know, perhaps this was luck, but it worked. This patient is now just about 2 years out from CAR. He's back to work full time. He's actually a surgeon. And he remains clonoSEQ MRD negative. So just going back to these CARs, remember this patient was treated a couple years ago. We just got obe-cel approval in the late fall in the United States. And so I'm going to spend the next couple of minutes talking about obe-cel, which was not available when this patient was treated. But I did mention that this has a unique binder called the CAT binder. And you can see here, this CAT binder is really a fast off binder. That's really the purpose of that is we know that when CARs are tonically active and signaling, we know that that increases the exhaustion rates. And in ALL, we believe to some extent that CAR persistence is important. And so the more exhausted the CARs are, the less likely they are to be persistent. And so in these preclinical studies, this particular binder was shown to have a high % of tumor killing and really to this fast off to really curb the exhaustion and improve the proliferation and killing of CAR. And so the trial that led to the approval of obe-cel in the US was called the FELIX trial. This was a phase 1b/2 pivotal trial. And there's a few interesting things about the way that this trial was designed. The first is that as you can see, this is a split dose infusion. So this is the only CAR that I'm aware of that is given in 2 separate doses. In the trial, the first dose was on day 1 and the second dose was on day 2. I'm sorry, not on day 2, on day 10. And you can see on the bottom that actually the dosing schema was based on disease burden. And so the disease burden had a cut point at 20%. So for patients who had less than 20% bone marrow blasts at lymphodepletion, the first dose of CAR was 100 times 10 to the 6, and the second dose at day 10 was 310. Whereas for patients with higher disease burden of greater than 20%, the first dose was 10, very small dose of CAR, 10 times 10 to the 6, and the second dose was 400. And you can see that there were 3 different cohorts treated. Cohort A was really what their pivotal cohort, which was patients with morphologic disease at screening. This was all adults over the age of 18 with relapsed refractory B-ALL. I'll go through this quickly. This is just their baseline characteristics, which looks pretty similar to most of the CAR trials in adult ALL. All treated patients, N equals 127, of whom most fell into the morphologic disease cohort. You can see 74% CR/CRI rate, the majority of whom were MRD negative. And in patients in those other categories, particularly cohort B, which was MRD only, all achieved MRD negativity. The event-free survival at 12 months with obe-cel was 50%. Again, very similar actually to the Brexucel ZUMA-3 data. But here, I think, is where you see some difference, again, with toxicity. So the overall CRS rate with obe-cel was 69%, but only 2% had grade 3/4. And the overall ICANS rate was 23%, but only 7% had grade 3/4. Now, these data were updated with long-term follow-up, and I'm gonna just kind of keep going through. So you can see now with 36 months follow-up, you can see a very nice plateau of curves here, both for EFS and for OS, suggesting that perhaps this CAR may lead to durable remission. The majority of these patients did not receive transplant after CAR. And so that's kind of exciting for the field, thinking that perhaps this CAR may be less toxic, but also lead to durability. And there's more novel therapies coming in ALL. We have bi and tri-specific targeting of CD19 2022, novel antigen targeting for B-ALL, CD7 CARs and T-ALL, and I'm just showing some data from a company, Wugen, who just launched their pivotal trial of CD7 CAR for T-ALL in the United States, which is exciting to think that we may have eventually an approved product for this population in need. And lastly, I will just mention some work that we're doing here at Stanford, combining CAR T cells with allo transplant. And so we use a graft called ORCA-T, which is a regulatory T cell-based allogeneic transplant graft. And we add in CAR T, in this case, CAR 1922 from the donor. And so this is a bit of a complicated trial, but the donor undergoes T cell apheresis. Then they go GCSF mobilization for transplant collection. The patient, on the other hand, undergoes conditioning. On day 0, they receive the CD34 HSPCs and the regulatory T cells per the ORCA-T graft. And then on day 2, they receive conventional T cells as well as CAR T cells from the donor. And one of the interesting things about this trial, we've now accrued 17 patients, is that the CARs, when obtained from the donor and given after myeloablative chemotherapy, do appear to be long-lasting. So we have 8 patients over 1 year, all with detectable CARs from the donor, which is quite interesting. So the last thing, how do I currently use CD19 CAR T cells that are commercially available in relapsed refractory adult ALL? So in adults who are transplant naive but are eligible for transplant, so if they haven't had a transplant and are getting a CAR, for patients who achieve NGS MRD CR, typically within 2 to 3 months, I am consolidating with transplant for most of these patients, although I think the obe-cel data is compelling that perhaps there will be a sizable population who can remain in deep remission without transplant. If patients had a prior transplant or are transplant ineligible and achieve a deep remission from CAR, I monitor their NGS MRD and B-cell recovery closely. If they turn NGS MRD positive, I confirm, track, and always intervene. If they remain negative for NGS MRD but have return of B cells, there's a whole array of things to consider. It's a very difficult decision if they're Philadelphia chromosome negative. If they're pH positive, I definitely start them on a TKI. So in conclusion, since entering the US market for adult B-ALL in 2021, we have learned that Brexucel performs similarly in the real world as in ZUMA-3. There is a high rate of high-grade ICANS. However, I will say I do think we've gotten better at managing this toxicity. Cure rates with Brexucel alone in the absence of consolidation are somewhat low, but not impossible. Obe-cel entered the US market in late 2024. This CAR targets CD19, but using a different binder, a different construct, and a different co-stimulatory domain. Low rates of high-grade CAR-mediated toxicity in their pivotal trial, and cure rates with obe-cel alone in the absence of consolidation do appear promising, but require more data and a larger sample to confirm. There's ongoing opportunities and challenges with CAR T cells in adult ALL. I think improving access and cost, certainly optimizing patient selection, and then understanding ideal sequencing and timing and clinical trials are very important to understanding this. And thank you to my team. Thank you to our consortium, which has been a lot of fun to work with. And again, thank you for inviting me to give this talk today.
Thank you very much. This segment was not live, so no questions for this bit. We're going to move on to the last presentation of the day by Dr. Heather Stefanski, who is a Vice President of Ssbmt and Clinical Services in the National Marrow Donor Program. She's a former Associate Professor in the University of Minnesota and currently is focusing on cord blood units in hematopoietic stem cell transplant and CAR T therapy, and overcoming HLA barriers in stem cell transplant using alternative donors. She's going to present to us about mismatched, unrelated donors with PTCY. To you, Dr. Stefanski.
Great. Thank you so much. Can everybody hear me? And can everybody see me?
Yes, we can hear you and we can see you.
Okay, great. Thank you so much for inviting me to speak today. I'm excited to talk about our experience. So these are the objectives. I want to describe the impact of post-transplant cyclophosphamide on donor selection, discuss our recent outcomes data in the United States using PT-Sci, discuss the rationale for focused on mismatched unrelated donor by the NMDP and CIBMTR, and review the current status of our prospective clinical trials and MMUD recipients. So this is looking at our CIBMTR summary slides. And for those that don't know, CIBMTR puts out summary slides every single year, and it's a great it's a great thing to have and a great reference. So you can go to cibmtr.org and go to summary slides and download them. I will say I download them very frequently. So this is just showing what are the trends in donor types over the years. So starting in 2000, going all the way to 2022. And you can see that over time, matched unrelated donors has increased. Matched related donors has decreased over time. And most likely this is related to the fact that we are transplanting much older patients where their sibling is potentially could be in their 70s. And so you may not want to use that as your donor source. Haplo had a very, increase over time here. And then just recently, we have seen a little bit of a decline. Mismatched unrelated donors had been relatively stagnant. And then now we have just started to see an increase. Umbilical cord blood really reached its peak in 2011, and we continue to see a decline. And then this is looking at other mismatched relatives. So I think one of the most important trials that has been done was the BMT CTN 1703 study that showed that PT-Sci had much better outcomes compared to TAC and methotrexate. So this was published in the New England Journal in 2023, and Dr. Shernan Holton presented this at ASH. And this is looking at the probability of GVHD relapse-free survival. PT-Sci is shown in black, and then the TAC methotrexate is shown in yellow. And you can see that there's a very significant difference where PT-Sci had 52.7% at 1 year and TAC methotrexate had 34.9%. So this really changed the paradigm of what we use for GVHD prophylaxis. And we can see this when we look at our CIBMTR summary slides over what is the preference in using different GVHD prophylaxis for different donor types. So here looking at haplo, not surprising, PT-Sci has mainly been done for haplo-identical transplants and was really pioneered at Hopkins, and that has not changed. When we look at matched-related donors here in this lower left-hand graph, you can see that CNI and methotrexate was predominantly used, but now we have seen an increase in the use of PT-Sci. When we look at mismatched unrelated donor transplants, PT-Sci has continued to increase. And then when we look at matched unrelated donor transplants, PT-Sci has also started to increase. And then this is looking at allogeneic types in different race and ethnic groups. So in non-Hispanic whites, matched unrelated donor is the most common. When we look at Hispanic or Latino, you can see it's predominantly haplo as well as match-related donor. When we're looking at non-Hispanic, Black, or African Americans, also haplo very frequently used, as well as match-related donor. And then looking at the Asian population, again, haplo, matched unrelated donor, as well as match-related donor. And then non-Hispanic others, you can see, again, matched-related donor, as well as haplo has been very frequent. So haplo has definitely played a role in being able to transplant the racial or ethnic diverse backgrounds. So one of the problems is that fully matched donors are not available for all patients in need of transplant. And this is shown here in this graph in blue. So to find a perfect match for Black or African Americans, Asian or Pacific Islanders, Hispanics, or Native Americans, you can see that the likelihood is much different than those for non-Hispanic whites. However, if we were able to expand and do these transplants safely, you can see if we were able to go to 7 of 8s or even 6 of 8s, that this would actually increase the chance of finding a donor. One of the problems with this is that prior to using PT-Psy, outcomes with mismatched unrelated donor in the presence of using CNI GVHD prophylaxis was significantly different. And so here's looking at 5-year survival. And so for 8 of 8s, there's a 50% overall survival for 8 of 8s. But this decreases significantly for 7 of 8s. So it goes down to 39% and then 28% for 6 of 8s. So if we are going to use CNI GVHD prophylaxis, we would not have excellent outcomes for patients that did not have an 8 of 8 donor. So what we thought of is that, you know, if PT-Psy can be used very safely in haploidentical transplants, why can it be used in mismatched unrelated donors? And so we did this 15 MMUD study. We did it in 80 patients with both standard reduced intensity and myeloablative conditioning. And then the donor was a mismatched unrelated donor that was 4 to 7 of 8. And here the graft was bone marrow. So we wanted to see if this was even feasible. And so here, this is showing the reduced intensity in the dashed line, the red dashed line, and then blue, the myeloablative. And you can see that there was an excellent overall survival at the 1-year outcome. So 76% survival after 1 year, 11% of acute GVHD grades 3 to 4 at 100 days, and then greater than 90% engraftment. There were 19 deaths, 7 relapse, and 4 of multi-organ failure. But what this showed also is that 48% of patients on this clinical trial were racially or ethnically diverse, which is unheard of for clinical trials. So this showed that mismatched unrelated donors can be used with PT-Psy as GVHD prophylaxis and have excellent outcomes. So then we wanted to look at differences using CIBMTR in our outcomes database. So we compared patients that had hematologic malignancies, so ALL, AML, or MDS, using PT-Psy GVHD prophylaxis, and it had to be their first allogeneic transplant, and then using PT-Psy. So the years here were 2017 to 2021. And there were 7 of 8s, there were 613 7 of 8s that had received PT-Psy during this time, and then there were 1,681 that were 8 of 8. And so the 7 of 8s are shown in blue, and then the 8 of 8s are shown in green. And we looked at overall survival as well as GVHD relapse-free survival. And what you can see here is that there's no difference in overall survival between these two groups. So 8 of 8s and 7 of 8s were exactly the same in the presence of PT-Psy. And what this means is that the number of potential matches for race or ethnic diverse groups really increases. So here, looking at African Americans, for 8 of 8s, they had 2 potential matches. But when you go to 7 of 8s, this increases to 74. For Asian or Pacific Islanders, it goes from 6 to 151, and then non-Hispanic whites, 29 to 1,226, and then Hispanics 5 to 147. So really, the effect of MMUD is very great in that now we can do transplants safely for these patients. So I'm going to briefly talk about the BMT CTN 1702 study, which was a new paradigm for donor selection. So this was the control alternate delete. So it was clinical transplant related long-term outcomes of alternative donor allogeneic transplant. And so we are going to focus on the 2 purple groups. And what this wanted to look at was assigning groups based on search prognosis and the likelihood of finding a match. So if there was no suitable HLA match family donor, then patients were put into groups based on their search prognosis score. So if a matched unrelated donor was very likely, so here they had 2 potential matched unrelated donors, greater than 90% likelihood of finding a matched unrelated donor, they would go down this matched unrelated donor path. That's what they would do. However, if it was very unlikely that they had a matched unrelated donor, so 0 potentials, less than 10% likelihood of finding a matched unrelated donor, they would pivot to an alternative donor. And this alternative donor could either be a haploidentical donor, a mismatched unrelated donor, or an umbilical cord blood. And that was declared at the start of this. And this could be declared for each patient. And so instead of waiting for the perfect matched unrelated donor to come onto the registry, they would actually pivot to their alternative donor and go down that path. And this was the primary comparison. And so this is showing the results. And a couple of things are key here. First is that it didn't matter what stem cell source a patient received, whether it was cord, mismatched unrelated donor, matched unrelated donor, or haplo. So meaning that it didn't matter if they were in the very likely or very unlikely group. When you looked at the cumulative incidence of patients achieving transplant over time, they all received transplant in the same amount of time. So a haplo wasn't faster than a cord. It wasn't faster than a mismatched unrelated donor or a matched unrelated donor. And this is because the reason that a patient didn't get to transplant wasn't related to donors. It was related to patient outcome or patient reasons. And this is shown in this pie chart over here. So, and most likely it was poor health related. So a patient had a new comorbid condition or had relapsed and they couldn't have gone on to transplant. 13% of the time it was related to a donor. So it wasn't mainly related to donor. And we hear a lot of the times that haplo or other types always get to transplant faster. And that's actually not the case. And that was shown in this study. Another interesting aspect was what was the transplant center's preference over time of what alternative donor they wanted. So shown in this darker blue is haplo. So at the beginning of the study in 2019, 63% of transplant centers preferred haplo. This went up to 65%. And then by the end of the trial, it went down to 57%. However, mismatched unrelated donors started at 21%, but then continually increased as time went on. And this is most likely related to the fact that that 15 MMUD study that I just showed you was published in JCO. Umbilical cord blood went down over time, and then the others. Another important and key result from this study is when they looked at the overall survival between the very likely and very unlikely groups. So the very likely went down that matched unrelated donor path. The very unlikely group went down that alternative donor path. And you can see in this graph here that the very likely is the solid line and the very unlikely is the dotted line. There's no difference in these curves. And so overall survival was exactly the same. So I think one of the key messages from this is that if you do not have a matched unrelated donor, that you should immediately pivot to an alternative donor so your patient can get the transplant they need when they need it. And so this is looking at a modern donor selection strategy. I will say we get a lot of questions about donor selection at NMDP. We are going to publish our new guidelines, which essentially is that, if you're using search prognosis, which you should be doing at HLA typing and figuring out, does your patient have a great matched unrelated donor or not? If they don't, and they don't have a suitable HLA match family donor, that's number one, then you should pivot to the alternative donor. And the things that you need to take into consideration are clinical trials. So if you have a clinical trial that's focused specifically on matched or mismatched unrelated donors or haplo, put them on that clinical trial. It's very key for us to understand. Also, what sort of GVHD prophylaxis are you using? HLA antibodies are also key. So if a patient has donor-specific antibodies to the graft, you do not want to use that graft. What is the donor availability and donor age? So currently, we've increased the donor age because it's shown that up to 30 actually have excellent outcomes. Other donor characteristics based on it, we still need to look at some other factors in this PT-Sci era. And some of the other questions we get are, which mismatch should you use? And we can't answer those questions yet. So now I'm going to focus on some of the clinical trials that we've been doing. So the ACCESS study. So we talked about 15 MMUD a while ago. So that was using bone marrow as the stem cell source. That is not practical to continue to get bone marrow from unrelated donors as much as we need it. And it's not as safe. And so we wanted to see if we could use peripheral blood stem cells as a stem cell source. So the ACCESS study has 3 strata. 2 of the strata are in adults. One's a reduced intensity regimen and the other is a myeloablative regimen. And then we also have a pediatric arm. The adult arms are closed. They closed a couple of years ago, whereas the pediatrics is still open, but planning on closing that this month. And so we initially had a design plan for 70 adults in each strata. However, the accrual had been so rapid, especially in our reduced intensity arm, that we expanded it to increase to 190. And here we wanted to analyze the impact of donors that were matched at less than 7 of 8. And so we had an initial statistical plan to analyze the first 70. So I'm going to focus on that as well as showing you some results from the myeloablative arm. So here, there were 13 centers that had participated in this portion of it. The median age in the reduced intensity arm is 65, 50% male, 50% female. This was started in the middle of the pandemic, so it opened in August of 2021. So many of the products were cryopreserved. Interestingly, this study also had more than 50% of patients that were of racial or ethnically diverse backgrounds. So truly showing that this was needed. And when you compare the BMT CTN 1703 study, which is that GVHD prophylaxis, 82% in that study were non-Hispanic whites. So that was not, the 8 of 8 was not, it's not reaching that ethnically diverse population. Looking at our donor characteristics, all donors on this study had to be under the age of 35. There could be no donor-specific antibodies. The median age of the donor was 25. Many of them were female, and then this is looking at the distribution. So 2/3 of the donors were 7 of 8, and then 1/3 was less than 7 of 8. And when we look at the primary and secondary endpoints, overall survival at 1 year post-transplant was 79%, which was excellent. GVHD relapse-free survival was 51%. Acute GVHD grades 2 to 4 was 43%. Grades 3 to 4 was 9%. Our severe chronic GVHD was very low at 9%. Primary graft failure 6%, NRM 13%, and then relapse of 21%. If you remember, I said that many of these products, most of them were actually cryopreserved. So we'll see if this still holds out as we're doing other studies, depending on if it's a fresh or frozen product. When we look at our myeloablative cohort, so there were 75 patients here. Number of centers were 18. The median age was lower, which isn't surprising because it's a myeloablative cohort. So it was 46. Most of them were male patients. And then the donor characteristics, same age. And again, about 2/3 were 7 of 8, and then 1/3 was less than 7 of 8. And again, we had a very diverse patient population that we were treating. Here, when we look at the overall survival, at 1 year, it was 84%. And GVHD relapse-free survival, 48%. Primary graft failure was very low at 1%, NRM 11%. Relapse was 23%. Acute GVHD grades 2 to 4 was 31%. 3 to 4 was 8%. And then chronic GVHD was 10%. So these had excellent survival. One of the issues with post-transplant cyclophosphamide is we tout it as it's a great medicine, but it's not without complications. And so one of the complications of using PT-Cy is the number of infections. And we see this when we're looking at our reduced intensity strata. So for grades 2 to moderate, there were 57 patients that had infections. Here's grades 3 severe, 27, or these are the number of infections, excuse me. Grade 4, life-threatening, 3, and then 2. And then these are the number of recipients that are affected. So 50% of patients are having an infection. And they still get infections even when it's day 100 to a year. So after the peri-transplant period. And so we need to figure out a way to make this better. And also PT-Psi has other complications with it. So it can create cardiac toxicities. It can also have hemorrhagic cystitis and renal toxicity. So it's not without its problems. And so we are now doing the optimized study. And here, the primary objective is to estimate infection-free survival and determine safety of combination reduced PT-Psi with MMF and tacrolimus as GVHD prophylaxis for patients with hematologic malignancies receiving MMUD. And we still have the myeloablative and reduced intensity arms. We do not have a pediatric arm on this trial. And we're looking at composite day 100 infection-free survival without grades 2 to 3. Here's some safety endpoints that we had, and then you can just look at it here. So we're using 25 mg per kilo per day of post-transplant cyclophosphamide. Oh, whoops, excuse me. Go back one. So here is the trial. We opened this, and we've had very rapid enrollment. We have 208 patients enrolled, 189 infused. 6 have already completed the study. So we've exceeded our enrollment by 30%. We've actually also expanded the reduced intensity arm again, and 50% of patients are racial or ethnic diverse background. So this is shown here. So all of these different colors are the different races that we're able to treat. So we're very excited about this study and proud of the fact that we're able to accommodate so many patients that would not have received their life-saving stem cell transplant. So our next trial that we're going to do is we are going to do Accelerate. So this is a novel way to do things. It is a platform trial. It's going to be randomized. And really the beauty about doing this is that because it's a platform protocol, that we will be able to add amendments in as potentially new treatments come. Instead of having transplant centers have to, basically start up a whole new trial, we'll be able to do the different amendments. So this here, we're going to be looking at PT-Psi as our control arm at 50 mg per kilo because we don't know the results of our optimized study. And then we're going to use abatacept, which is FDA approved for mismatched unrelated donor transplants, as well in one of the arms with PT-Psi. And then we're going to be using PT-Psi with ruxolitinib. And so this currently where we're at is this. I'm going to go here and then I'll go to the other one, is that this is FDA, it's DSMB approved as well as IRB approved. And we're hoping to enroll our first patient in June of this year. So, really what we wanted to do with MMUD is to expand access for patients that could not get a transplant. So with 15 MMUD, we showed that it was feasible, but that was bone marrow, not practical. So with access, we showed that it was practical. With Optimize, we're hoping to show that we can decrease the dose of PT-Psi and make it safer for patients without, making GVHD worse or relapse worse. And the other nice thing with Optimize is that if you're using reduced PT-Psi, potentially more patients then could be on the myeloablative arm because you're not worried about the effects of post-transplant cyclophosphamide. And then Accelerate, we hope to make this faster. So really, NMDP is fulfilling an unmet need at the transplant center based on their robust enrollment and expansion of cohorts, and over 50% of patients, are racial or ethnically diverse. And then this is just looking at the ethnically diverse transplants that NMDP has facilitated in the United States. And it's mainly driven by PBSC. So you can see it expands every single year. Marrow and umbilical cord blood are here. And, before, really umbilical cord blood was filling this niche of for racial or ethnically diverse patients, but now PBSC in this PT-Psi era has been able to do that. And so in conclusion, the outcomes for different donor types are relatively similar. We have been able to overcome this HLA barrier with PT-Psi. Patient and donor characteristics other than donor type are increasingly important in selection. The 1702 study showed that search prognosis is very critical, where you want to quickly assign your patient to a donor selection strategy and ensure that that patient can achieve transplant. And then the reasons that patients aren't getting to transplant is patient reasons and not donor reasons. And really donor types, you should be able to pivot to an alternative donor immediately. Patients should be enrolled in clinical trials wherever possible. And donor registries, like NMDP, play an active role in the process of donor selection, including the development of tools. So that is where I end, and I want to thank everyone. I want to thank all the patients, all of our funding, our NMDP and Ssbmt leadership, as well as the Access Protocol chairs. I know that Dr. Jimenez gave a talk earlier today, so we're grateful for his partnership. And really, I appreciate the fact that I was allowed to share our data today. Thank you very much.
Thank you very much, Dr. Stefanski, for concluding the day. Do we take questions at this point? Okay, maybe one question, if that's okay.
Yep.
Thank you, Dr. Stefanski, for this is very, very comprehensive and elegant talk. My question is, you mentioned about the mismatch, and there is an area of research regarding the type of the allele mismatch from the donors. It's really interesting to identify which allele that mismatch that POTS-Y cannot help at this situation. Do you have any comment on that? Thank you.
Yes, that is an excellent question, and it is one that we are constantly getting and we are looking into. We should be able to have some more information about this as we continue to get more mismatched unrelated donors, and we'll be able to put it into our models to be able to let you know, right? Like, are there certain things where you want, if your patient has MRD positivity, for example, is that a time where you might want to use a certain allele mismatch because you're going to have better outcomes? And so more to come on that. I wish that I could have a more definitive answer, but I'm hoping in the next year we'll have that answer.
If there's no other question, I think we'll just conclude. And thank you very much again, Dr. Stefanski. Thanks.
You're welcome. Thank you so much for the invitation. Thanks. It was a pleasure. Have a great day.
Okay, by that we conclude this prestigious event. Thank you so much for people who have flown from all over the world to the East Coast, and I come from East Coast and I'm born and raised here, so it's a pleasure having you here. I hope the weather suits you well, and I hope everyone has a safe flight home and a nice outing tonight, if feasible. Thank you very much, everyone. Thank you, Dr. Lasker, for this opportunity.